Good morning. On behalf of organizing committee and faculty of AIG, I welcome you all to this conference. This conference is designed to know about early gastric cancers, and majority of us are doing therapeutic procedures, especially in India, where we must learn from the stepwise method like to diagnose these cancers. We are still far behind the Western and also especially the Eastern world in as far as diagnosis is concerned. So we have planned this workshop in such a way that we will dedicate one day for diagnosis, second day for therapeutic, and third day for majority of the hands-on, especially the live animal models and also the ex vivo models and also the other models which will facilitate our training. I sincerely thank our international faculty, Dr. Rajvinder Singh coming from Australia and Dr. Noria Vedo from Japan. Tomorrow Saichiro will also join us, and also all the national senior faculty, Amol, Naresh, Pankaj, and all the other people who have given their consent and spared some time to join us. So we'll start with our chairman's address. Unfortunately, he has to travel outside, but he is always with us. So we'll listen to him and then we'll proceed.
Good morning, friends, and welcome to this AIG ANBIG workshop on detecting and treating early gastrointestinal cancers. Unfortunately, due to an earlier commitment in Japan, I won't be physically here, but all my wishes are with you. I think on behalf of all the faculty of the AIG Hospitals, I'd like to welcome you to this very unique conference. For long, it's been felt that we in our country have been missing early gastric cancers predominantly and other cancers in the gastrointestinal tract. There are two reasons for this. One is because of probably teaching and knowledge in this area, ability to recognize early cancers, and secondly because of how we prepare our patients for the examination. But in recent years, especially with a lot of inputs coming from our Japanese colleagues, we have been able to change this a little bit. Professor Noria Vedo has been visiting us several times, and he has taught us not only how to identify this very early lesion along with Kenchi Yao and others, but also how to dissect this very adequately because of the various techniques that are available. So this, I think, gave us a feeling that we are now in the right time for all the especially the young endoscopists in India to actually start thinking very aggressively in terms of identifying and treating patients with early gastrointestinal cancers. So with this in the background, Mohan and his colleagues have worked very hard to create an excellent program. You see in this program that not only is there significant time allotted to detection of early cancer, but also to live animal exercises where you can actually practice on doing various procedures. These are very unique aspects of this workshop, in addition of course to traditionally showing procedures, advanced third space procedures. So this conference I think is very unique in that sense. It's very comprehensive and gets everything together under one roof. I'd like to thank our faculty, of course the very eminent national faculty who've been friends with us for so many years, but also the three international faculty, Rajvinder Singh, Saichiro Abbey, and of course Norio Ovida, who has been coming for several years now to India and especially recently to our institute to help us actually increase our knowledge on detection and therapy in these patients. There I think a large number of cases lined up for this, very exciting procedures that are going to be done. But I think for me what is more important is the emphasis on basic detection of early cancers, and this I think is going to be very novel and very important. So all in all, this is going to be a great experience, and of course AIG has always been a host for these conferences for many years, and this is a situation where we like to spend time with our friends, showcase what is happening here, exchange very important information, and I know that there are very experienced Indian colleagues also here who have been taking part. They themselves have been conducting many of these workshops. So together I believe we in this country can raise the standards of detection of early gastrointestinal cancers and of course consequently the treatment for this. So once again, I'd like to wish you a very productive and academic conference. I'm sure these 2 or 3 days will be very important. Actually, I'm looking forward to watching all the live recordings of this at a later date, and I'm sure this will be an excellent opportunity to follow up with network, get together, enjoy the traditional Hyderabadi cuisine. Thank you very much.
Thank you, sir. And I invite Dr. G. V. Rao, our director, to say a few welcome words for everybody.
Good morning. On behalf of faculty, staff of AIG Hospitals, a warm welcome to all the delegates, the executive of the ANBIG, and the international faculty who have joined us. Thank you, Norio. Thank you, Rajvinder. I think, looks like a total turnaround in the last 75 years. We are reinventing upper GI endoscopy. I'm surprised to see that actually after 75 years after the initial endoscopy, we started relearning endoscopy again. Thanks to Professor Norio, who's been coming. I keep watching his endoscopy procedures, and I'm surprised at how we totally missed out on doing this procedure so effectively, though endoscopy was there almost for about 75 years. I know that the newer endoscopes, magnification, NBI, other things have changed the entire concept, but I think the basic the concept or the basic understanding lies in the mind of the endoscopist who is doing it. We have to spend time. We have to look for the lesions, and the lesions are there. This is what Professor Norio has taught us actually. Immense patience is what in teaching. I think his teachings are the ones which are responsible for the entire change in how people are practicing. And I also followed up some of the endoscopists who have been doing this endoscopy procedures, and they thank Professor Norio for all what he has done for upper GI endoscopy in this country. Thank you, Professor Norio, for this. And I'm sure that the new concepts will change the entire way in which we practice. Though, I mean, as surgeons, we hardly ever see early GI cancers. Actually, it is not that we are losing surgical patients. Actually, we continue to operate on advanced GI cancers as usual. But the early GI cancers actually certainly come in the domain of endoscopists. And I'm sure as days go on, more and more invasive endoscopic interventions can be done in combination with the medical oncologists, maybe radiation oncologists, which would change the entire outcomes. And when it comes, actually patient comes first, obviously, we treat the patient first. So I'm sure that the outcomes of these patients will definitely improve and also improve their quality of life whenever we're doing these organ preserving surgeries endoscopically. Thank you once again. Welcome to this. I'm sure it will be an endoscopic feast for upper GI cancers. Again, thank Professor Norio for this, whatever he has done to the Indian community. Thank you so much once again.
Thank you, sir. And as tradition in India, we start our conference with lamp lighting. And I invite our international faculty, Dr. Noria, Dr. Raj, and senior faculty, Amol, Naresh, Pankaj, if you can join us, and our faculty from AIG, Dr. Sandeep Laktakia, Dr. G. V. Rao, to help us in blessing this conference so that we can do good work and learn something from you. To honor our international guest, I'll invite Dr. Naresh Bhatt to welcome Dr. Noria Vedo. Thank you. And I'll invite Amol to welcome Raj. Thank you. Thank you, sir. So we'll start our academic program, and for okay, one minute. So, I'm so sorry, Naresh Bhatt. Thank you. Amol, yeah, come. So we'll proceed, and I'll hand over the stage to our Master of Ceremony, Dr. Sandeep Laktakia, and he's been supported by Gautam and Sonam.
Thank you, Mohan. Good morning, everybody. Let's start the proceedings. We'll have the first talk. Mohan, you have to give the first talk, I think. Get down the other stairs and come climb on the what side. May I request my colleague Dr. Rajesh Gupta to join me on the stage. Rajesh, wherever you are, please join me. Together we'll run the show so that nobody takes advantage of anything. I also invite the chairpersons for this session and discussants, Dr. Noria, Dr. Nitin Behel, Dr. H.P. Yadav, Hari Prasad, and Hardik. I'll probably need, Nitin, you can come here. Noria, please join me. Rajesh, we can join together.
HP is also.
HP is here? Okay, so. Okay, ठीक. So let's start the ball rolling.
Yeah. So I thought I'll start the talk myself and get the ball rolling. What is the aim of this conference? And everything starts with the standardization, and this is what is happening in our country. Countries that we are facing a lot of challenges because of huge volumes. There is no standardization. It's a huge country. There are so many states. We have all our different protocols. We do prepare for colon, but we do not have any concept of preparing for upper GI endoscopy. We do not have any guidelines for our nation, how to do the endoscopy in what time. We are not following any protocol for landmarks also. And that's why what is happening is our reports are all over. Our reports can vary from a handwritten note to some of the elaborate reports. But in India, why we need this? This is a very big problem. Though the gastric cancer may not be as high as the eastern countries, but still the burden is so high because we are 1.4 billion population, and we have advanced gastric cancers, advanced esophageal cancer, and at present our 5-year survival rate is 35%, and for esophagus 20%. It's a very, very bad situation. That means if I diagnose cancer now, the chance of survival of esophageal cancer is only 20% and 5 years. And that is the glaring problem here. And you can see the difference between incidence and mortality. we are here, our incidence is equal to mortality. That means how many we are diagnosis, all are dying. But we must look at the countries where incidence is high, but mortality is less. That is happening because they are diagnosing the cancers early. And that's why they are able to produce good results. And that's what our aim is, to diagnose these cancers early. And why we are missing is because we are doing endoscopy very quickly. It's like one of our professor told us, it's like a duodenal darshan. Just go to the duodenum and come back. And then there is a lot of mucus which is being covered by the with the froth. There is no preparation, and that's why we are missing. But since we have started doing things more carefully, we are able to diagnose such small ulcers. You can see there's only a white patch here, and then if you give some time, and you are able to diagnose these cancers, because they need time and they need a proper examination. That's what we are going to learn in this conference. And not only to do ESD. ESD is one which is everybody wants to do. But how to reach here? We have to reach here by proper detection, proper targeted biopsies, proper be able to characterize the lesion. Unless we have that, we will not be able to have a good volume of ESDs, and we will not be able to detect cancers early, and will not be able to treat them in an organ preserving way which ESD provides. But the gastric cancer allow us to do like this, because it does not just come a fungating mass. It follows certain pathway: chronic gastritis, atrophic gastritis, intestinal metaplasia, dysplasia. All these can be caught on endoscopy. And once you have these pre-malignant condition, you can be more observant and follow these patients more carefully. So our things will start with preparation, procedural steps, equipment standardization, and also reporting. Unless we have all for this, we will not be able to have a better diagnostic yield. So starting with preparation, I think once we are decided that we have to do a standardized endoscopy, three things are the most important. One is we must prepare our patient, which we'll talk about that, and then we must have a adequate equipment, at least high definition white light endoscopy, and we should have some time, at least 6 to 7 minutes for endoscopy. And all the endoscopy must start with preparation. The preparation is not very big. It's like a very simple medications which are available in the pharmacy. These are the dimol drop or semethicone, and this is N-acetylcysteine. And if you're doing endoscopy in such way without preparation, you will be missing many things. But once you prepare your patients, you will be able to expose the mucosa to the good white light endoscopy and also the magnification endoscopy. So preparation is the must, and that has been shown in many studies that if you prepare your patient well, your outcomes are going to be better. The second thing which we always do is not to insufflate. We are in hurry, and if we don't insufflate and separate these folds, we will miss the hidden cancers. So we must have a preparation and proper distension of the stomach. That's very important. Then comes the systemic observation method. Don't be in hurry. You do a good examination. Even for esophagus, have a proper landmark, like a landmark of left main bronchus, and above that is the upper esophagus. Between the left main bronchus and left atrium is the mid esophagus, and between the left atrium to the G junction is the lower esophagus. So we must have a landmark evaluation. Suppose I am seeing a polyp in mid esophagus, I'll just not write mid esophagus unless I have measured that. Okay, this is between the left main bronchus, which can be easily seen on endoscopy, and left atrium. So I'll count that as a mid esophagus, not arbitrary. And also we must know the position. Like if a patient is lying on the left lateral position, the water will settle down on the left side. So this is the left quadrant, and opposite will be the right quadrant. So we must know where in the esophagus we are. Not right just like at the 3 o'clock, 4 o'clock. No, a left wall, and right wall, or anterior wall, or a posterior wall. Posterior wall you can easily see by the spine, the vertebral bulge. Also the G junction. So these are some of the things which we will study today. How to identify a G junction, what is the anatomical G junction, like end of the palisading vessels or end of the gastric folds, and then Z line. exactly pinpoint where we are and what we are calling, whether it's a Hill's grades or whether it is Barrett's esophagus or hiatus hernia. And also the SSS protocol, systemic screening protocol by Kenshi Yao, they told that you must do a proper evaluation. Go to the gastric antrum, see the anterior wall, see the lesser curve, see the posterior wall, see the greater curve, then come back into the lower body, again see the greater curve, see the anterior wall, above see the lesser curve and posterior walls. So in this way we have to see all the corners of the stomach, which we'll learn today from our experts, how to do a SSS protocol examination of the stomach so that we don't leave anything. So we have prepared our patient well, we have also distended the stomach well, and now it is time to do SSS protocol to see each and every corners. And we must know what is cardia, what is fornix, what is anterior wall, and we must also have a proper evaluation of all the systems. Say for example in the duodenal bulb, this is superior wall, inferior wall, anterior wall, posterior wall. Similarly, once you come back from the duodenum, this becomes medial wall, lateral wall, superior wall and inferior wall. Also, if it is too cumbersome to follow SS protocol, we can also follow ESG guidelines. I will not go into the details, which takes slightly lower number of pictures, but ultimately once you start developing a habit of seeing the stomach, you need not to follow all these protocols, but you can take images, which Japanese does, but at least we can have a good examination. And moreover, we must follow the classification. There are not many classifications in endoscopy, starting with Los Angeles, Barrett's esophagus, we have Prague CM classification, Hill's classification, ulcers, which is being practiced, Forest classification. Always define your polyp in Paris classification, like 1S, because everything is associated with dysplasia. Like if you see a depressed lesion, it will be more cancerous rather than a polyp which is pedunculated. And also always Barrett's classification we must evaluate in the terms of the Prague classification, telling about the circumferential extent and the maximum extent. Regarding the biopsies, also we must know that we must take 3 biopsies from upper and lower esophagus whenever we are suspecting eosinophilic. For the Sydney protocol biopsies, we must take biopsies from antrum, body and incisura. For celiac disease, from duodenal bulb and from the D2. And for Seattle protocol biopsies for Barrett's has been well known. So these are some of the protocols. If we follow, we are all on the same page. What is anterior, what is posterior, what is at upper wall, esophagus, lower esophagus. Just not be very vague about our diagnosis. So other things which I wanted to ask about is the difference between Japan and India. The problem is that we are having lot of volumes. But if we can try to concentrate on the patients who are more likely to have cancers, like those patients who are older age, who are smoker, who are alcoholics, who have previous head and neck cancers, male gender. So these are the patients whom we will be very careful to do. Those patients, as I said, if we understand how to see atrophic gastritis, how to see metaplasia, H. pylori infections, family history of cancers, we will zero down these patients in our triage room. Okay, these are the patients I am going to be very meticulous to examine and try to find out underlying characteristic findings of suspicious lesion. So the key is to slow down and see how you do magnification endoscopy, which Prof. Noria and Prof. Raj will tell us about today. Know what is normal in gastric fundus, what is normal in gastric antrum, and able to diagnose pre-malignant conditions like atrophy, where we see this is a normal stomach, and moment we start seeing the increased visibility of the vessels or pale mucosa or loss of gastric fold, we start seeing this is a gastric atrophy. Similarly, Kimura Takamoto classification we will follow. We'll follow all these things today, but my aim was to tell you about the early lesions and these can only be picked if you follow these protocol. Like if you have a proper indication, proper consent, mucosal cleaning and insufflation, high definition white light endoscopy, some knowledge of image enhanced technoscopy, then spend sufficient time, classify and use standard protocols. As I said, follow the protocols of the biopsy, always write management recommendation, and always be sure about what is the surveillance. Say for example, you must know what is the surveillance for Barrett's, what is the surveillance for atrophy, what is the surveillance for metaplasia. If you know all this, you will definitely be going away from symptom-based to prevention-oriented endoscopy. And then we'll be able to do the standardized way endoscopy and attend some conference like this to have advanced imaging knowledge. Training and credentialing is very important for us, and we must build Indian data to build guideline and policy for our own country. With this, I'll stop and will be happy to answer any questions if there are any.
Questions? We'll take
After, okay, yeah.
request now. Now I request Dr. Rajendra sir to kindly come for his second talk on standardization of colonoscopy after a master talk on standardization of upper GI endoscopy.
No. Use the HDMI. Yeah. Thank you. No. Can you see my slides? Can you put it up? Thanks. Thank you for the kind introduction. Firstly, I'd like to thank Professor Reddy and Mohan, Professor G.V. Rao, Sandeep, who I've known for a long time, as well as all of the senior endoscopies, including my friends over here, including Naresh, Pankaj, Amol, as well as Professor Uedo. Thank you for the invite. So what I'm going to do is basically talk about standardization of colonoscopy. So some of these data has come from the part of the Cancer Council of Australia, where we develop guidelines. There's actually a 340-page guideline on colorectal cancer and screening and surveillance, which we were part of. So I'm sure if you have plans to produce some sort of guideline for India, you can clearly look this up. I've also taken guidelines from Malaysia, where I was part of the advisory board, as well as the AGA, and also an international consensus guideline, which I will touch on briefly. So I'm going to outline the talk on local data and new standards in the West, what to measure, how to improve, and some of the key points will be in red. So this is one of the studies which was pulled up, and I thank Hardik for this. So thanks Hardik for handing me this study. So this is perception and practices of colonoscopy practice in India, study which was performed actually in this state, in Secunderabad, 350 surveys with about 88% completion. It's very interesting to know that 18% of those surveyed perform more than 100 colonoscopies a month. 46% denied or following a colon cancer screening policy. PEG was the most preferred solution, and about 1/5 of the proceduralists did not use any sedation. The cecal intubation rate of more than 96% of the time was 58%. So these are some quite interesting and compelling local data. Average time of completing procedure in more than the 20-minute group was 17%. There was quite a lot of the proceduralists who performed these procedures quicker than that 20-minute time frame. And a lot of them use air, and some use CO2. And as you can see, perforation was the most noted complication faced by the respondent, not too dissimilar to anywhere else in the world. So what we could measure, what we could do as part of a guideline is firstly start with 8 key things, and I will go through this. So one of it is bowel preparation. We should have written and verbal instructions and navigation. You know, we've all got AI type tools these days. So a phone or text sort of navigation tool will be important for bowel preparation. We do use split dose for patients who come in for the morning, and for the same day patients who come in the afternoon, we actually do a same day preparation. So I had a colonoscopy 3 months ago. I did the PM sort of procedure where I myself took the bowel prep at 7 a.m. and again at about 10 or 11 a.m. and had the procedure in the evening. So you have to begin the second dose 4 to 6 hours prior to the colonoscopy for the same day prep, and finish the last prep at least 2 hours prior to colonoscopy. Judge the prep after washing is done. Don't sort of go in and say it's a poor prep and pull out the scope and say you come another day. We should wash the mucosa before we judge what sort of prep, and we should achieve an adequate bowel preparation in 90% of the time. These are all measurable things which we can do in our respective units. How you do it is up to you again to discuss with your nurse unit manager and your team. If the prep is inadequate, we should repeat it within a year. But I would say that 6 months is preferable in case you don't want to miss a cancer. And we should use some sort of standardized bowel preparation score. The Boston bowel preparation score is easy to remember, and I would urge you all to look into some sort of a score so it is standardized, as Mohan mentioned. In the upper GI, you should do the same in the lower GI. You should use the ADRs. You've heard this time and time again. This is a large study of more than 700,000 patients, which showed that if patients achieve an ADR of 28% or more, there's a lower risk of post-colonoscopy colorectal cancer. There's also a lower risk of post-colonoscopy colorectal cancer deaths. All right, so PCCRC. So this graph you can see on the right basically came to some sort of a plateau to suggest that perhaps we should be looking at the 30 to 35% mark in a Western population. All right. So the new benchmarks with ADR is that for all indications in the West, we should achieve a benchmark of 35%. In Australia, we're still at that 25% mark, and 40% for men or 30% for women. And the new benchmark for adenoma detection with a positive stool test is 50%. So in 1 out of 2 patients, you should be finding an adenoma. What is the local data we have here? This is from 2 studies. One was done in 2016 and the other in 2024, where you can see the ADR rates have gradually improved with knowledge, with perceptions. It has improved to about 20% now in the local population. I think the last study was performed over here in the AIG itself. Sessile serrated detection is another thing. We've got some discussion around that. We have to understand that there's this new benchmark called the SSLDR, which is 6%, should be about 6%. So just take that into consideration. Withdrawal time is the other thing. 8 to 9 minutes, you can see in the graph there is the right sort of plateau. All right, and these are some of the techniques you can use, which includes adequate distension, washing, cleaning, looking behind folds, segmental inspection, and subjective timing as well, and a cecal intubation rate of more than 98%. Intubation times, I just put this up slide to break things up. You can do intubation times, but you shouldn't, okay? This is a self-colonoscopy report in one of our premier journals, GI Endoscopy, of a person doing this within 4 minutes with a small caliber colonoscope. So this is just put there to break things up. Don't follow this protocol, okay? This person liked it so much that they did it 3 more times over the next 2 months, 5, 3.5, and 4 minutes. So really good, but you don't want to do that. But it ended up being a publication actually. So it's a big no, okay? We should use some IBD type scoring systems, including the Mayo endoscopic score, as well as the percentage of patients with UC undergoing dysplasia screening. Resection measures, lesion shape, size, location, and method of resection should be reported in more than 98%, almost 100% of our patients. This is an international modified Delphi process study which we were involved with, looking at this, and we have come up with all of the standards in resection, which you can see there. So it's important to get the appropriate information before we embark on a large resection, not only in the lower GI, obviously in the upper GI as well. We need to know if this lesion was tackled before, it was tattooed. We need to have pictures to show, and you need to know if there's biopsies which were taken, where they were taken, how many biopsies were taken. It's very important. So resection methods, another study which we did, looked at these 6 experts in 5 domains. I will just come to this. This is the methodology, which was quite tedious and took about 1 year to complete. What we found was with training, you should use IEE, which is, I think, that's why we are all here today. We should have an adequate caseload to perform complex resections. And I know this workshop is on complex resections later on in the workshop, so we should have an adequate caseload to begin with, and we should monitor and audit our performance, because you just don't want to be doing it for the sake of doing it. Pre-resection, use IEE methods as described here, and you can see all of the other things. And you should follow some sort of protocol with regards to optical classification. This is the JNET classification, and looking at various things, including whether lesions should be removed en bloc in a piecemeal fashion, and where they fit into this greater protocol. It's important to understand this. We should also have a histological sort of criteria and cut at 2 to 3 millimeter intervals throughout the specimen. This is one of the recommendations or agreement which was having strong in strength but very low quality of evidence. Surveillance, once we are done, all right, so we should be able to be telling our patients that you'll need to come back for surveillance, and you can see various sort of strategies here. This is again Western data. I would urge you to have your own type of data to look and see where these patients fit into this sort of strategy of 7 to 10 years, 5 to 10 years, 3 to 5 years, 3 years, or 1 year. You don't want to be bringing patients every year, right? Because surely they can't be having 10 adenomas every time you bring them, right? So you want to make sure you follow a strict protocol. And post-resection, for AMR, same-day discharge is advised without hospitalization. There's a very strong sort of evidence and high sort of agreement amongst the people, the 46 or so experts here. Follow-up colonoscopy should be performed 6 months after a piecemeal resection, and if it's an en bloc resection, either EMR or ESD, you can extend that to 1 to 3 years. And if there's deep submucosal invasion, you have to carefully consider if these patients need to go for surgery, or they can have close follow-up if they've got different comorbidities. The other thing is that with surveillance itself, there's very poor indication that we are actually adhering to it. So that is something you need to consider in your respective units. The other thing is where these surveillance patients who you scope, they're going to become your largest pool of indication later on in your years. So once we embark on a screening type strategy, you have to be aware that patients are going to come back for surveillance later on. How to improve? Just quickly, I'll go through this. Water assistance may be beneficial, 6 to 10%. Retroflexion in the colon or second look can increase your ADRs from 5 to 17%. So that is worthwhile to do. Dynamic change in the patient position, 7% improvement. Distal attachment caps may improve your ADRs by 5 to 11%, but also may reduce procedural time. The other thing is IEE itself will obviously improve your detection. Some of the other techniques, computer-aided detection, may be about 10 to 12% in adenoma detection rates. Video recording of colonoscopy, no improvement. So don't bother recording your videos unless you want to use it for presentations such as this. If you have somebody in the room looking at your procedures, that can increase your ADR up to about 19%. Physician report cards actually does increase. Focused educational intervention versus no education increases one's ADR by up to 39%. And finally, public reporting is fantastic. So if you put your ADR scores there in your unit, it increases one's ADR rate by up to 50%. It's just extraordinary. I mean, what things can be done to improve your ADR. So in summary, these are the 8 points which I think you should be able to use in your own individual practices, but standards in colonoscopy is only feasible if they are measured. So if you can measure this with whatever way you can, that will really help improve your quality in colonoscopy. So thank you very much.
Thank you so much, sir. Request Dr. Mohan, sir, to also come and join Dr. Rajendra on the dais. Now the session is open for questions from the audience as well as from the discussants. Professor Noria, any comment from your side, sir?
Yes, Ashutosh.
So, thank you both the stalwarts for a nice lecture. For one comment, for upper GI endoscopy, standard endoscopic examination time should be at least 7 minutes,
Yes.
not 6 minutes. If someone says 6 to 7, then the junior will come, will tell 5 to 6. Then next person will come, will 3 to 4. So, always should be 7. And if you find high risk features in the endoscopy, then give at least 2 to 3 minutes. Otherwise, you can never detect early gastric cancer. Second, for colon, as always, withdrawal time is there, 7 to 8 minutes. But I think the technique of withdrawal needs more emphasis than the time only.
You are absolutely right. I can answer the colonoscopy question. So the data comes from extrapolation from large studies. So they are looking at 8 to 9 minutes. But certainly, if you do not expose the mucosa well, you do not have good technique, then you obviously will not have any incremental ADR detection rates. You know, you don't want to sit in the rectum for 8 minutes, and when the clock is up, you pull the scope out. So certainly what your points, what you say is correct. Can I ask you one question though in return? So you say in upper GI, 7 minutes. Is it total endoscopy or only in the stomach?
For me, it's stomach only. Because there are many studies for G junction, if you give more than 5 minutes, you detect more Barrett's. So I am talking about stomach only, not duodenum or not esophagus, only stomach.
We can start full endoscopy in 7 minutes, I think. Dr.
Okay, there are studies, but it takes time. Even in Japan, if you ask Dr. Noria, he will tell also, if you find high risk feature, you will 100% you are going to give 2 to 3 minutes extra.
Of course, yes. Yeah.
Just short comment. Probably all study say that it's all time, all procedure time, not on limited stuff.
Whole procedure.
And also maybe good preparation can really reduce the time and then more efficient.
What about those countries who have Barrett's? Then how can you complete within 7 minutes? Because Barrett's, you are looking for Barrett's, you are looking for early gastric cancer. And if you look for duodenal examination, it will take at least 3 to 4 minutes. So there are no study to conclude to say firmly that we can finish in 7 minutes. Because now I have started doing, say, endoscopic exam of duodenum. It takes at least 3 minutes to 4 minutes for complete evaluation of ampulla and duodenum D1, D2.
I think it depends. I think it depends on what you ultimately find. So, for instance, if you find a Barrett segment, you're gonna increase the examination time. What's been recommended is 1 centimeter per minute. 1 minute per centimeter. Sorry. So if it's 7 in total, if you've got a 3 centimeter segment of Barrett's, you may spend an additional 3 minutes to that. So I think it depends on the situation of what is encountered.
Dr. Naresh, sir, so your question.
Thank you. I think a couple of things that I wanted to do. One is that you did not give any emphasis to cap-assisted endoscopy in the colon for completion. 2 is you said withdrawal time. What happens if you have time that you need to do a cold-snare polypectomy in the proximal colon? How do you add up that to the withdrawal? And finally, when we decide standards, we always have to remember that there's going to be a medico-legal sort of perspective on this. So we need to have clear things on this, because if you don't do that, then you open up your thing to issues on that front.
So to your first question, with regards to the cap, one of the last slides said that you can increase the ADR rates by 5 to 11%. So it is possible to do that. What I would urge from a practical standpoint though is that to realize that once one uses a cap, the visibility of your entire endoscopic views reduces by 25%. You could see in some of Mohan's videos as well, once a cap is used, there's a shadow in the distance, and that reduces visibility. So it's important to then have good technique to try to expose the folds to find these adenomas. That's one. To your second question with regards to withdrawal time, all of the studies, and I don't know how much of resources they have, which obviously is quite a lot in a Western setting, they stop the clock when an intervention is being performed.
Oh, yes.
So the withdrawal time is only calculated based on the actual diagnostic procedure itself. With regards to standardization, I think it's important to have them because, as I think Mohan said very clearly, you have the same language, you've got the same parameters, and those parameters can hopefully be applicable to all, but at the same time, they will change.
Yeah, I mean, ask Shri Hari for a question. Can we ask the questions to be brief and short? Yeah, one question
so
only.
This was a question and a comment to Dr. Mohan's thing that pre-endoscopic preparation is obviously a very important thing, but you know, despite so much of talk, not many people are still using it very often. Yeah. So my question is to Dr. Vedo. We obviously saw that your center does it. Do all centers, do all primary centers, that is where the actual screening happens, right? So do they also perform a pre-endoscopy preparation? And Professor Rajwinder, at your place also, is it common in Australia?
In Japanese practice, we do probably almost all center use preparation. Yes.
So you're talking about upper GI?
Yes.
So it's just part of when the patient comes in to register, and once they are booked in by the nurse who sees them outside, they're given the drink. So it forms part of the protocol.
Professor
So by the
Pagira.
time they come back, come to the room, which is about 30 minutes later, all of that action has taken place within the upper GI tract.
I'm not trying to evade the questions, but we are very tight with our program. So
We just take
we'll take up your questions in the next session. Thank you.
Thank you, everyone. Thank you, the speakers, for the wonderful sessions. Thank you.
We would like to thank all the chairpersons and invite our chairpersons for the next session, Dr. Naresh Bhatt, Dr. Pankaj Desai, Dr. Jimil Shah, and Dr. Mark Siboi. We would request them to introduce the next speakers. Thank you.
Good morning, and we'll start the second session, which is on enhanced imaging and endoscopy, and we start off with Dr. Monish Habra from Chandigarh, who will be speaking to us on seeing beyond white light.
Thank you, Dr. Bhatt. Thank you, Dr. Reddy, Dr. Mohan, and the entire AIG team for this honor. I'll be speaking on image-enhanced endoscopy, seeing beyond white light. Besides so much advancements in endoscopy, the diagnosis of early GI cancer still pose a great challenge to us because these present as subtle events, subtle changes on endoscopy, which are usually missed on a routine endoscopies. And if you see the missed lesions of the squamous cell carcinoma of the esophagus, adenocarcinoma in Barrett's, or the early gastric cancer, the missed rates are around 4 to 6%. And few series have reported a higher rates within 6 to 36 months after a non-diagnostic EGD. And I feel these rates would be much higher in our country, and Mohan has adequately discussed the causes and reasons why we are missing so many early cancers in this country. So image-enhanced endoscopy provides us a new paradigm where not only we detect these early cancers, but also characterize them by studying their microsurface and microvascular pattern, which gives us a potential tool for treatment, because we have to know whether these early cancers are amenable to any treatment, whether they require treatment, they are for endoscopic treatment, or they go for a surgery, depending on, once we characterize what is the depth of involvement, and on that basis we predict what is the involvement of the lymph nodes. If we see image-enhanced endoscopy, it involves a combination of modern endoscopy technologies, high-resolution, high-definition video endoscope, sequential color CCD chips, more than million pixels, optical enhancement technologies like NBI, BLI, and the most important here with magnification with zoom or near focus lens where we magnify 50 to 80 times and do not lose the wider field of view once we magnify. And the most important thing which has been emphasized in earlier talks is the distal attachment cap, which makes a real difference in the endoscopic images once we use it. So the most commonly used optical enhancement technology and most practiced is NBI, which involves using blue and green light, where the bandwidth of both these have been reduced to narrowed to 415 and 540. So the blue light with a shorter wavelength is absorbed by the superficial capillaries, which are displayed as brown, and green light being longer wavelength is absorbed by deeper veins, and they are displayed as cyan. So what does NBI do? NBI basically improves the contrast of the superficial capillaries, blood vessels as compared to the background, and we are able to study the angiogenesis and make an early diagnosis of dysplasia and characterize these early cancers. There are a lot of indications of NBI, magnifying endoscopy, as diagnosis of early squamous, diagnosis of dysplasia and Barrett's, H. pylori gastritis, diagnosis of early gastric cancer, and characterization of colonic polyps. So these are the ideal settings, structural and color enhancement, when we use NBI and magnification. A8, B7, B8, color enhancement has 3 modes, 1 and 2 for upper GI endoscopy and 3 for colonoscopy. I feel gastroenterologists, we are not looking at the pharynx completely, and we think that it is a domain of the ENT surgeons. However, the morbidity which is involved with the advanced presentation of these cancers in our country, I feel that it's an opportunity for us as gastroenterologists when we are using these scopes to diagnose them at a very early stage. So in my practice, I usually start with an NBI, look at the palate and look at both the buccal mucosa, then go down. And what we are looking here, we are looking basically for a well-demarcated brownish patch, which is a collection of abnormal capillaries which are called as IPCLs. So you should be well versed with the anatomy of the hypopharynx, both pyriform sinuses, laryngeal inlet, and the post-cricoid space. And I tell you that as small as 1 mm, 2 mm lesions you can diagnose with NBI and magnifying endoscopy, which can make a real difference to these patients. And you must remember a fact that this stratified squamous epithelium of pharynx is slightly different from esophagus. It doesn't have muscularis mucosa. That is why lymphatic metastases are very early in oropharyngeal cancers. And sometimes you may have this incidental laryngeal papilloma, and it just takes about a minute to scan oropharynx. So the NBI examination of the esophagus, basically I start, again I do an NBI right from the beginning in the esophagus, and esophagus does not have any glandular pattern, it doesn't have any pits. So what do we see on an NBI in a normal esophagus? In a normal esophagus, you examine the microvascular system, which are these green branching veins which you can see, which are superficial to muscularis mucosa. And from these green branching veins, there are certain special capillaries which arise, which are called as IPCLs, which are not visible on a non-magnified endoscopy. Only once you magnify, you see these IPCLs which are around 10 micron. And in otherwise normal, you won't be able to see this. Whitish thing are the normal glycogen deposits. So near the G junction, there is a sharp contrast between the gastric and the esophageal mucosa, because the gastric mucosa is rich in superficial capillaries, so it appears as brown. And the other thing which you see here are the longitudinal green parallel veins which are beneath the epithelium, called as the palisade veins, because the lower end of the palisade veins usually coincides with a G junction, which is the upper part of the folds, and usually helps us to delineate the Barrett's esophagus. So the most important thing in esophagus with magnifying NBI is to study the morphology of IPCLs. And this morphology changes once there is a dysplasia or there is a cancer, that they dilate, they become tortuous, there is a caliber change and various shapes in IPC, various shapes. This is in a simple reflux esophagitis, that these are type 2, where they just dilate and elongate, and you see here they are just present in rows, they are not variable forms. And if you see, for early squamous, you have to look for a well-demarcated, sharp brownish patch which has a very high density of IPCLs. And further, once you detect it, you have to characterize what is the depth of involvement of this squamous, and this we do by studying the IPCLs, and this has been given by the Japanese Esophageal Society, and they have divided into 3 categories, B1, B2 and B3. B1 are the loop-shaped IPCLs. If you see, then the depth of involvement is still lamina propria. And if we have a B2, which are the loose vessels, variable shapes, and the loop has opened up, these are the B2, where the depth of involvement is still superficial submucosa. And B3 are the larger vessels. They are almost 3 times the B2 vessels, and this suggests a deep submucosal invasion where this lesion is not amenable for endoscopic resection. Again, Barrett's esophagus again poses a great challenge, because the dysplasia in Barrett's presents as a subtle lesions which are present in only 10 to 15% of patients. So magnifying narrowband imaging really helps us to assess the microsurface microvascular pattern, where you have to see whether, which indicates basically there is a specialized intestinal metaplasia as the straight, villus and cerebriform pattern shows. And again, this capillary pattern like leaf-like DNS coiled spiral pattern suggests that this is a specialized intestinal metaplasia. For esophageal adenocarcinoma, again you see for a demarcation line and irregular pattern microsurface or absent microsurface with an irregular microvascular pattern. I found this classification from the Japanese Esophageal Society as very useful, where they classify and have just simplified mucosal patterns into pit, non-pit, vascular patterns into net and non-net, and depending upon regularity or irregularity they divide it into dysplasia or non-dysplasia. Here you can see it's a pit type, net type, regular pattern, so non-dysplastic, non-pit, non-net on the left side, regular, non-dysplastic, invisible pattern, net pattern of the capillaries you can see in the middle with a demarcation line, irregular, so this is a dysplastic pattern. Again, non-pit, non-net, irregular, dysplastic, and invisible pattern on the right side, non-net, irregular and dysplastic. If you see this pattern and thick greenish veins, it is usually a non-dysplastic pattern on Barrett's esophagus. So on Barrett's, as everyone has said, that you have to do a Prague classification. This was a C1M2 lesion, and basically you have to spend at least 1 minute, as has been said by Dr. Rajvinder, 1 minute per centimeter. And so just for the paucity of time, I think I'll skip this video. In the NBI is very useful in the stomach when you apply it with magnifying endoscopy. And in the stomach you have 2 distinct patterns depending on whether you are examining the corpus or the antrum. In the corpus, the glands are usually tubular, the pits open perpendicular to the surface, whereas in the antrum the glands are branched, they are oblique, and the pattern definitely is different. So this shows how the pattern is different. In the corpus we have a hexagonal subepithelial capillary network which surrounds a brownish pit, and there is a clear white zone of marginal crypt epithelium with intervening areas. Similarly, in the antrum, if you see, you have the pattern, we call it as linear reticular. The intervening part is usually broadened, subepithelial. The capillaries are coil shaped and they are within this linear or reticular white border where the pit opens. So this is the normal H. pylori negative NBI magnifying images. On the left side you see corpus. They also have these star shaped veins called as the collecting veins, and the antrum has a reticular pattern. So prediction of H. pylori gastritis on endoscopy is important because 98% of gastric carcinomas are found in patients with H. pylori gastritis. All of you have seen these endoscopic images of H. pylori negative white light images. These are the H. pylori positive, but we have to concentrate what happens with the H. pylori on NBI magnification. When H. pylori migrates proximally, the corpus shows atrophic changes. It from the honeycomb pattern it changes to linear, then ridged, and finally papillary and villiform. This is the advanced stage of atrophic gastritis, and these are the patients where you should be looking carefully. This was a very novel finding which was described by Dr. Vedo, who is here. An interesting concept using NBI magnification, a light blue crest where a fine blue white line on the crest of the epithelial surface was seen, and this was highly predictive of histological intestinal metaplasia, which is a risk factor for intestinal type of gastric adenocarcinoma. This is a marginal turbid band, which is an enclosing white turbid band. This is an early form of a intestinal metaplasia. Similarly, this is an NBI picture of H. pylori gastritis, where you can see the pits have enlarged. You don't see collecting veins and don't see subepithelial capillary network. Same is seen here. These are the patients with nodular enteral gastritis, where you see a lot of lymphoid follicles on NBI magnification endoscopy. This is atrophic gastritis with this absent pits, absent SCCN, and irregular arrangement of collecting veins with the submucosal veins are prominent. These are the patients who, with intestinal metaplasia, we see these grayish white patches, and on NBI magnification, you will usually see a villous or papillary pattern. Early gastric cancer is basically defined as limited to mucosa or submucosa, irrespective of the lymph node metastasis. And Yor described a very simple diagnostic algorithm that if you see a high-risk lesion on white light endoscopy, you do a magnifying endoscopy and look for a demarcation line, and if present, look for irregular microsurface and microvascular pattern. If demarcation line is absent, irregular microvascular pattern is absent, it has a very high negative predictive value, more than 99%, it rules out a malignancy. So this is a VS classification system. V stands for microvascular and S for microsurface, that look for demarcation line, then look for whether they're regular, absent, microsurface pattern, and make a diagnosis of early gastric cancer. Again, few images showing on the left side regular, the middle image shows is an irregular microvascular pattern. Here on the right side, the microvascular pattern is absent because of the white opaque substance, which shows an irregular distribution. Similarly, in colon, NBI again plays a very important role for characterization of the polyps. The Japanese NBI expert group team gave this classification for characterizing and differentiating benign from malignant polyps, as well as it gives us an indication how much is the depth of involvement and whether they are amenable for endoscopic treatment or not. And genet type 1, where the...
Sir, can you please wind up?
So last line is that image enhanced endoscopy, basically, if you want to learn, it requires a high intention, intelligent direction, very sincere effort and skillful execution. My thanks to Dr. Vedo, who has been my mentor and taught me NBI. Thank you, sir. Thank you.
Thank you very much. We'll invite our second speaker, Professor Noria. Thank you. He's presenting on chromoendoscopy. All die, new science.
Okay, thank you for everyone and AIG organizing committee to invite me to this scientific symposium. I'm very happy to see all my friends in India. And then today, this time I explain about the chromoendoscopy, about chromoendoscopy diagnosis. So on the background, this is already talked. Digestive tract cancer is one of the leading cause of cancer deaths worldwide, and early detection and treatment really effectively reduce the mortality. So such advanced cancer, special technique is not necessary. But superficial lesion or early stage cancer does not show very subtle changes of morphology or color changes. So in such case, chromoendoscopy really helps to detect or characterize the lesion. So chromoendoscopy really enhances tumor characteristic like a morphology or color and improve diagnostic accuracy. And very important point, it does not require very expensive equipment. If you can prepare the dye solution, and then you can apply to your clinical practice. So interestingly, such chromoendoscopy was developed in 1970s. So at that time, we didn't have a very high technology like image enhanced endoscopy system, like NBI or BLI magnification. So at that time, Japanese endoscopy developed chromoendoscopy to improve diagnosis of superficial lesion. So chromoendoscopy basically categorized according to the method or enhancement method, contrast or absorptive or reactive. So I explain each other. So contrast method use some dye. So such dye put to the depressed area or some mucosal sulcus or something, and then highlight surface topography, such as indigo carmine, and also methylene blue can also use as a contrast method. So like especially with magnification, we can really see the minute mucosal pattern like this. So basically dye put in a depressed area, so the pit or sulcus can be seen as a kind of stained area like this. And as I mentioned, like methylene blue can be also used as a contrast method dye. And another method is absorptive method. So some dye like methylene blue or crystal violet is absorbed or diffused into the epithelial surface and then stain the surface epithelium like this. So if you apply methylene blue to the mucosa with intestinal metaplasia absorb dye, and then we can really characterize the presence or distribution of intestinal metaplasia efficiently. And as I mentioned, we can use crystal violet to stain the epithelial surface. So we can really see the pit as a non-stained area. In contrast method, usually pit is stained or pit capture dye, so it is kind of stained. But in absorptive method, pit is seen as a non-stained area, like a positive or negative film like this. But anyway, we can really evaluate detailed micro surface structure with this method. And acetic acid also can be used as a very similarly to absorptive method. So it really enhances the surface structure of the micro mucosa so that it increases the diagnostic accuracy of characterization of mucosal pattern like this. And interestingly, recently some doctor used acetic acid to detect sessile-serrated lesion in colon. So acetic acid can enhance a diagnosis of surface structure and also detection of sessile-serrated lesion. And another method is a reactive method. So in this method, so normal esophageal mucosa, squamous epithelium contain glycogen, so it reactive to iodine and then change the color to brownish, while cancerous mucosa glycogen was consumed, so we can see extension of the squamous cell carcinoma as a non-stained area. So this is currently still it is developed in 1970s, but some method is still using in a Japanese clinical practice. Contrast method using indigo carmine for diagnosis of stomach or colon lesion, colonic lesion, or crystal violet for especially with magnification for colon pit pattern diagnosis, and acetic acid for Barrett esophagus diagnosis, and sometimes we use characterization of the surface mucosal pattern of stomach or colon, and the iodine for use for squamous carcinoma. And for usage, most important point for methodological importance for usage is mucosal preparation. This is already emphasized by previous presentation, but especially when you apply a dye, when the mucus or floss is covered the surface, dye is applied on top of such kind of mucus, so it make it more obscured the lesion characteristics. So it is very important to perform good mucosal preparation before application of chromoendoscopy. Another important methodological point is concentration. Some concentration can really provide different effectiveness. So if you use thin concentration, low concentration dye, you can appreciate original color of mucosa and also very subtle change of the mucosa as well. But if you apply very high concentration dye, you can evaluate more detailed micromucosal pattern, but sometimes very subtle lesion or small lesion can be missed, like this. So low concentration is better to evaluate gross appearance with using original color of morphology. But high concentration is useful for detailed characterization of the mucosal surface pattern. And even you use high concentration dye, it does not really affect the NBI magnification diagnosis. So basically, this is also explained in a column. It is better to use light color for detection to put the low concentration dye into the spraying catheter, or dark color, high concentration dark color to characterization of the lesion. And that is mechanisms and then important for the usage of chromoendoscopy. And some clinical study data is also available. Previously, we have conducted the randomized control trial to compare the usefulness of chromoendoscopy or magnifying NBI for delineation of early gastric cancer. So in this study, we expected to improve the diagnosis by magnifying NBI, but the actual result was not the same. So chromoendoscopy, diagnostic accuracy for delineation by chromoendoscopy and magnifying NBI was almost similar. So maybe according to this result, if you have chromoendoscopy, you can achieve almost a similar diagnostic accuracy for delineation of early gastric cancer. And in the some subgroup, we found that the very flat lesion, because chromoendoscopy really contrasts the surface topography. So very flat lesion, diagnostic accuracy is magnifying NBI is better because it can really evaluate microvascular structure. But the actual percentage proportion is quite low. So overall, chromoendoscopy can provide good delineation diagnosis. And another important recent data is iodine chromoendoscopy. It can find some very multiple Lugo unstained area. So in such patient, development of subsequent lesion, squamous cell carcinoma, is more than the others. So if you find such lesion, you can really assess the risk of development of squamous cell carcinoma and then change the practice for surveillance. So in summary, chromoendoscopy enhances tumor characteristics and improves diagnosis. It needs only dissolution. So if you don't have a high technology or magnification endoscopy, it really improves the endoscopic diagnosis accuracy and improve clinical outcome. Understanding of proper usage is important. Thank you.
Thank you, Professor Norio. It was a masterly lecture. So it's open for the house for the discussion. For I have two questions for Professor Norio. That what is the utilization of addition of the dichromoendoscopy in about to the NBI or the virtual chromoendoscopy in today's scenario in a clinical practice? So let's say if there is a high risk individual, either for the squamous cell carcinoma of the esophagus or the early gastric carcinoma, where you have not found anything suspicion on NBI, would you still go ahead and perform the dichromoendoscopy or not? And second, what is the utilization in demarcation line once you have already been identified the lesion accurately before the resection? What is your clinical practice in today's world?
Sorry, maybe I answer one question. So can you see my slide? Show my slide. Can I?
Yeah.
Yes. Can you? Yeah. So, especially, the one question is, what is additional advantage of chromoendoscopy over NBI or something?
Yes, yes.
So, probably, maybe chromoendoscopy can really evaluate the gross appearance. So especially very large lesion like very extensive gastric cancer, sometimes magnifying NBI takes very long time to evaluate whole delineation. So usually we evaluate gross appearance by chromoendoscopy and then focus on very suspicious area or unclear diagnostic area so that we can really make the diagnosis more efficient. So I think that is a role of dye-based endoscopy. Evaluation gross appearance.
Professor, I'm Dr. Kunal. So my question is, normally the gastric cancer incidence in India is less compared to in Japan. So normally what technique should we do a white light endoscopy complete, and only when we see something suspicions on white light endoscopy should we do a NBI, or we should try and involve NBI as a complete upper GI endoscopy procedure right from the first beginning? What is your suggestion?
So I think this is different according to organ. So esophagus, there is a randomized trial. It showed that NBI is significantly better than white light for detection of superficial squamous cell carcinoma. So esophagus, basically we evaluate mucosa with NBI. But for stomach, currently, I think there are several randomized trials, but still NBI diagnosis does not show the significant benefit for detection of early gastric cancer. So still in our practice, gastric cancer detection is based on a good quality white light diagnosis. So that is still
a question for you, Professor Noria.
Yes.
You said that dye-based chromoendoscopy can be used when you don't have more advanced scopes.
Yeah.
Now, without magnification, see, I think the big problem comes about you don't have zoom, you have dual focus, there's some data to show that they're reasonably okay. But how much is the difference that you lose out if you don't have zoom and you just use chromo?
I think zoom endoscopy is beneficial for characterization, but for detection, I think non-zoom magnifying endoscopy is enough. And also, still, if the chromoendoscopy really enhance the morphology or color difference in some part, so still we can really increase the suspicion and then make target biopsy, something like this. So still such advantage available over conventional white light endoscopy, I think.
Yeah. Last very brief question.
Which is the best dye for the early gastric cancer, intestinal metaplasia and the chronic atrophic gastritis? What your opinion about the Congo red dye that we use?
So for diagnosis of early gastric cancer, most of Japanese practice we use indigo carmine for morphological assessment. And intestinal metaplasia, as I show, that probably methylene blue is the most high accuracy. But probably mucosal preparation is too much, and then maybe clinical usage is very limited.
What about Congo red?
Congo red, actually my senior professor developed such technique. And then when I was resident, we have done. But it takes about 20 minutes for one procedure. And then currently, I think Congo red has some suspicious for a carcinogenetic effect or something. So it does not use in a clinical practice.
Yeah, thank you so much for this wonderful session. I think we'll end the session here. Thank you, everyone.
And thank you, Professor Norio. So now we break for the lunch and we reassemble sharp at 1:45. We have a packed session. Please be here by 1:45 sharp. Thank you.
networking up network
నాది అయ్యింది. చెక్ అన్నా, చెక్. హలో 1 2 3 చెక్. హలో చెక్. ఆడియో ఓకేనా? చెక్ 1 2 3 4 5 6. హలో చెక్. ఓకే. చెక్ 1 2 3 టెస్ట్. హలో చెక్. Check 1 2 3 4 5 6 7 8 9 10. Check. Hello. Mic test. Check. 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 Hello. 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 నాకు రావట్లేదన్నా ఇది. ఇవ్వు పర్లేదు.
హలో రిషి.
అన్న నీ ఆడియో వస్తుంది.
సుశాంత్ చెక్. రిషి ఆడియో ఓకే అన్న ఇక్కడ.
నీ ఆడియో కూడా నాకు వస్తుంది.
ఓకే. నువ్వు ఎనేబుల్ చేసుకో ఒకసారి.
ఓకే. రిషి.
హలో.
నా ఆడియో వస్తుందా?
నీ ఆడియో వస్తుంది.
క్లియరా?
క్లియర్ ఉంది. శివన నీకు కింద ఆడియో ఉందా? క్లియర్ ఉందా?
ఎస్ క్లియర్.
ఒక్క నిమిషం. హలో, నాకెవరిదో పిక్ అయి వస్తుంది.
కేదార్ శివనతో మాట్లాడు, కింద పోడియంలో ఉన్నాడు.
కేదార్ బాగుందా? బాగుంది కేదార్, ఆడియో ఓకే.
శివన్న ERCP4 నా ఆడియో క్లియరా?
క్లియర్ సుశాంత్.
ఓకే. ఒక్క నిమిషం. ఇప్పుడు నేను ఒక్క నిమిషం అబ్బా. కేదార్ ఒక్కసారి నువ్వు ఏదైనా నంబర్స్ కౌంట్ చేయవా?
హలో చెక్ 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17.
ఓకే. ఇప్పుడు ఓన్లీ రూమ్ 4ఏనా సుశాంత్? రూమ్ 3కి వచ్చినావా? ఓకే ఓన్లీ రూమ్ 3 కూడా చెక్ చేస్తున్నావు సుశాంత్? ఓకే, నీకు అక్కడ ఏ రూమ్ ఒకసారి కేదార్ చూసుకోవాలి, నువ్వు చూడు.
చెక్ 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 అన్న 3 ERCP 3 హైబ్రిడ్.
నువ్వే వాళ్ళతో మాట్లాడాలి మనంతో.
శివన్న ERCP 3 హైబ్రిడ్.
సుశాంత్
ERCP 3 హైబ్రిడ్.
ఓకే ఓకే
క్లియర్
క్లియర్ నెక్స్ట్
కేదార్ ERCP
4th floor OT. క్లియర్
క్లియర్
4th floor OT.
క్లియర్
స్టూడియో
క్లియర్ స్టూడియోనా? ఓకే, వస్తుంది ఆడియో బాగానే వస్తుంది. అన్నా ఏమైందన్నా?
రాజేంద్రన్న
ఏమన్నా ఏమైందన్నా?
3
ఇచ్చినామా అలాగే?
హైబ్రిడ్ ఇక్కడ వీడియో
వీడియోనా? వీడియో వాళ్ళకి పంపించాలా? ఒక్క నిమిషం, వీడియో స్విచ్ చేయలే.
ఫైనల్ అవుట్ లో హైబ్రిడ్ ఇచ్చా అన్న.
ఇస్తుంది.
ఓకే అన్న, క్లియర్ అన్న, క్లియర్ అన్న.
ఆడియో వాళ్ళకి కింద క్లియర్ అన్నాడా శివ?
క్లియరా?
బాగుంది.
ఆడియో ఓకే, ఓటీ నుంచి ఓకే, ప్లస్ సుశాంత్ ఆడియో కూడా ఓకే నాకు.
అది ఒకసారి అన్న, ఒకసారి ప్రెజెంటేషన్ కూడా చూసుకోండి అన్న. వీడియో అవుట్పుట్ కూడా చూసుకోండి.
వీడియో అవుట్పుటా?
నేను ఇవ్వాలి ఇక్కడ నుంచి.
అర్థం కాలే.
అక్కడ ఆడిటోరియం
ఆడిటోరియంలో
ఫైనల్ అవుట్ చూడు, ఎండోస్కోపీ.
రిషి
వీడియో అంటే చూడు రిషి ఒకసారి.
ఉన్నాడా? తినడానికి వెళ్ళిండు.
హలో ఒక్క నిమిషం అన్న, చేంజ్ చేస్తున్నాను నేను. అది కెమెరాకి ఇచ్చుకున్నా.
లైవ్ 5
ఇస్తున్నా. వస్తుంది, స్క్రీన్ మీద ఇస్తున్నా చూడు.
ఓకే సుశాంత్ కన్వర్ట్.
ఫైనల్ అవుట్ 4
ఫైనల్ అవుట్ లో ఉన్నావు.
ఓకే,
నెక్స్ట్ రూమ్.
ఓకే,
లేవు రెండే 3 and 4.
3 and 4. ఓకే డన్.
ఓకే
క్లియర్.
మోహన్ సార్ ఉన్నారా రిషి?
లేరన్నా.
ఓకే,
యా
అయిపోయినట్టేనా?
రాజేంద్రన్న ఏమైంది ఇది ప్రోగ్రామ్?
ఓకే,
ప్రోగ్రామ్ ఏందబ్బా, నేను వస్తున్నా కిందికి.
అన్న అయిపోయిందా బయటికి?
బాబు లంచ్కి
క్లోజ్ చేయొచ్చా?
కేదార్
క్లోజ్.
లంచ్కి వెళ్ళేసి వచ్చేయండి.
వాల్యూమ్ తగ్గించు.
Good afternoon, one and all. Welcome after a very yummy lunch break for our next academic feast. So I would like to start the session 3 of esophagus, early neoplasia. I would like to call the chairpersons, Dr. Chalapati Rao, Dr. Sanish Ansil, Dr. Vinod, and Dr. Domicilo to introduce the speakers for the next talk.
Good afternoon and welcome back. I would like to request the speaker for this session, Dr. Srihari, to speak on early esophageal squamous cell cancer. Dr. Srihari is consultant gastroenterologist at Gangaram Hospital, New Delhi.
Very good afternoon to everybody. I am extremely grateful to Dr. Mohan and the entire team AIG for this opportunity. I shall be speaking about early esophageal squamous cell carcinoma, focusing mainly on the IPCL classification and how to interpret it in a practical fashion. Of course, I cannot start without my acknowledgement to Professor Vedo, whose teachings have enabled me to understand so much out of this, and I am extremely grateful to him for that. So if you look at esophageal cancers, we keep talking about early gastric cancers, but I think for us as a region, as a country, esophageal carcinoma is extremely common. It's the third most cancer among males in this country. And I think we need to focus on this aspect also. So if you talk of 5-year survival rates for esophageal cancer, in an advanced cancer, the advanced cancer survival rates are hardly 10%. But for early esophageal cancer, if you are able to detect it, it increases to 85%. So when we talk of early cancers, so in the true sense, early cancers are T1A lesions, which are limited to the mucosa, and there is also superficial esophageal cancer, which includes both T1A and T1B, that is lesions which are localized to the mucosa and submucosa. So when we look at the esophageal histopathology, there are something called papillae. So these papillae are basically projections, finger-like projections, which are going up from the lamina propria into the epithelium, right? And so IPCLs are basically the capillary loops which are present within this papilla. So IPCLs are intrapapillary capillary loops. So if you look at the esophageal microvasculature, the vessels start from submucosal vessels, from where arises these arborescent vascular networks, also called as branching vessels, from which you have this subepithelial capillary network, and eventually the third or the fourth degree capillaries are these IPCLs, whose diameter is around 7 micrometer, which is equivalent to that of an RBC. So basically these are such fine vessels where a single RBC can traverse, right? So if you look at it, these vessels on histopathology, these are where they are located. These are the branching vessels that you can see. These are the subepithelial capillary networks that will be visible as such on the histopathology. And the IPCLs will be there right at the top. So these are the smallest capillaries that you can see right on the surface of the squamous epithelium. So if you look at tumor progression that occurs from a stage of normalcy to a submucosal cancer, we all are aware that there's a lot of angiogenesis that goes on. This has been proven by multiple studies where you see all these angiogenic factors going on increasing as the tumor goes on becoming more and more invasive. And this is what leads to a change in the microvascular structure because of the alterations in the angiogenesis. And this is what we intend to find when we try to look for IPCLs. So how do you look for it? We all know that when you use a white light endoscopy, white light has this entire spectrum starting from the violet to the red, and this has deeper penetrations also. So it will be focusing on all kind of vessels, not particularly focusing on the superficial vessels. So we might not be able to pick it up very, very clearly. But when you use a narrow band imaging, you are actually using a blue-green filter. And what this does, the blue-green light only goes to the more superficial layers, and it enhances the visibility of these superficial layers. So the blue light, when it enhances the IPCLs, it is reflected as a brownish colored light, and the green light, when it reflects from the more deeper vessels, which are usually the subepithelial capillary networks, they are reflected as a bluish kind of a tinge of light. So when you have done an NBI or a magnification NBI, you will start appreciating these structures. Like the branching vessels are the deeper ones, which are the bluish appearing larger vessels that you can see at the bottom. Then you have the subepithelial capillary networks, which are arising like an arborizing fashion from here. And at the end of that, you will have these intrapapillary capillary loops, that is the IPCLs, which we try and characterize when we do especially a magnification NBI. So how does this help us, right? So when you are doing an endoscopic diagnosis, it involves two steps. The first step is the detection, and the second step is characterization. So characterization involves both differentiation of that lesion into a carcinoma versus non-carcinomatous lesion, and the next step also involves the staging if it's a cancer. So we are able to perform all these functions by just looking at the IPCL patterns, right? So how do you detect an early esophageal squamous cell carcinoma? On a white light endoscopy, when you do white light endoscopy, look out for these reddish areas. So look out for these reddish areas where there's a disappearance of background vascular network. The same correlate on a non-magnification. We are talking of a non-magnification NBI. You will see these demarcated brownish area. So on white light, it's a reddish area. On NBI, it's a brownish area. And this shows us a fair sensitivity and specificity to demarcate a lesion. Why does this lesion appear brownish? So it's a brownish demarcated area. Why it appears brownish? Because it is thought that there is a thinning of the overlying keratinous layer of the squamous epithelium, which gives it a brownish hue. So you'll see a typical brownish area on NBI. Then you go to characterize and staging, and this is aided by doing a magnification NBI. When you start doing a magnification NBI, you start seeing these IPCLs in a much more detailed fashion, and then you look out for the morphology of these IPCLs. So when you look at the morphology of IPCLs, initially there was this Inouye's classification, which gave us these different types of IPCLs, starting from type 1 to type 5, and then these type 5 were again subclassified. So basically type 1 to type 5 were indicating a sort of characterization, whether we are dealing with a normal IPCL or that with an inflammation or that with a neoplasia. And once it is neoplastic, it could be subclassified to find out about the staging based on the subtypes. But then this appears quite complex usually for the beginners, and especially the problem lies when you have to differentiate whether it's an esophagitis, whether it's an inflammation or it's a malignancy, because many times these IPCLs tend to appear similar. So it's very difficult sometimes to differentiate between an inflammatory lesion versus a neoplastic lesion. What is more important to understand is that as the lesions go on progressing, you go on from dilatation of the IPCL patterns to more tortuosity, to more change of caliber, to change into a non-uniform structure. So from one structure to other. So this is the grade of hierarchy that you're looking out for, right? So the highest grade would be a non-uniformity in the structure. So now we have the JES, Japanese Endoscopy Society classification, which has made it much more simpler. So for type B1 vessels, you will need all those 4 characteristics that we discussed to say it's a B1 vessel. If it is not all 4 of those characteristics, it stands as a type A vessel. So let's look at these B vessels. So B1 is a B type vessel with a loop formation. So when you see these kind of IPCLs, you are probably dealing with a T1A lesion, which is restricted to lamina propria at the most. If you see a loss of loop, so initially you are seeing a looped pattern, now the loops have opened up. So this is probably a T1A or an early T1B lesion with a good sensitivity and specificity. And if you see a thick greenish vessel, so greenish vessel, remember, previously we were seeing brown vessels. Now it's a greenish vessel. So greenish is, it's a deeper vessel. The diameter of this vessel is at least 3 times that of the original B1 vessels. So these indicate that we are dealing with a much deeper lesion, which is usually more than a T1B or a deep submucosal tumor. So the JES has made it pretty simple for us to identify these patterns. So I think we should all use that. There is also this concept of an avascular area, which was published by Dr. Arima's group, where they have tried to see for the size of avascular areas, but here again you would also try to see the vascular structures in the surroundings. So when you have appropriately characterized these lesions using the JES classification and so on, you can actually make out how the stage of the esophageal cancer, and that is very useful because that will help us in determining what would be the right treatment strategy for this lesion. So ladies and gentlemen, I think the take-home message from this should be that to diagnose and triage early esophageal squamous cell carcinomas effectively, we all need to understand and know the IPCL patterns. Thank you so much.
So that was a wonderful talk by Dr. Srihari. Now I would like to invite Dr. Amit Datta to give a talk on Barrett early neoplasia, recognition of flat and subtle dysplasia. We will have discussion at the end of this.
So good afternoon, and first I thank Dr. Mohan and AIG team for inviting me. So I'll be speaking about Barrett's, how to detect early neoplasia and dysplasia. Okay, so essentially we know what is in Barrett's. What happens is that the stratified squamous epithelium, it changes to columnar type, and the main reason being gastroesophageal reflux disease. The clinical importance of Barrett's lies in the fact that some patients of this metaplasia can progress to dysplasia and adenocarcinoma. So these patients carry a risk of developing adenocarcinoma, and therefore these patients have to be kept on a surveillance. The diagnosis, obviously we all know, if you see a salmon or pink colored mucosa above the G junction, you take a biopsy. If it shows metaplasia, then it is Barrett's esophagus. And the risk of progression to neoplasia depends on what the background lesion is, and it increases from normal no to low grade dysplasia, high grade dysplasia. Now why is Barrett's important in Indian context? I'll tell you, because if you look at the esophageal cancer per se, it is the among the top 10 sort of causes of cancer cause as well as mortality. Actually, to be exact, it's number 6 in terms of mortality of cancers in India. And 25% of these cancers are adenocarcinoma. And we know Barrett's is an important precursor of adenocarcinoma. And also when I looked at the literature from our country, about 15% of patients who have GERD actually have Barrett's. So Barrett's, like, we think it's infrequent, but actually it's there in our patients, and we have to look carefully for Barrett's. So coming to my main topic, that how do we detect this flat and subtle neoplasia? So there are 3 things to remember. First is, if you want to detect early lesion, then the patient obviously will not be symptomatic. So it has to be some sort of a surveillance or a screening. So you have to do surveillance for these patients, and there are different protocols which we have to follow for surveillance. At surveillance, you do a good assessment with a white light first, and after that you apply image enhancement with narrowband imaging, and that actually will further improve the detection of dysplasia. So surveillance, a good white light assessment, and then you go for an image enhancement with NBI or other techniques. I won't go into details of what is the protocol for surveillance. We'll move straight away to the assessment using endoscopy. So when you're doing a white light examination, obviously you have to clean the mucous surface of any debris or any fluid, and then look at all the landmarks, the C line, the C and the M extent actually, and then look for any elevation, any depression, any nodularity. These are subtle things which will tell you there is a presence of some dysplasia in that area. So any of these irregularities like elevated area, depressed area, nodularity will point towards some sort of this thing. Also remember one point, that if somebody is having active esophagitis, then in that situation, surveillance becomes difficult. So therefore for those patients, they say you should give PPI, heal the esophagitis, then do the surveillance. Now in white light endoscopy, the recommendation is that you take 4-quadrant biopsy every 2 centimeter. This random biopsy, the problem with this random biopsy is that you may or may not hit the dysplastic area. So there is a chance that you will miss a dysplastic area, as has been shown in the literature. So therefore we need something else which can tell us directly where the dysplastic focus lies. So in real time, we want to see where the dysplasia is, and that's where image enhancement is going to help us. In fact, if you look at the ASG technical committee, they have approved NBI as a method of detecting dysplasia. It has got good sensitivity and specificity. There are different classifications for this one, whichever one we can use, whichever we want. But if you look at what these classifications are telling you, there are two things. That you look for the surface and the vascular pattern. The surface pattern in Barrett's can be different. It can be a tubular, it can be villous, it can be, so there's no one type of pattern in Barrett's. And also the vascular pattern can be different. The key thing for dysplasia is to look for irregularity. That's what all the classifications are telling us about, that if there is an irregularity present, then you suspect a dysplasia. It can be a irregularity of surface or irregularity of the vascular pattern. So whichever classification you want to use, but the key thing they are telling you is to look for any irregularity. So I'll just show a quick video about how to assess for dysplasia in using NBI. So first you do an initial white light assessment, clean the mucosal surface of debris, examine with white light, look for any elevation, depression, nodularity, etc. And then you go to the narrowband imaging mode. Now remember, you should have a cap for this, because without a cap, you will not get a good clear in-focus vision. So cap is essential for doing examination of the G junction and Barrett's. And then you should have some sort of a systematic approach. How do you, so that you examine the entire area. So it can be either a quadrant-based examination, it can be a circumferential, but each area you should examine and look for any irregularity in pattern, whether it's surface pattern or a vascular pattern. And obviously, sometimes we have patients with long segment Barrett's, and long segment Barrett's, you know, is a higher risk of neoplasia or dysplasia. So here again, if you just have a white light assessment, you'll just see something like a plain, similar looking mucosa everywhere. You don't get much detailed idea about what's on the, but once you switch to NBI, you can see so much more. You can see the vessel so clearly, surface pattern so clearly. So it's much easier to pick up a dysplasia in this image than a plain white light assessment. So therefore, assessment again, white light assessment followed by NBI, have a systematic approach, either quadrant wise or circumferentially. Look for any irregularity of surface or vessel to pick up dysplasia. This is one of our cases where Barrett's, again you can see this is a white light assessment. We have done NBI, this is a normal focus, a near focus. In the near focus you can see the patterns are all regular, so in this person there is no dysplasia. Another case, patient we saw some time ago, this is a 70-year-old male patient, he didn't have any symptoms. Basically he came for surveillance endoscopy for Barrett's. This is the white light assessment. We switch to NBI, this one area looks all regular pattern, another area also pattern is quite regular. But if you look at this particular, there's one small focus where there is irregularity. And this is the area when we biopsied it came as dysplasia. So as you can see in this particular case, that it's such a small focus of dysplasia is very difficult to detect on a white light, and probably this patient you'll call him normal. Also random biopsy may not pick up this particular area. Another patient, again a known case of Barrett's, is undergoing surveillance endoscopy, no symptoms as such. This is the NBI, and you can see there's a depressed area next to the Z line, and this area when we examine more carefully we see there is irregularity present in this. So as you can see, they can be so subtle. One small focus can have this type of an appearance. The remaining area can look entirely normal. So if you're not aided by image enhancement, you may miss these lesions in your practice. Another patient, this patient again case of hiatus hernia, Barrett's esophagus, known case of Barrett's, and he's come for surveillance. Now in him we can already see there is a nodule on the white light itself. Now let's see what happens when we examine this nodule with the image enhancement. So first obviously white light, we picked up the nodularity. And then once we assess this area, we switch to the NBI image mode. And on NBI, as you can see, if I just freeze the image here, that pattern in this area looks quite okay, but the top area there is a lot of irregularity. The entire thing looks like a one nodule on white light, but probably if you want to pick up the dysplasia, you have to hit this area with your biopsy. So you can very clearly see there's a demarcation here, there is irregularity of surface and vessel in this area. This is again a patient who had a nodule, and there was this. In fact, this came out to be actually a carcinoma in this particular patient. But here again, the diagnosis, we could see nodularity, but where to target biopsy is what was critical, what the image enhancement helped us in this particular patient. Another patient, again, a patient with Barrett's, he was planned for a surveillance endoscopy. Again, nodularity on white light assessment, which came to be a neoplasia. Now, these lesions are actually visible even on white light, and you can take biopsy. So again, just impressing upon the need for surveillance in these patients, because I think we have the feeling that there's not much dysplasia in our patients, but if you look carefully, you will find patients with dysplasia. Another patient with a long segment Barrett's, one of our patients, you can see on white light everything looks okay, but NBI there's one focus where the vessels are quite irregular in this particular. So we can target that area for biopsy rather than randomly targeting some area which may or may not include this irregular area. So just to sort of give you the evidence, there's enough data available in literature which says that if you use image enhancement in Barrett's with NBI or any other modality, then your pickup rate for dysplasia actually improves quite well. So the benefits are two. One is that you pick up more dysplasia, and second is you need a fewer number of biopsy samples for such this thing. Just want to touch upon acetic acid chromoendoscopy also, which has been found to be useful as well for detecting dysplasia. So if we don't have NBI, we can probably, personally I don't have any experience using this technique, but when you spray acetic acid on a Barrett's, it becomes white. It's called acetowhitening. And then when there is a neoplastic focus, there is early loss of acetowhitening. That's what it's called. Early loss of acetowhitening will suggest there is a neoplasia, as you can see in this particular picture, that this area there is erythema because of loss of acetowhitening. And obviously a lot of work, because in NBI we are seeing a lot of information on the mucosa. There is the vascular pattern, the surface pattern. As I told you, surface pattern can be of different types, vascular pattern can be of different types. So it obviously becomes too much to interpret, and I think at some point we'll need the help of AI. Work is going on in this area, but as of now it's not ready for clinical use, but we probably in future you may have AI assisting us in detecting neoplasia. So I just want to sort of say two messages from my presentation. First is that please look for Barrett's in your patient when you're doing an endoscopy, because Barrett's is there. Also, among the 5 cases which I showed you from our center, in 2 patients it was visible on white light, but in 3 patients there was nothing much seen on the white light. So if you only apply white light, probably you're going to miss half your cases of dysplasia. So again, you look for dysplasia, and for these patients, where you pick up an early lesion, it makes a big difference in terms of their long-term outcome. Thank you for your attention. Yeah.
Thank you for the wonderful presentation. Maybe we have just the time for one short question, if, some of the audience. I wanted just to do a small question about the IPCL classification. Should we report it in order to give a standardized report, just in case the histopathologist will be negative and we have to do a second biopsy? Do you think it's important?
So I think looking for abnormal IPCLs and taking directed biopsies from the suspicious areas would definitely be recommended. I think it should be especially be screened in patients who are high risk for developing squamous cell carcinomas. If not for everyone, at least for the high risk groups, yes.
Should you write in the report, so just in case the histopathology would be negative?
Definitely.
Yeah.
Dr.
Thank you.
Just one comment which can help with picking up dysplasia, especially in the esophagus, is a simple technique where you go in with white light and you withdraw with narrowband imaging. So in that way you have 2 different modalities to look at the esophagus, and that in itself may allow one to pick up more squamous type lesions or even Barrett's esophagus. So that's one technique which can be easily implemented in day-to-day practice.
Okay, thank you. Time is running.
I have a question. See, we see the IPCL pattern as abnormal, and we take a targeted biopsy. If the biopsy turns negative, what should be one's approach?
So I think that's a pretty common situation, especially if there is a doubt between an inflammatory lesion versus a definitely malignant lesion. That happens quite frequently. If it is negative, then I think this patient should be followed up closely. Adding on iodine chromoendoscopy might also be useful in such cases. There you see for Lugol's voiding lesions, but you also see for the typical pink color sign. So if you have a pink color sign, it's very highly likely to be a malignant. So I think you can add on to that.
So given the complexity in diagnosing these lesions are increasing day by day, do you see any role of AI in coming future?
I think yes, definitely. I think it will make things much more easier for us. So the studies show that between an expert endoscopist and AI, the pickup rates might not be very different. But for peripheral centers, especially if used as a screening protocol throughout, maybe AI will really be useful in picking up lesions across.
I think for characterization, I still think AI is far away. Detection probably, but characterization, I think, because there's so much of variations in the what patterns you see, it will be not easy to train an AI on the different variations actually. But for detection probably, but I think characterization will take really, I would say, a time to get there.
So Dr. Amit,
Thank you. Yes, sir. Thank you, Dr. Srihari and Dr. Amit Datta, for a wonderful talks, and thank you, our chairpersons, for moderating this session. I would like to thank and invite the other set of chairpersons, Dr. Zahir Nabi, Dr. Vaneet Jitiye, Dr. Vishwanath Reddy, and Dr. Sumit Rungata for the next session on stomach, precursor lesions to early cancer. I also request them to introduce the next speaker.
So we welcome Professor Nouria Vidu. He needs no introduction, and will proceed with his talk, Optimal White Light and Image Enhanced Endoscopy of Stomach. So this is, I think, will be the talk of the day, because this is this makes the job easier for further management and surveillance.
Okay. Thank you. This time I'm talking about optimal how to assess gastric mucosa by white light and image enhanced endoscopy. I think it really improved the knowledge or recognition of mucosal changes caused by H. pylori infection. So why it is important to recognize gastric mucosal atrophy or intestinal metaplasia? Because it is associated with risk of gastric cancer. I think, as Mohan mentioned, that usually gastric cancer does not really develop immediately. So it usually develops according to the subsequent mucosal changes of, on the background of subsequent mucosal changes of atrophy or intestinal metaplasia. So this is histological changes caused by H. pylori infection. Neutrophil infiltration or monocellular inflammatory cell infiltration, and reduction of the gland atrophy, and then replacement of the gastric glands by intestinal glands. So these change, especially atrophy and then intestinal metaplasia, is strongly associated with the risk of development of gastric cancer. So initially, we want to learn the anatomy of gastric mucosa. So mainly it consists of two different parts of mucosa. So corpus mucosa and antral mucosa, pyloric glands and fundic glands. So both mucosa is covered by foveolar epithelium, and then on the basal layer of the mucosa there is pyloric glands and fundic glands. And the fundic glands is usually much thicker than the pyloric glands. So such a very thick gland is very folded like this. This is normal gastric mucosa. Normal means mucosa without H. pylori infection, neither atrophy or neither intestinal metaplasia. And such fundic mucosa has many vessels, vascular-rich glands. So the color is homogeneously reddish like this. And when you get closer, you can see these spider-like vessels. This is called collecting venule. And so this is a normal mucosa. Thick corpus mucosa is folded, fundic mucosa is folded. And then when we switch to NBI with magnification, we can see the very regularly arranged round crypt orifices and network capillary that surrounds this crypt orifice. So this is a normal corpus mucosa. So round regular crypt orifice which is surrounded by network of capillary. And when H. pylori infection develop, and then atrophy or intestinal metaplasia is caused, this thick fundic mucosa becomes thin, and then replaced by intestinal type mucosa. So this thick fundic mucosa has a reduction in growth, so mucosal height becomes low, and then loss of vascular-rich fundic gland can cause very pale color of the mucosa. And then it increase, thin mucosa increase transparency of the light. So we can see the increased visibility of some mucosal vessel. So usually atrophic mucosa is characterized as a increased vessel visibility with lost gastric folds and pale color of the mucosa. And when we evaluate extension of this mucosa, we can, this extension of the mucosa is also associated, atrophic mucosa is associated with the risk of development of gastric cancer. And when we explain about the mucosal microstructure, as I mentioned, normal corpus mucosa has a round regular pits surrounded by network capillary. But when atrophy or intestinal metaplasia develop, such mucosa become little bit biliform or ridge-like surface structure. And when it is intestinal metaplasia is developed, we can see white color of the mucosa in non-magnifying NVR image, and this light reflection on the surface of the epithelium caused by brush border expressed in an intestinal type mucosa. So, for example, this is corpus mucosa. So, atrophy is usually predominantly developed in a lesser curvature side in H. pylori associated gastritis. And somewhat like a mucosal, atrophic mucosa and non-atrophic mucosa exists in a patchy, showing patchy distribution like this. So, in patients with H. pylori associated gastritis with intestinal metaplasia, the mucosa looks biliform, while normal corpus mucosa has a round regular pits, but the mucosa with atrophy or intestinal metaplasia showing this biliform or ridge-like shape. And then, as I mentioned, some non-metaplastic mucosa and metaplastic mucosa exist multifocal or mosaically distributed. So basically pathologists already reported such kind of changes of gastric mucosa. So H. pylori associated gastritis is defined as a multifocal atrophic gastritis. Inflammation is caused in whole entire mucosa, but usually atrophy or intestinal metaplasia develop multifocally patches in near the glandular border, and then eventually increase the proportion and then replace the normal corpus mucosa. So that is a characteristic distribution and progression of H. pylori associated gastritis. And how about another etiology of atrophic gastritis? So another etiology is autoimmune gastritis. And pathologists explained or reported that usually autoimmune gastritis causes inflammatory infiltration to only oxyntic mucosa. And it causes diffuse atrophy, but the minimal changes of intestinal metaplasia. And previously, we compare the endoscopic finding between H. pylori associated gastritis and autoimmune gastritis. We found that H. pylori associated gastritis usually mucosal atrophy develop in a lesser curvature dominant distribution, while autoimmune gastritis cause very diffuse atrophy. And when we look at the micromucosal structure, we as I explained, usually H. pylori-associated gastritis, there's a mosaic distribution of intestinal metaplasia and non-metaplastic mucosa. And we found that even its extensive atrophy, but the surface mucosa structure is quite similar to normal corpus mucosa. And when we take histology, as pathologists reported, H. pylori-associated gastritis has atrophy and also intestinal metaplasia. But autoimmune gastritis shows significant atrophy, but the intestinal metaplasia is not so significant. So I want to show the example of autoimmune gastritis. So mucosa lost gastric folds and then increased visibility, and the color is pale. But when we look at the NBI magnification image, it's quite similar to normal corpus mucosa, regularly arranged cryptoriphies and network of capillary. So probably, usually H. pylori-associated gastritis, H. pylori colonize to the surface of epithelium and then cause a surface layer dominant inflammation, and then replace the epithelium into intestinal metaplasia. And usually this develop multifocally. While autoimmune gastritis, autoimmune antibody attack the glands, not the epithelium. So it shows a basal layer dominant inflammation, but the surface epitheliums remain intact. So I think endoscopic finding can differentiate such kind of etiology. And the patient with atrophic gastritis require surveillance endoscopies. So recognition of mucosal atrophy, intestinal metaplasia, it's important to identify high-risk patient. Mucosal atrophy is seen by white light endoscopy as a pale color, lost gastric folds, and NBI enhanced detection of gastric intestinal metaplasia. Image enhanced endoscopy distinguish different etiology of chronic atrophic gastritis. Thank you.
Thank you very much, sir. We'll have the questions at the end of the session. The next speaker is Dr. Ashutosh Mahapatra. I think he is well known for his passion and proficiency in finding out early gastric cancer, and we'll hear from him about the same topic.
I must thank Dr. Mohan and AIG team for giving me an opportunity. So, my talk has been made easier or my talk has been made easier or more difficult, you can imagine, because I am giving a talk after stalwarts like Professor Noria and Dr. Mohan. So it has been, I don't know what to describe, because they have told everything about early gastric cancer. So learning objectives, how to perform a high quality endoscopic examination, and what are the key endoscopic features, and what are the indications for ESD. Always I show this slide because Dr. Noria taught me for continuously for 10 years, almost like 8 or 9 years, how to detect early gastric cancer. I can take one more minute because there is some technical glitch.
Can I close it?
Huh. So everybody knows it is the SSS protocol.
Can you open the PPT?
Which one? No. Where? I don't know. No. I don't know. Salman, can you help me? Where is the PPT?
Where is the PPT?
PPT था यहाँ पे है, यहाँ पे है.
This one?
Okay, it's coming.
Where is the PPT?
In extend mode, sir. One second, sir.
This is it's coming. So extremely sorry. Okay. So let me skip these slides. So in my 11-year practice, my EGC detection rate was 0%. I visited Dr. Noria for a considerable time. So I am not going into the details, but my favorite is SSS protocol. I think it looks difficult, but you should practice SSS protocol every time. Now you can see the bubbles obscuring the antrum. So this is important because you have to wash off the bubbles. Now this is mucus covering an EGC. This looks simple, like mucus, I do not want to wash. You have to wash your hand, otherwise you are in problem. So this is SSS protocol. What is more important, you should have a thorough knowledge of background mucosa. Dr. Noria has already explained what are these. Unless you are aware of these features, you are not going to get early neoplastic lesions. The next important point, remember two things to detect early neoplastic lesions of the stomach. One is color, second is surface. Color should be or can be reddish or whitish or pale. Surface, that is mucosal height, can be just irregular, little irregular, you should be suspicious, and spontaneous bleeding. Remember, all these images are of early gastric cancer, published in Den Open. All these are early gastric cancer images, and thickened or irregular fold or disappearance of vascular network. Coming to demarcation line, once you find a suspicious lesion, you should find demarcation line. What is demarcation line? This is very important because if there is an abrupt change in vascular pattern, microvascular pattern or microsurface pattern, that is called demarcation line. Gradual change is not a demarcation line. Then inside the demarcation line, one should search for irregularity of microvascular pattern and irregularity of microsurface pattern. If any one of these present, you can tell with 95% accuracy that you are dealing with a case of EGC. Of course, there are limitations like for undifferentiated cancers or contact bleeding. So this is one of our patients. Can you say what is it? This looks like a depressed lesion, but look, here is a clear demarcation line, but inside the clear demarcation line, the microvascular pattern and microsurface pattern is regular. So this is non-neoplastic. Got it? What is a demarcation line? Next comes, looks pale, pre-pyloric mucosa. Look at the 12 o'clock position. Looks normal mucosa, but look at magnifying NBI. So my favorite is always zoom endoscopy. Sometimes I do not agree with my teacher. So I always perform zoom endoscopy. So this is again a neoplastic lesion. So white light you can suspect, but for characterization always NBI, and if magnifying NBI, that's good. So we published our paper with the help of Professor Noria, Dr. Mohan, and of course Reddy sir, Goenka sir, Dr. Sonmun is there here. So we got 8 early gastric cancer in a period of 6 months. So who says in India early gastric cancer is rare? It is very common. Probably there are some geographical variation in our state. It's like almost similar to Japan. So this is a okay, it's running. No. Oh. Okay. I'm not computer savvy in 2021. So this is a nodular lesion. Can you tell? is it differentiated or undifferentiated? So always describe in white light. There is a nodular lesion, elevated lesion. With 97% specificity, you can tell that this is a well differentiated cancer. So any lesion that is elevated and reddish, take home message is well differentiated cancer, not undifferentiated. So here inside the demarcation line there are irregular microvessels. So ESD was done, R0 resection was achieved. So Professor Nauria, I have shared this image with you. Anybody from the audience who can tell where is the early gastric cancer? Or because I am showing an image, that does not mean that it contains early gastric cancer. Now look at the image. So on chromoendoscopy, NBI didn't help much. So on chromoendoscopy, there is a spiny edge with reactive elevation. This shows that this is a well differentiated cancer. So any pinpoint erosion, suspect early gastric cancer unless proved otherwise. Who can tell where is the lesion? Again, this is difficult, very, very difficult. Looks normal to the even to the expert eyes. Look at the magnifying NBI image for a few seconds, pause, put your NBI, not only NBI, always use magnifying NBI, always use a zoom endoscope. So this is the cancer. So next time you will tell, yes, I am a fan, you should be a fan of zoom endoscopy. Can you say, where is the lesion? This is a very old slide. Anybody? Okay, this is less than 1 millimeter lesion is the early gastric cancer. So early neoplastic lesions, always do a chromoendoscopy if it is a pinpoint lesion. And if in chromoendoscopy you find a spiny edge, this is characteristic of early neoplastic lesion. So ESG was done, no residual cancer was involved. Again, so nodular lesion, I told you, who can tell the diagnosis? Any nodular elevated lesion, if it looks whitish, then reddish, then it is well differentiated. If it is a pale mucosa without elevation, then you suspect undifferentiated. Here there are white opaque substance and diffuse oozing of blood. And this white opaque substance is also irregular in nature. So this, you can see the microvessels inside the irregular microvessels, and there is almost loss of surface pattern inside the demarcation line, except oozing of blood. So sometimes absence of microsurface pattern with demarcation line, you can diagnose early neoplastic lesions of the stomach. So these are my few slides. I think I can finish before time. This is very important. You should assess from the color and the surface. You should look whether it is slightly reddish color or whitish. Initially, this patient was referred to us for EMR of a gastric nodule. But my colleague Dr. Sonmund told this might be an early gastric cancer, so we should evaluate it thoroughly. Then she did ESD. So what is the depth of invasion? Whether endoscopic resection versus surgery? How can you say well differentiated or undifferentiated from imaging? So take home points very clear. Always look for red or pale mucosa. When you find an EGC, you should first be risk stratification, detection, then characterization, then you should go for resection. So the rate of lymph node metastasis increases with the diameter of the lesion. I think I have finished before time. Thank you so much, Dr. Mohan and Dr. Nauria, for teaching me how to diagnose early gastric cancer.
Thank you, sir, for the excellent talk. Now I would invite Dr. Nauria, and we would open this for discussion now.
Excellent talk for both of you. Thank you very much. Dr. Noria, so you said that atrophic gastritis, especially associated with autoimmunity, are not associated with the intestinal metaplasia. But we see autoimmune gastritis converting into cancers also. So which pathway they follow? This is atrophy, but there is no intestinal metaplasia.
So, good question. So, probably our study included little bit younger patient compared to H. pylori-associated gastritis. So, most pathology reports show that even if autoimmune gastritis become very end stage, still intestinal metaplasia develop. But previous Lawrence classification, according to histological type of gastric cancer, there's a two phenotype for mucin phenotype. Gastric gastric mucin phenotype and intestinal mucin phenotype. And most of the autoimmune gastritis, gastric cancer is gastric mucosal phenotype. So it's not really associated with the H. pylori infection always cause the mucosa toward intestinal phenotype, intestinal metaplasia or intestinal type gastric cancer. But still gastric phenotype cancer can be developed.
But we see a lot of neuroendocrine tumors in autoimmune gastritis.
I think neuroendocrine tumor little bit different carcinogenesis. But according to epithelial neoplasia, gastric cancer, that is a difference. Yes.
Sir, any difference if intestinal metaplasia found in the antrum and another one found in the fundus and the body of stomach? Any difference? Endoscopically?
Endoscopically, probably antrum usually whitish traditional finding like a whitish pale elevated lesion, while gastric intestinal metaplasia in the corpus is more like a reddish or sometimes depressed or very flat lesion. So,
sir, apart from loss of connecting venues, any other H. pylori gastritis feature on endoscopy, Zoom endoscopy?
Please say it again.
H. pylori gastritis, you frequently found the loss of connecting venules. And apart from these feature, any important feature to identify H. pylori gastritis without taking biopsy on endoscopy, because it's a very important.
You mean H very low
He is
risk?
asking about H. pylori features of endoscopic features of H. pylori, nodular gastritis, diffuse redness, hyperplastic polyp. These are the telltale signs of mucus covering the whole of the stomach. These are the findings of H. pylori infected stomach.
But I think the most endoscopy finding or histological finding associated with negative gastric risk is regular arrangement of colic venom. Because it indicates H. pylori naive gastric mucosa. And also most significant high risk finding is atrophy, mucosal atrophy, Kimura Takemoto, pale, lost gastric for increased visibility of vessel, and then intestinal metaplasia. Yes.
Thanks, Noria and Ashutosh for very nice talks. So congratulations. I've got a very simple, practical question to ask you. With the advent of a lot of NSAIDs now, plus H. pylori on board, in routine endoscopy, we inadvertently come across erosions and ulcers. Okay, so some ulcers or erosions, the central part is covered with slough. So you're unable to see the pit pattern and the vascularity. So can you tell the audience, what is your algorithm in looking at these erosions and ulcers? When do you decide you're not going to biopsy and you're happy with what you see? Or when you're going to decide, okay, I'm not really sure, I'm going to take biopsies?
So usually we evaluate morphology. Like Ashutosh said that usually neoplastic depression is even central part is covered with mucus or granulation tissue or something. But the peripheral shape is more spiny like shape. That is more suspicious for neoplastic depression or erosion. And also the distribution is really solitary or isolated. That is also increased suspicion. So some morphological assessment can help. And also if you apply magnifying NBI, even the central part is covered with mucus of regenerative granulation tissues. Still some in the periphery, still characteristic finding of NBI finding, like a demarcation line and irregular vessels. So that is my differentiation point.
Thank you, sir.
Excellent.
Thank you for the nice talk. I think time is up. We will proceed for the next session. Thank you all.
Thank you everyone. So moving on to the next session quickly, I invite the next chairpersons, Dr. Yogesh Shastri, Dr. Ravindra Gade, Dr. Sonam Mathur and Dr. K. Pandurangarao. Kindly invite the next speaker.
So let's continue with the next session. So it's stomach precursor lesions to early cancer. I'll invite the next speaker, Dr. Sunmun Mahapatra. She is a rising star expert in third space. So please, Dr. Sunmun.
Good afternoon, everyone. I would like to thank Mohan sir and Zahir sir and the entire AIG organizing team for this excellent opportunity. So my talk today is on gastric subepithelial lesions. So today we'll learn about how to recognize gastric subepithelial lesions endoscopically and when to sample and when to avoid sample and how to manage it. So in brief, subepithelial lesions, they are identified as smooth protuberances with normal overlaying mucosa. They are relatively uncommon and are found incidentally. The majority are less than 2 centimeter and they represent a broad spectrum of histologic entities ranging from mesenchymal tumor, that's the majority, followed by pancreatic rest, then carcinoid, etc. One thing to know is most of this tumor, they are benign and only less than 15% are malignant at the time of presentation. So what are the factors that really influence the decision making in managing these lesions? So first is the presence of symptoms and then the malignant potential and patient-related factors also play a very significant role, particularly the emotional burden associated with this diagnosis, especially the possibility of a malignancy, increase in lesion size and risk of complication, and finally, the endoscopist experience. So coming to presence of symptoms, so mostly they are asymptomatic, but they can present with dysphagia, especially if they are in the lower esophagus or GE junction, bleeding, abdominal pain, and also large tumors can cause gastric outlet obstruction. Then coming to the malignant potential, again, not all gastric subepithelial lesions, they carry the same risk. Some like lipomas, pancreatic rest, they are truly benign, whereas there are lesions like neuroendocrine tumor, high-risk GIST, they are malignant, and therefore early diagnosis and treatment of these lesions are crucial. So coming to how to evaluate for malignant potential. So there are several techniques that has been described: bite-on-bite biopsy, US guided tissue acquisition, unroofing or mucosal incision associated biopsy, endoscopic resection techniques. So among them, the bite-on-bite biopsy, they have the lowest yield. So they shouldn't be performed in each and every case. And they are helpful if the lesion is originating from the second layer, like present in deep mucosa, like neuroendocrine tumor, some of the cases of inflammatory fibroid polyp, but they are not at all helpful if this is a GIST or pancreas rest or leiomyoma. So they should be avoided because they can complicate the endoscopic resection if further plans. So this is one of our multi-center study from the United States on outcome of STIR that was recently published in GI Endoscopy. It highlights some of the important finding on tissue acquisition. So there are 51 lesions, 47 patients. So of these 51 lesions, the sampling was performed in 82% of the cases, and majority had US guided sampling. And as you can see, the mucosal biopsy was non-diagnostic in all cases. But remember, the lesions are chosen which were originating from the fourth layer. And then this US guided biopsy was 86% diagnostic. However, submucosal fibrosis was present in nearly 20% of the cases. So this submucosal fibrosis, what happens is they can predict the transmural resection, and that is not necessarily increase the rate of adverse event, but it can increase the procedural time and the risk of R1 resection. So just be careful if the lesion needs to be removed anyway because of high clinical suspicion for GIST or associated symptoms or patient preference over ongoing surveillance. So it's best not to perform any sampling and directly proceed to endoscopic resection. So coming to what are the endoscopic features that to focus with SELs? So location, size, shape, color, surface, mobility, consistency. So these things helps in narrowing down the differential diagnosis. So for example, surface. If there is dimpling umbilicus opening, they represent pancreatic rest. And if there is ulceration, they could be malignant. Coming to mobility, pillow sign, it's represent either there is air or the fluid or fat in the lesion. So it's specific for lipoma, and there is rolling sign, and if that's absent, then probably there is a wide attachment to MP or ulceration or fibrosis. So coming to the endoscopic resection or management, so it largely depends on the size of the tumor, the depth of invasion, the access and availability of the expert and cost. So if the lesion is small size, like less than 20 millimeter and arising from second or third layer, EMR can be performed, but they do have a high risk of incomplete resection. So ESD is a better option, and it's also ESD can be done if there is a narrow MP attachment. That helps. If the lesion is originating from fourth layer, then either STIR or EFTR, and EFTR can be exposed or non-exposed. Non-exposed means using an FDRD device. I'm not going to dive into details about EFTR today because tomorrow we have talks on that. So coming to some of the cases, so this is a 37-year-old male who had this reddish nodular lesion at the pyloric ring. So US was performed, and it's an hypoechoic lesion, 15 millimeter, predominantly in the deep mucosa. Muscle layer was free. Therefore, we thought ESD was feasible in this case. So ESD was planned. So this is the lesion. So after injection, I did the submucosal incision at the pyloric end, and you can imagine there is a lot of blood vessels there, but after coagulating them and I applied traction here, the rubber band traction, it clearly exposed the tumor here. So there is no muscle attachment at all, so ESD was sufficient for this tumor, and this was removed unblocked, and the final diagnosis was neuroendocrine tumor with negative margin. So this is another case, a 35-year-old female. So she was referred to us. The CT showed this is an enhancing lesion. So around 12 millimeter with an erosion on the top, probably from biopsy that we thought. And we performed EUS, and as you can see, the lesion was heterogeneous and deeply adhered to the MP. So I approached this lesion with a pocket creation ESD, and you can see here the tumor is deeply adhered to the muscle. So separating this tumor from the muscle was a bit challenging, but was successful. So here I was cutting fiber by fiber, separating the tumor from the muscle. So after separating it, I was also prepared for an deeper margin resection, but there was a little bit of superficial attachment that was cleared. So that's the tumor in the pocket, and then I removed it with ESD and closed, and the final diagnosis was pancreatic rest. So this is another patient who had this lesion in the posterior wall of the mid-gastric body, so suspicious for GIST. I didn't take biopsy because I was prepared for stir. So after injection, like 2 centimeter proximal, so a mucosal incision was performed, and that's the tumor deeply adhered and into the muscle. So I had to remove it, fiber by fiber, enter the subserosal space because the tumor was extraluminal as well. So here you have to be very careful not to breach the tumor capsule because that can cause tumor spillage. So after detaching it from the serosa and the muscle, so the tumor was completely resected, unblocked, and that's the site of the area where there is a serosa you can see outside. There was no air leak or anything, so that's the advantage of stir here. And there is little bit of, that's the just final diagnosis, and it was R0 resection. So the coming to if stir is feasible in the stomach, because everybody thinks it's just a straight path, it's feasible only in the esophagus or cardia, but there our study has showed that it's possible in almost every part except the fundus. Coming to conclusion, subepithelial lesions, they are commonly found in upper GI endoscopy. Initial endoscopy, avoid bite-on-bite biopsy, especially if planned for EUS endoscopic removal. It's not so easy to decide whether to resect or not, but the decision depends on the symptoms, degree of malignant potential, patient and endoscopist aspect. Thank you so much for your kind attention.
So now we will invite Dr. Pankaj Desai. He needs no introduction. He is a well-known endoscopist. So you can proceed with it.
The outset, thank Dr. Reddy, Mohan, Zahir, Sandeep, and the entire team at AIG for this kind invitation. Very quickly, in next 10 minutes, we will go into duodenal neuroendocrine tumors, the classification, detection, and endoscopic management. 15-fold increase since 1970. They usually account for 1 to 3% of all GI nets, 90% non-functioning, located usually in D1, usually solitary. They are epithelial neoplasms arising from the mucosa and the submucosa and the enterochromaffin cells, cells. So, and yield of biopsy is high in these tumors. Usually solitary, as I told, less than 10 mm, and often detected incidentally. And usually they are non-functioning, or maybe some are functioning. The prognosis depends. It's all 5-year survival rates are very good. All DNAs are 85%. Less than 1 centimeter is almost 100%. Non-ampullary 90-95%. The lymph node risk also depends on the size. Less than 1 metastasize less. 1 to 2, maybe 5 to 10, and more than 2 metastasize more. Usually, the morphologic appearances, they would have a narrow base with a notch, or sometimes a pedicle or a broad base. Liver metastasis is quite common. And the classification which WHO and the European entities have given is the grade 1, grade 2, grade 3, and it depends on the mitotic count and the Ki-67 index, as we all know. Less than 2 and 2 to 10 is grade 1 and grade 2 with a Ki-67 index of less than 2 and 3 to 20. These are well differentiated tumors and good 5-year survival, while grade 3 tumors are more than, they have a mitotic count of more than 10 per 2 millimeter square, Ki-67 index of more than 30. These are poorly differentiated carcinoma, and the 5-year survival rate is poor. And so Ki-67 is a critical prognostic biomarker. Functional, majority of them are not functional, but sometimes they produce hormones 2 to 3%, and you know that they can cause oligocaralysis syndrome, somatostatinoma, or Cushing's and carcinoid syndromes. Majority of these are non-functional, usually diagnosed when you are doing upper GI scopy, and they are mild symptoms, but these symptoms may not be associated with the tumor. They do produce some hormones sometimes, but the amount of production of the hormone is not significant, and diagnosis, as I told, is usually when you are doing an upper GI scopy. Malignancy, though indolent, they have a potential to metastasize. The diagnostic workup, as we all know, you can have to do a gastrin or chromogranin A level, do an endoscopic biopsy, and for imaging, you have to do a CT or MR to see for the lesion itself, plus other lesions if they are there, or metastasis. EUS would give you the depth of the lesion, which layer it goes to, the characteristics of invasion and lymph nodes in the vicinity. Dotatalk PET CT is usually done for high risk of lesions for metastasis, which includes a size more than 2. Where you have a muscularis propria involvement, G2, G3 tumors, lymphovascular invasions, if there are nodes, and all gastrinomas. The treatment of these non-ampullary neuroendocrine tumors, which are usually non-functional, is classified as, if they are less than 1, no angio invasion, mucosa and submucosal involvement, you have to do an endoscopic resection. 1 to 2 centimeter with low risk of metastasis, either you can do an endoscopic resection, which is common, or surgery. And more than 2 centimeters surgery is offered, but nowadays with the advent of the third space endoscopy procedure, even these can be added as to your armamentarium of doing an ESD. Lesions which are high risk for metastasis, which are going beyond the submucosa with angio invasion and lymph node involvement, and poorly differentiated carcinomas, all would require a surgery. Palliation for patients with comorbidities and inoperable lesions. Depending on this, the size and the grade, we have a risk stratification system. So G1, G2, usually these can be done with EMR and ESD. Intermediate high grade, you have to do a surgery with lymphadenectomy, and high grade tumors, you need surgery with chemotherapy. When not to treat duodenal tumors, usually when the patient is surgically high risk, the comorbidities are present, and there is distant metastasis. There is a wait and watch policy which you can adopt in a few cases where less than 10 millimeter lesions, non-functioning, and very low risk of progression, you can just safely observe for a selected few. Majority of the duodenal tumors, as per the current guidelines, need resections. And how do you resect these tumors? You can do a conventional EMR, you can do a modified EMR, that is with ligation with a cap, or doing a pre-cut, ligation alone, ligation with clips, or ESD. And the endoscopic management, as you see here, either whenever, even if you do an EMR or an ESD, there is a good on-block resection rate around 70 to 100%, and the recurrence rate is also quite low. So the treatment options can be decided upon the size. As we told that you can, if there are small less than 10 mm lesions, what you can do is just band them, leave them, they will slough off and fall, and you can observe. Obviously, you have biopsied the lesions and showing to be low-grade G1 lesions. For EMR, on-block resection rate is around 88 to 97. R0 is less. Incomplete removal is there because you can cut through the lesion when you are in an EMR. So band EMR gives you a better on-block resection with R0 resection, which is similar to EMR. Negative free vertical margins with band EMR in all patients is seen, and most preferred method for NETs which are arising from the submucosa and less than 10 mm. Complications in both are similar, bleed, delayed bleeding and perforation to the tune of around 10 to 12%. And this is a small video which I'll just run through. This is a small EMR. What we have done is apply a band which we use for the band ligation, and with a snare we cut below the band and you have the defect which is then closed. ESD, on-block resection rate of 100%, R0 resection rate of 88 to 100%. The high rate of adverse events is the only problem in duodenum, that is perforation up to 23 to 25% and delayed bleeding up to 7%. Usually very difficult when it is near the pylorus, near the ampulla, and if they are large and with deeper invasions. This is a very small video. This is the NET which you can see. What we do is we inject, start the incision, usually do a circumferential incision if they are around 1.5 to 2. The dissection has to be very slow and meticulous, and you have to identify the muscle. Sometimes you can do an underwater lesion here and expose the muscle and you can remove the lesion. And of course, if it is in D1, you have to clip it and close it. Full thickness resections for lesions gives you R0 resection rate of almost 100%. Muscularis propria has to be involved when you choose this method. It is a salvage procedure for recurrent or residual neoplasms which has been treated earlier with EMR or ESD. And it is difficult in juxtapyloric and juxtaampullary region because there is a risk of taking the ampulla in the FTRD device. Adverse events are not much. Perforation, microperforation and hemorrhage are known, but very few. No other major adverse events. And this is a small video which we can see here. This is a lesion here. You have to mark the lesion, dilate the pylorus because up to 20 mm because the cap is quite wide. Then you have to go inside and with the grasper and a minimal suction, just get the ring inside, get the white ring going down, and you have the lesion cut with the snare inside, and you have a wonderful full thickness resection. Long-term outcomes of ESD are very good. Even with EMR and endoscopic resection is supposed to be safe, effective, and provides a favorable long-term outcome for patients with local or distant metastasis. EMR compared to ESD, of course, we all know on-block resection rates with ESD, R0 resection are very high. Perforation rate is more with ESD. Overall survival remains same, and local recurrence is almost similar. And ampullary nets, if they are high grade, we have is a poor survival, but well differentiated G1 10 to 20, you can do an endoscopic resection, a lymph node resection or a surgery if they are higher, and more than 2 centimeters or G3, you can offer them a surgery. This is ampulectomy, which I am not going to show. Surgical resections are compared with endoscopic resection, and surgical resection usually show good R0 resection more than the endoscopic part. So in brief, these are the guidelines. The only difference I would like to highlight here is the European guidelines put endoscopy as the first line treatment, but NCCN uses surgical as the first line of treatment. But there is a catch here that there is a multidisciplinary approach and you can do whatever is decided by the patients. So in summary, duodenal nets are not very common. Most are detected incidentally. EUS is good for seeing the depth. Endoscopic resection is preferred for small lesions, and surgery is preferred for larger lesions with the deep invasion and metastasis. Palliative care for patients with comorbidities. Thank you so much for your kind attention.
For want of time, we can take one question.
Sir, how to follow these patients after doing ESD or FTRD?
Yeah, it will depend on the grading of the lesion. So if it is a G1 or G2, probably you can just follow them up at 6 months, and then probably till 5 years you have to follow them up. That is the guideline which has been given.
Sir, a very nice talk. Sir, incidentally you pick up a very small lesion in D1. So what should be the approach? Like patient has come for is an asymptomatic, you find one duodenal submucosal lesion around 1 centimeter. Yeah. You biopsy or you proceed for resection?
Yeah, no, I think you can biopsy these lesions. You will get a good yield of biopsy. And then depending on that, you can just do a band EMR or resect the lesions and close the defect.
Pankaj, one point about EMR versus ESD, particularly for bulbar NETs. It's, most NETs are adherent to the muscle layer, although they may not be infiltrating into the muscle layer. And therefore, an EMR, despite whatever the results are seen, there is a high risk of residual lesion, or it can cut through deep through the muscle and lead to a perforation. And ESD is a much safer and a much controlled approach. So that is the point.
Agree. EMR is usually reserved for lesions which are only in the submucosa.
Pedunculated,
I agree.
That occasional pedunculated
Yes.
NET that you might see could be amenable for an EMR, but otherwise is always an ESD or probably an FTRD. That's a different one.
Yeah, thank you. Thank you.
Sir, one question please. Sir, post ESD, if the margins are positive and you have closed that defect with clips, so how do you follow up and what are the risk of recurrence?
Yeah, there is, but margins are positive. That means you have cut through the lesion.
No. In ESD, the deeper margins are positive, means the depth was touching the muscularis propria, and you have preserved the propria. There was a thin.
Yeah, you can just keep. I think these patients you can follow up or do an FTRD at the end.
So should he follow
Yeah?
this patient? Should he follow this patient?
Yes, we will definitely follow up. So you do a regular follow up at 3 months or 6 months. And then, depending on the findings, you will decide what to do ahead.
Thank you. Very informative presentations. We conclude this session.
Thank you. So we'll move on to the next session. It's an interesting session on ergonomics in endoscopy, followed by live endoscopy. So I invite Dr. Nitin Joshi, Dr. Amit Agarwal, Dr. Abdul Aziz to chair this session. I invite Dr. Yogita to start the session, along with Dr. Anirudh, Senior Gastroenterology from AIG Hospital.
Good afternoon. So this is a very interesting session on ergonomics in endoscopy, preventing fatigue and musculoskeletal injuries. So with the expansion of the horizon of the ESD, I'm sure that the procedural duration and the challenges are going to increase subsequently, which is going to create more trouble and more musculoskeletal injuries. So what happened was that while we were preparing for this program, Dr. Zahir suddenly went missing. And we were surprised why he is missing. So he started an ESD which was planned in the morning, but it got prolonged, so he missed the meeting. He started the procedure in the daylight and finished under the moonlight. So this is how it looked. You can see here Dr. Zahir starting his procedure at 11 a.m. procedure, and by 1 p.m. he completed 70% of the dissection. And by 4, it was 90% dissected, and by 7 p.m. he completed the procedure. And over these 8 hours, you can see there is progressive neck bending, abnormal elbow positioning, and there is absolutely no movement of the left hand. However, this variability may be less noticeable in him because he is a seasoned endoscopist, but for youngsters who are starting out with prolonged procedures, you should take care that ergonomics are very important. So ESD for large polyps or stir, a glory on the screen, but a grind on the mind and the body. So we do prolonged procedures, we take wrong postures, incorrect usage of the endoscopies and the accessories ultimately leads to fatigue and musculoskeletal injuries. So these are the kind of typical gastrointestinal injuries along with the musculoskeletal things what we notice typically in gastroenterology. So there are certain things like colonoscopist thumb, also called as decurvent stenosynovitis, endoscopist neck, which happens because of prolonged extension and flexion, shoulder injuries, upper extremity injuries which are noted commonly, along with thumb osteoarthritis. Since we are using knobs continuously and we are talking the scopes, biliary endoscopist knuckle is also described. Lumbosacral pain is quite common who have been doing long procedures like do enteroscopies which will last for 2 or 3 hours, and then lower extremity joint pains and arthritis. So what is ergonomics? It is a study of hard work, how work affects people physically and cognitively, and it evaluates how a job can be best fit to the person's capability. So it also emphasizes methods to reduce fatigue by designing the task within the worker's capability. So it is also economics, it is not just ergonomics. So what is the physical performance to an athlete? It is ergonomics to an endoscopist. So till the time you are going to sustain for long time, you have to be a marathon runner and you have to pay attention to the ergonomics. So how bad is the problem? This is a systematic review of 12 studies which showed that there was high prevalence of carpal tunnel syndrome, decurvance, tenosynovitis, neck and back pain in endoscopists very commonly. And this is an alarming situation where we have to look into it in detail, and ergonomics requires more attention in the future. So can we make it better? This was an excellent study which looked at gender disparities. They looked at weekly case volumes which were higher for men. Females were shorter in this study and females had smaller hands. And also the advanced procedures were performed by males. Since 60% of the males were there in this study, that's why it is biased towards that part. However, females preferred that the cord is there outside the forearm. They used to rotate the knobs right hand frequently, and they preferred pediatric colonoscopes to maneuver when the patient is of low BMI. But you see that there is increased incidence, like 50% risk of endoscopy related injuries, and females had higher risks. So actually females are putting more pressure and they are putting more efforts doing the same kind of movements what we normally do. So they are not able to rotate the knobs, the muscle strength is also low. So that's why the injuries in females are slightly higher. So can we improvise this? There is a single use ergo grip knob extender which is currently not available. However, Olympus is in design, and they have designed a knob which can extend the rotation, and currently it is not available. However, it is going to come subsequently. This is going to be helpful for people who have short hands. And then you have to understand how to use the scope properly. I am sure all of you know all these things. But suppose if you are holding the scope, your hand should be at topmost of the handle so that you can rotate the knobs left and right with the single hand. Sometimes use the right hand when there is acute bend, like doing a colonoscopy or prolonged ESDs. And then try to use fingers properly so that it can guide your thumb and relieve some strain on your thumb. So this is the thumb sign which people use, the thumb technique, like resting the scope on the thumb and the middle of the hand, which is rarely recognized. But this is causing more injuries to the endoscopist, as the thumb and the finger are causing more strain and you have to use them quite frequently. So what are the usual sites of pain? There may be pain in hand, wrist, elbow and shoulders. These are the usual problems. And there may be pain in legs also with prolonged procedure, especially the left leg, since we are moving the right leg continuously. So these are the biomechanical risk factors. We tend to use repetition, high force, awkward joint postures, and also suppose if you are doing ERCPs and EUS, there is a static load of the lead apron. So what about the neck position? You should always keep your neck position in a neutral manner, since when you are bending forwards, actually it causes extension problems and it causes burden on the posterior neck extensors. You tend to use more ligaments in the neck, which will worsen the neck pain, cause muscle fatigue, shoulder pain and sometimes headache. So that's why you remember Pushpa said that jhukega nahi sala, because he understands the importance of ergonomics. So when you reduce the lid from a single lid jacket to a double lid jacket, actually you reduce the strain by 80% because the shoulder strain is taken out and you are wearing a two-piece apron. It is going to take lot of strain from the shoulders away to the pelvic girdle. So this is very important. This is how an ideal setup should look like. You should have a main screen which is adjustable, then a second screen for the technician, adjustable bed. You should have an anti-fatigue mat and a cushioned soles, which is going to help you for the longer procedures. So always we are using the right knee, we are constantly moving around using cautery, using water sufflation, and our left knee is constantly hyperextended. That causes lot of pain and trigger, and it poses lot of strain on the quadriceps. So you should be careful what you are doing. So always try to flex in between the procedures whenever you are moving around a bit while using cautery also, so that it reduces the strain. This is very important. Don't become the scope yourself. Sometimes I see my colleagues seeing inside the screen deeply like this. It is a two-dimensional screen. You are not going to see more than what you already see on the screen. So don't bend your neck too much. It is not going to help you, and it doesn't improve your dimensions. So you can see on the left side, this is a poor slouching. We tend to do a maneuver to see the uncinate process while we are doing EUS. And this is stable position. You need not bend so much. Adjust the height of the monitor accordingly. So there are multiple ergonomic assessment tools, of which rapid entire body assessment is the most popular. It classifies people to have a musculoskeletal disease risk factors due to awkward positioning. So this is how it looks like. It consists of two components. There are two parts, A and B. A will categorize into neck, trunk and leg analysis when the patient or the person is doing some activity. Somebody is going to watch them and score them, and when you combine these parameters along with the load and the coupling of the wrist, you tend to give them a score. So when the score is 8 to 10 or 11, you need to consider these patients at high risk and consider correcting their postures. It's very important. So these are features of ergonomically sound procedure. Every one of us knows that. Monitor should be straight, bed height should be variable. You have to focus on your posture. You have cushion mats, take micro breaks, and also use a compression stocking if possible, if required for you. So ergonomics learning can help. So this is a chart where they assess that novices were taught ergonomics, and the people historically who are doing procedures for a very long time, you can see here the REBA score was significantly better people who learnt ergonomics. So you should always take micro breaks in between the procedures. This is going to help you a bit. They looked at this study where surgeons took micro breaks. That was imposed actually. They don't take self breaks, which actually improved the physical performance and the mental focus of the surgeons. Vigorous exercise is also associated with the decreased musculoskeletal injury in these patients. So this is Dr. Azim performing at our endoscopy ergonomics gym, which is there at the second floor after a prolonged procedure, and he is taking a short micro break, which is helping him doing that stuff properly. So to conclude, actually you have to plan the procedure very well. You have to understand the anatomic difficulties, look at the alternative strategies which is going to decrease the duration, always be ergonomically aware, take mental rest, strategic short breaks, and take help from your colleagues when you are tired, when you are doing a prolonged ESD. That might help, because ultimately what you are doing, it is going to benefit your patient and decrease the complications. So you don't know if Raymond Duckett would also attend this lecture and change his posture after learning the ergonomics. So thank you so much for your patient listening. So now I welcome Dr. Yogita. She is going to take us through the exercises which are important.
Hello everybody. I'm Dr. Yogita from Orthopedic Physical Therapy Department. And I see a lot of gastroenterologists who perform endoscopies come to me with various back pains, neck pains, shoulder pains. Most commonly I see is wrist pain, that is recurrent stenosynovitis, and most common age group is 35 year to 40 years, that is who have just started. And senior endoscopist also I see with low back pains and shoulder injuries. So today I'm going to teach you what you can do apart from managing your monitor, your scope and all. What exercises you can do in the micro breaks, macro breaks, and to prevent all those injuries. So we have seen this. It is not only, it has two main objectives, which is maintenance of human health and well-being, and most productive use of human capabilities. So why does it matter to endoscopist? Because it is a repetitive, forceful and prolonged procedures, and it has high prevalence of ergonomic related injuries. Poor ergonomic affects carrier longevity. The most common affected muscle groups is hand muscles. Mostly affected is hand muscles. That is your abductor pollicis longus and extensor pollicis brevis, because of which you have decurrent stenosynovitis. Then comes the shoulder muscles, your supraspinators, infraspinators, which gives you rotator cuff strain, and your neck muscles. The first picture is very important because you are seeing the upper cross syndrome there. Just a forward head posture. Small intro forward head posture will give you few muscles will become tight, few muscles will become weak. So once we correct the tight muscles and once we strengthen the weaker muscles, your posture will go back. Okay, so this is very looking very simple, but yes, if you can maintain the posture correctly, you can prevent all these problems. Then comes the lumbar muscles, where you have quadratus lumborum tightness because of spinal rotations. Okay, advanced procedures is equal to higher ergonomic risk, that is ESDs and ERCPs are advanced procedures. So this will also, because of the longer static loads and higher torque, you will have higher ERIs. Cost of ignoring human factors is a poor quality, which gives you increased probability of injuries and errors, higher medical and material cost, and low quality of work. Now here we can see the head and neck are neutral, shoulders are relaxed, elbows is closer to the body, and knees are slightly flexed. So that's the ergonomic posture. Now when you have shoulders relaxed and elbow flexed, sometimes I have seen endoscopists doing this procedure, talking most of the time. So rather than talking, just use the other hand endoscopic wheel. So when you correct your posture like this, your shoulder is getting corrected to the backward rotation, your elbow is getting flexed, and you're using the other hand also alternatively. So that is the importance of elbow being closer to the body, shoulders getting corrected backward, and all your muscle load reduces on the shoulder and neck. This is also important. Wrist, you have to put your wrist in neutral. If you deviate slightly or if you flex or extend, then there's a static muscular load on the wrist extensors and flexors, and you will develop tennis elbow and golfer's elbow. So neutral wrist is very important. And then this was also previously discussed when you do the pod. So instead of keeping it hyperextended, the right leg, consciously flex it. Most of the times you need to flex it so that your hamstrings don't go into tightness. If you keep it hyperextended, then quads become weak and hamstrings become tight. So good versus bad ergonomics, monitor influence of the eye, neutral neck position, with this all we have discussed. And bad ergonomics, if your monitor is too high or too lateral, then neck rotated, elevated shoulders, that will give you rotator cuff strain. And yes, excessive force on the thumb will give you decoherent stenosynovitis, which you need to be careful. So always before going further procedures, just check yourself. So myself, M is monitor, Y is standing wide, S is scope, E is elbows closer to the body, L is lower extremity on the antiphatic mats, and F is free. That is your scope thing should not be coiled, it should be free so that you don't have a muscle load on the elbows. Now exercises to prevent. How many of you had or still experiencing low back pain, neck pain, thumb pain, and wrist pain because of the procedures, during the procedures and after the procedures? All of you. How many of you with back pain? Okay, neck pain, wrist pain. Okay, I say neck pain is more common. Okay, so whole body pain, okay, I can teach you that also. Exercises to prevent pains. Now, Dr. Anirudh has already spoken about micro breaks and macro breaks. So what exercises you can do in the micro breaks? So when you take break in between the procedures, you can just, as if you're drying the hand, just open your hand like that. That will improve your intrinsic muscles. Okay, and do the wrist flexion, extension, thumb movements clockwise and anti-clockwise. This is a great exercise to prevent the decoherent stenosynovitis. Okay, that is your micro break. Then for the neck, what you can do? You can just do simple neck movement, just rotations, so that whatever trapezius is the most common muscle to go into tightness when you're like that into the monitor. So your trapezius gets corrected and your deep cervical flexor. So you need to do the chin tuck. Just get your head on the cervical spine, your deep cervical flexors gets activated and your posture gets corrected back into the neutral. Okay, that is what you can do in the micro break. And for the shoulder pain, so when you are like this, your pecs major mostly gets tight. So what you can do for the shoulder pain, just go towards the wall, keep your hand at 90 or 120 degree angle and rotate quarter. Okay, you will have a nice stretch at the pectoralis major and minor muscle. It will also correct your shoulder posture back. So when you are forward neck rotation, your shoulders will go into forward rotation, and then you will have pecs tightness. Just correct that. You can do this in micro breaks for 3 seconds or 4 seconds hold. For the lower back pain, you can do quietus lumborum stretch. Just go against the wall and then stretch yourself like this. Okay? This is a main muscle which goes into tightness when you are into the non-neutral postures. This is a piriformis stretch which you can sit and do at the edge of your table. So I want to explain few exercises for the decurrent rhinosynovitis because I see a lot of patients from the gastro department, lot of gastroenterologists coming to me with the decurrent rhinosynovitis or first CMC arthritis. So this is a hand gripper which you can use in your ergonomic setup at the endoscopy suite. So what you can do is, in between the micro breaks, you can just hold it and relax. Hold it and relax for a couple of times. Okay, and these are the physio balls, which you can try to prevent the CMC arthritis. Okay, just rotate your ball in between the thumb and the index finger. Then you can take the other ball and try to do the grip strengthening. So these are physio balls easily available on the Amazon. And this is a silicone finger stretcher, which is also available on Amazon, which you can keep it in the ergonomic setup, which will help you to improve your intrinsic muscles strain. Okay, and then we have...
Actually, Dr. Yogita, sorry to interrupt you. The theater is ready and you can explain these exercises later on. Thank you very much.
Yeah, if you are experiencing pain, then please join us in the physio department. We'll be happy to help you.
Thank you. Thank you very much. And we close this session. It's a great session. And now we move to the theaters. And Mohan, are you ready there? Mohan, can you hear us? Yeah, you're not audible, Mohan, in the hall. No, your voice is not there.
You can speak, Dr. Nouri.
Yeah. Now we can hear you, Mohan.
So it's a great honor for us to have Professor Noria and Dr. Naresh Bhatt to demonstrate first case. So in next 1 hour, we'll show you all the cases, pre-malignant cases and other early gastric cancers, how to diagnose, how to do standardized endoscopy and colonoscopy to be better in terms of catching these cancers in early stage. So we'll go to the first case.
Yes, Noria is using 1200 series scope, which is a high definition scope with zoom function. There's a 63-year-old lady who's got abdominal discomfort and some weight loss. History is significant. She's got a multinodular goiter with thyroidectomy. She's also had a non-healing ulcer, not clear whether there was malignancy or not in the tongue, but rest is normal. Now she's come for a routine examination, and let's see what Dr. Noria finds.
Okay, so as Naresh mentioned that now we are using a zoom scope. So now can you see the slightly like a black hood, tip of the black hood in the periphery of the endoscopy image? So this I use a black rubber hood. And then this really avoid complete contact of the lens to the mucosa. And then we can achieve...
Can you show us the screen, please? The screen of calibration.
Okay. So now it really facilitates to get a very good focus for this image. So usually 4 millimeter to 5 millimeter is adequate size and then distance. So I start insertion of the endoscope. And then, as I mentioned, probably many doctors mentioned that for squamous epithelium, NBI is very good for detection of squamous cell carcinoma. So we usually evaluate oropharyngeal mucosa as well. And then now you can see the melanosis. This is one of the high-risk findings for squamous cell carcinoma. In such patients, it's better to little bit check the oropharynx to check the kind of squamous cell malignancy. Now you can see some dilated vessel, brownish area. I think not really well defined, so cannot be a carcinoma, but I think she is very high risk patient for squamous cell carcinoma. So I checked right piriform sinus, so I moved to left piriform sinus. This is lymphoid follicle, no malignant, but and then we insert the scope from left piriform sinus to upper sphincter. So this is esophagus. And then we screen the squamous, esophageal squamous mucosa with NBI. So whether there is demarcated brownish area is present or not. So we screen esophageal mucosa with NBI. But not so much. Slightly dilated vessel is seen, but not so much well demarcated. So previously, Amit explained about the IPCL pattern. So I also want to explain what is IPCL. So now you can see a dilated loop-like vessel. This is IPCL. And then it aligns on the one line along deep vessel. So I think this is maybe inflammatory change or something. But if it is
type A step.
Type A step, yes. Dilated and then tortuous, but not caliber change and heterogeneity of the shape or size. So I think it is caused by inflammation. But anyway, this is squamocolumnar junction, and then we go into the stomach. So I tried to evaluate gastric mucosa with SSS protocol. So SSS protocol, longitudinal position, upper part, middle part, and then lower part. And then we evaluate circumferential position, 4 quadrant, greater curve anterior and lesser curve and posterior. And then Kenshi did not really define the order. So Kenshi usually start from antrum, but I usually start from upper body. So upper part, greater curve, anterior wall, lesser curve, and posterior wall, 4 quadrant direction. And then proceed the scope to the middle part of the mucosa, stomach.
Reddish streaks that you see,
Yes.
do they mean anything to you?
Just inflammatory change. So it does not really associate with the risk of gastric cancer. So you have to just pay attention to the mucosal atrophy or intestinal metaplasia when we really want to assess the risk of gastric cancer. So maybe greater curvature side, you can see the gastric fold, but the lesser curvature side, especially lower part, it is lost. And then color, here is homogeneous, but here is somewhat like a patchy, red and white, yeah. So I think this patient have a atrophic mucosal gastritis in the lower part of gastric corpus. But anyway, I checked 4 quadrant direction in the middle part. So I proceed the scope again to lower part, greater curve, anterior wall, and lesser curve, and posterior wall. I think this patient has a scar change in an incisura. And then...
So that Kimura, Takimoto, where would you put this?
So Kimura Takemoto, usually we evaluate the atrophic border by downward view and also retroflex view. So I think this lower part of the corpus, mucosal color is pale, and then you can see the vessel, increased visibility of the vessel.
So C2?
Probably this mucosa extend to middle of the corpus, so I think C2.
C2.
Yeah, you are right. Like this. So lower part of the corpus we see, and then this time not only just up angle. If you use small wheel to left, we can see the lesser curvature in a very frontal view. So it's very easy to evaluate the extension of the atrophic mucosa.
So this is showing features of atrophy.
Yes.
So we are worried that there may be something more sinister.
Yes.
That alerts us to that.
And then antrum, and you can see that the color of the mucosa is really mosaic color of the reddish color and the whitish color. And then when we switch to NBI, that color difference is really contrasted.
So this looks like H. pylori related possibly?
I think so.
Multifocal?
Yes.
Yes.
And then, anyway, we start complete examination, SSS protocol, finish SS protocol. So this is a pylorus. And then I think there is a ulcer scar in the pylorus. So maybe patient has a H. pylori gastritis, and then in the past, probably H. pylori associated peptic ulcer was developed in a duodenum valve and stomach. So this is duodenum. And then incisura, lesser curve, anterior wall, posterior wall, and then corpus, retroflex, lesser curve, anterior wall, and posterior wall. And then greater curve become very tangential, so usually we don't, SS protocol does not require to evaluate. And then fundus or cardia, we evaluate 4-quadrant direction. Anterior greater curve.
Dr. Naresh and Dr. Vedo?
Yes.
Yeah, Amol here. Is there something at the incisura looks like some puckering? Some puckering or something that we all
Yes. But anyway, we have to follow the standard observation protocol. So otherwise, sometimes we miss some point or some lesion.
Okay. So, didn't want to get distracted by that. So he's finishing off the overall examination. But you're right. There looked something suspicious there. You're right.
Yes.
Right.
Maybe in the lesser curvature side, maybe some scar change. So we switch to NBI. I think the mucosal color is a little bit whitish compared to surrounding mucosa. So when we evaluate with magnification, now you can see the mucosa in between the kind of sulcus. I think this is a non-metaplastic surrounding mucosa. You can see the brownish capillary here, but this part we cannot see the vessel. This is because of presence of white opaque substance. Can you see whitish? Not a good image. Yeah. Like this. Now, maybe left part of the image, some whitish deposition is accumulated in the epithelium. So this is intestinal metaplasia. Intestinal metaplasia absorbs the lipid from the bile or food, and then it is accumulated in a subepithelial part. This is white opaque.
Considered part of IM?
IM, yes.
Okay.
Definitely. But the structure is not really irregular, and then we cannot evaluate the vessel, but basically shape of white opaque substance is not irregular. So I think it's benign intestinal metaplasia. And now,
what about your light blue crest?
Light blue crest we cannot see here very well. But anyway, we
one lesion suspicion.
Yeah. And then now we see some little bit protrusion, reddish protrusion or slight erosion. Maybe Raj previously mentioned how can we differentiate benign or malignant erosion. So I think we apply magnifying NBI to this region. So now I'm using a water immersion technique. So
is using water to magnify the image further?
Or avoid reflection. But not so much. good image. Okay, I push the scope. I think this region, so around the erosion, the mucosal structure is a little bit irregular. And somewhat like a slight demarcation. So I think this is suspicious.
You have used maximum zoom here?
Because I cannot really get close to the region. So, okay.
Dr. Naresh and Dr. Vido, Amol here again.
Yes,
one practical question for which I don't have an answer for. I always keep thinking about this, and I think everybody would benefit. Now, for example, meaning I think AIG may be having a lot of zoom scopes, but most centers will have one zoom scope in the department. Now, how do we stratify patients? Which patients go for a zoom scopy, or which patients go for a regular 190 scopy, and then do these patients come back for a zoom scopy on the same day or another day? How do we do this?
So, in practice, basically, if the patient has some clinical information for the suspicious lesion, we usually use magnification endoscope.
Yeah, I mean, that is understandable.
Like
but what about patients
family
with
history
dyspepsia
or something? And then in endoscopic examination, if we find some severe extensive intestinal metaplasia or something, maybe we change the scope actually.
So I think Amol, in Indian situation, that's a little thick because all of them don't come. But as you say, find something suspicious, call them, shift to the other's room for the, with a zoom scope or something like that.
Okay. Yeah,
Ideally, everyone has endoscopy with a zoom endoscopic.
Yeah, but that may not be practically possible.
Ideal.
Dr. Naresh, we have many cases today, so we'll shift to another room where Dr. Raj is there with the colonoscopy demonstration.
Go ahead.
So our next case will be 61 years female with complaints of constipation and bleeding per rectum since 6 months. Upon evaluation, she had iron deficiency anemia, and colonoscopy showed subpedunculated polyp of size around 2 centimeters of JNET 2A just beside IC valve. So plan is underwater EMR.
Hello, hi. Can you guys hear us?
Yes, we can hear you.
Okay, so you heard the history. So I have here together with myself, my senior colleague, Dr. Ravindra, and we also have Srinivas and Sridhar, who will be assisting us. So you heard the patient, and what we are trying to do is to start the insertion. And you can see we're using something called a scope guide, all right? So just before that, I'm going to tell you what we're using. So we're using an EZ 1500 scope. So this is the newest Olympus scope. It's got a lot of functionality, and it's got a lot of zoom functionality as well. In addition, what we're doing is we're using something called the scope guide. So if you can see the picture in picture, can you see that picture in picture? There's the scope guide there, and you can see that we form like a question mark sign. Basically, magnets around the scope is being picked up by a monitor, and the monitor is transmitting the magnets and the scope image onto a screen. So it allows us to look at loops and allows us to reduce loops as they are forming. So you can see right now we have not had any loop formation yet. All right, so I'm just going into the hepatic flexure now. It's pretty straightforward. I'm not pushing, right? So one thing about doing a colonoscope is slow is fast. So I'm sorry I'm being very basic here, but slow is fast. I'm not pushing. I know the lumen is down there. I'm just suctioning the
the CO2 or the air to basically try to get and hook around that area. All right, so I know just by the feel of the scope, I'm going to push and it's going to push me back. Can you see that? It's pushing me back as I push.
On the scope guide, we are able to see that.
So now when you're in this sort of situation, there are two options. One is to keep pushing, which won't give you any sort of good product or good end outcome. The other is to pull back your scope until you go back to that situation, and then you have two options. If the patient is semi-awake, you ask them to turn and then you try to maneuver past the corner. If they're not awake, you apply some abdominal pressure. So we're going to get our assistant to apply some abdominal pressure because the patient is quite highly sedated. So our scope is very short. It's only 52 centimeters. And with pressure, I'm gradually going to see if I can turn my scope around the area and reach the cecum. Alright, so right now, as you can see, we have reached the cecum by just a simple maneuver. Slow is fast. We probably got to the cecum within, I guess, since we were talking about 2 minutes. So this is the appendicular orifice. You can see the scope guide there. Scope guide has been shown for many years, over the last 20 years or so, to basically allow people to look at loops within the bowel. And if loops are forming, you can see the scope guide pressure developing within the body of the colonoscope, which will turn yellow. And that warns you and tells you that maybe in a different part of the bowel, rather than what you're seeing on screen, there's some pressure being formed there, and you have to either reduce that loop and then apply counter pressure to prevent that loop from reforming. All right, that is one way of knowing where the loops are forming and what to do with those sort of loops with regards to applying counter pressure. So when we apply pressure, or what's called as counter pressure, to prevent the loop from redeveloping, there's a little device we can use and we put on the patient's abdomen, and that has got a magnet as well, and that gets picked up on the screen. Okay, so that's how the scope guide works. It's very useful for people who are just learning, but it's not very useful for people who have done multiple scopes, like my colleague here who does 60 scopes a day. So it's not, it won't be very useful there. The other thing you can see is we're using a cap. All right, so the cap has easily gone into the terminal ileum. All right, this is one of the quality indicators I discussed in the morning, because if you are in the terminal ileum, you know cecal intubation has been achieved, and it's important to basically take an image to prove that. So when you do audits, you can know what your cecal intubation rate is. You can know what your unit cecal intubation rate is. You can also know what your institution's cecal intubation rates are, and they should generally be above 98%. All right, so you can see we're using a bit of zoom endoscopy here, and this scope is quite magnificent. Yeah, so we can remove the scope guide, but you can see that these are the villi, and we were just discussing, just take out the scope guide, we were just discussing that you can sometimes see what's called as the light blue crest here actually in this villi. You can actually maybe vaguely appreciate it if you've got a good high quality screen like what we have in front of us. This is underwater, and you just saw the scope guide image being taken off, and the reason it was taken off was because we need to look at the polyp, which you may have partially seen. All right, so what I'm going to do is, our scope is now only 62 centimeters long in the cecum. It's not a long scope, so for any intervention it's important that you have a shortened scope so you can do any sort of advanced procedures. So slowly coming out from the IC valve, reason is because the lesion was very close to the IC valve, so we want to make sure there's no extension. Alright, so immediately you can see the IC valve is on our sort of 4 o'clock position, and the lesion doesn't extend into the IC valve. In fact, it is subpedunculated. Would the people on the panel agree?
Yes, sir.
Yeah, so one other thing is
we have picked up something. So maybe you can tell us what we have seen.
There is an extension. Initially, we thought it's just a pedunculated one, but if you see that it's an extension. Initially, the plan was to just like a simple polypectomy. We wanted to remove it off, but the advantage of this zoom endoscopy is you can see that there is an extension. Dr. Rajvinder is showing us. See, there is an extension almost to the tune of around half a centimeter or 1 centimeter to the lateral extension. There is a lateral extension. Everybody can appreciate in the hall?
Yes, we appreciate that.
So what we are doing is, I'm going to do some underwater, so you can actually see the extension a bit more clearly. All right. So can you see that? So there is a lateral extension, and that is one of the good things about some of these newer scopes, I suppose, is that the ability to see a lateral extension, the ability to call a lateral extension for what it is. In this case, it looks quite regular and in keeping with a JNET type 2A lesion. All right, so this is a tubular adenoma, a villous component maybe on the surface there, and an extension which is going towards one of the margins. All right, so it allows us to actually see this and allows us to do one thing. This allows us from ensuring that we just take a snare and remove the polyp and then leave a remnant here, and this remnant then comes up and basically leads to a recurrence. Okay, so I'll just tell you of one sort of thing I use with regards to polyp assessment, and it's called the SSMMAA. All right, just remember that 2 S's, 2 M's, and 2 A's. So S stands for site, which is in the cecum. Size, which you can see it's probably about maybe 1.5 to 1.7 centimeters at the head, but with a lateral extension of about maybe 1.2 to 1.3 centimeters. All right, so you got the site, the size, then you got the M. M is the morphology. So morphology, you've got a 1P lesion plus a 2A. 2A is flat, 1P is pedunculated. So that you got your S, you got your S, you got your M. Your next M is magnification, which you partially saw, but you can actually see that with magnification, you can nicely see that there's a nice villous component here. Doesn't take you very long to do this, it's quite straightforward. So we've got the magnification there, and we already saw this area here, which is a type, as I said, JNET type 2A. Alright, so now we got both the M's done. The next thing is your access. Okay, your access. Can you get this? Can you get it today? Do you want to do it another day? All these things are important. So your access is easy because, as I said, we got a straight scope thanks to partially the scope guide, but we didn't use it actually. We just used our own clinical judgment and got here, and we got that lesion there very nicely demonstrated. Access is good. Shortened scope, 62 centimeters. Next come your assessment. What are you going to do then? So within 2 minutes you can decide. You got a polyp. Is it necessary to do an ESD here? Why? You should ask yourself. What's the risk of a submucosal invasion here? I think it's close to 0%. So the thing is, do you want to spend time doing an ESD, or do you want to spend time taking off this polyp first at the head and then the lateral extension? We can do it safely. The patient can go home today if we do it safely. So your assessment is the last A. So SSMMAA. All right. I hope,
Raj, as you are preparing for EMR, we got your points. Now I think we'll go to Noria because we have many cases to show.
Yeah, sure.
We'll go to Noria and come back while you are doing EMR.
Okay,
or whatever it is.
no problem. Thank you, Mohan. Thanks. Okay, let's go.
Our next case is a 57 years female, came with complaints of dyspepsia and reflex symptoms since 1 year and was dependent on PPI. Routine labs were normal, and UGI with NBI suggestive of suspicious of early esophageal malignancy. So we planned for endocytoscopy.
Okay. Yes. NBI. Yes. So now This is a patient. So initially I checked the circumferential orientation. Now we infuse the water. Now water is pulling to the left side. This means the patient is left lateral. So left side is left side. And then this is, I think this is posterior wall. So this is spinal bone. And then opposite side is right side. And then upper side is anterior wall. And then this is, now you can see the upper side, upper part of the image. You can see the left main bronchus here. So this is a distinction between upper esophagus and middle thoracic esophagus. Now, I think this is the lesion, but actually on white light, it is a bit difficult to see. But when we switch to NBI, you can see the brownish demarcated area in the lower part. So actually this is almost opposite side to the left main bronchus. So it's located in the middle thoracic esophagus and then mainly posterior wall. And then about half circumferential of the region. So this is white light, again white light. It may miss the region.
But Dr. Vedu, any subtle sign on white light to pick up?
So usually in white light image, diagnostic criteria is reddish uneven surface mucosa and then disappearance of background mucosa, so background vessels. Now you can see the three branch-like vessel, but when we get close to the lesion, now this vessel is disappeared here. And then now you can see the slightly uneven surface area.
Color
with
is also
yes. This part you can see the vessel, but the lower part you cannot see. And then this color change is really enhanced with NBI. And when we use magnification, this brownish area consists of a dilated IPCL. This is proximal demarcation. Now you can clearly see the differentiation between surrounding mucosa and the mucosa.
So you normally will apply the AB sort of a classification.
Yes. And then not only dilated vessel, but also if we see the pay attention to the epithelial color in between the dilated vessel, this epithelial color is more browner than the surrounding mucosa. So brownish area consists of the dilated brownish IPCL and color change of epithelium. So this is very characteristic finding of epithelial neoplasia.
Prof. Noria will be back with you for 2 minutes.
Okay.
Just,
Yes.
Yeah. Raj, you are on.
Oh, sorry. Yeah, hi. So you can see that we have injected the lesion. We have carefully placed the snare behind and underneath the area which we think has got adenomatous tissue. All right, so you can see that there.
The lateral extension is taken care.
Yeah, so we are trying to get this in an en bloc fashion. It's not necessary, but we are trying to see if we can get, because it came around quite well. So once you get that, the snare must be put maximally, okay? Maximally closed, okay? So we are closing it so that we try to make sure the muscularis propria is away from the wall. All right, so very good control. Then we do something called a jiggle, like a Bollywood dance or something. You jiggle a bit to make sure the opposite wall does not move. Is the opposite wall moving? No. So opposite wall is not moving, meaning it's quite likely you've got only the submucosa and not the muscularis propria. Okay, so now I'm going to make a cut. It should cut in 3 seconds. Okay, less than 3. All right, that's very important to do because you can actually see the lesion here. It's important to cut within 3 seconds. If you cut above 3 seconds, the laterocautery system, the machine is telling you you've captured something else. And you don't want that. Okay? So you have to cut within 3 seconds. It goes teen, 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 teen. Better prepare your clips because you're going to perforate. Alright, so these are some technical points. So you have seen we've just taken it off in one piece. I'm just giving it a little bit of some water just to make sure that everything is okay, and we clean it. So something which we also do is called a snare tip soft coagulation. I'll show this quickly, and then we will just close this with one or two clips. So use your tip of snare a little bit, just a little bit. Okay, stop. Okay, so this is called STSC, all right? You hold the scope. So STSC, can you put hemostasis there? So you use soft coagulation current. You can use 5 or 6. And what you can do is just use your blue pedal and try to achieve the tip
Dr.
of...
Ahmed, one small question, that this was a tumor with a certain lateral extension. So what is the probability of doing, although this is a CCUM, what is the probability of doing a ESD? What are pros and cons of a ESD in such a situation?
Okay, so I didn't quite get your question fully.
ESD, whether why not ESD in place of
Yeah. So the question is why ESD, right? If the intent is to take this lesion, our intent initially is to take it actually in 2 pieces. But because we could get the snare around very carefully and safely, we did it in 1 piece. So there was no intent to take this off in a single piece. The reason is SSMMAA. We really decided that this is a benign lesion based on our assessment. So if you want to do an ESD, you can do it here. You may spend a good 1 or 2 hours doing it with very little gain or no gain at all. All right, really, no gain at all.
Okay,
and there's no reason to do that unless you suspect a cancer. And I will discuss this tomorrow during my talk.
Thank you, Raj, and thank you, Ravinder. We'll go back to Noria.
Okay. Okay, so now I explained the indication, whether it is indication for endoscopic treatment or not. So now you knew that NBI really enhanced the detection or delineation. And then we see the magnification image so that we can see the loop-like vessel. And loop-like vessel is seeing weak magnification or non-magnification. It's almost like a dot-like appearance, like this. And then if you all area is dot, this indicate intramucosal region. So from here to left side, so everywhere looks like a, this is called B1, and then correspond to intramucosal region. So all area consists of this dot-like IPCL pattern. So I think this region is intramucosal carcinoma, squamous cell carcinoma. So I think a good indication of ESD. And if such dot-like pattern is destructed, and then you can see some continuous line, like linear vessel, it is indicated of some deep muscularis mucosae invasion. And then if you see very thick vessel, it is indicated for deep submucosal invasion. But
is there any avascular zone there?
I think this area is
normal stratified.
Normal squamous. Probably it is caused by inflammation or sometimes biopsy. Degenerative non-neoplastic mucosa can be seen like this. Okay. Avascular definition of avascular area is avascular area should be surrounded by irregular vessel. So not really, it is not surrounded. So
what do you think when you have this normal areas in between this? Can it be a multifocal thing also? Just
basically no, because we can really delineate the whole area. Inside there is some non-neoplastic epithelium, but basically we can really delineate the whole region. So I think we can completely remove this area. Yes.
So you want to use chromoendoscopy also? You said you want to use.
But recently we basically marking with NBI.
Okay.
In case of very well demarcated lesion, and then after that we check with glucose iodine. So that is a practice. Okay, I think maybe this is indication of endoscopic resection, maybe ESD.
Okay. So now you're spraying the dye.
Yes. I'm not sure we can really see, but this is endocyte scope. So if we stain the nuclei, we can see the nuclear staining according to literature. But not so much good. Maybe not good example. So according to literature, methylene blue stain the nuclei of squamous epithelium. So with high magnification, we can see nuclear staining, but probably the concentration is a little bit too low for staining. So as I mentioned, chromendoscopy always concentration is very important. So this is high. Now you can see some bluish
Correct.
round thing.
Maybe if you can you freeze the image, Dr. Vedu? I think once you get the nucleus, if you can freeze the image, we could
Wait
see.
a moment.
Yeah.
This.
So yeah.
Now you can see the regular,
Correct.
very lightly stained.
Those dark
brown.
dots on the screen, they are the nuclei, the regular nuclei.
Yes.
Maybe you can see it in the area of tumor, how the
Tumor. Yeah.
Yeah.
And then this is boundary. Maybe it will be difficult according to maybe anatomical location. So many literature say that the usefulness, but sometimes in real clinical practice, such kind of situation is happen. So
for this we need AI more than for the other one, because for such magnified detail. So like they have endocrine for the colon, it's something for the esophagus also that way.
So maybe this is not good case for chromoendocytoscopy. But maybe NBI is more, universally useful. Now you can really understand. That is why maybe chromoendoscopy become not so popular. I think.
Use iodine, you said, for your dissection to see the margin. When
Yes. Maybe tomorrow, before the treatment, we can see how iodine chromoendoscopy work.
And
for
one more
this type of lesion.
question, Dr. Vedu. See, when sometimes we deal with some scarring or something in the esophagus, in the setting of a scar or something, how do you evaluate the IPCL pattern in those patients actually? Or can you say not do IPCL assessment when there is a scarred area or radiotherapy changes or something?
But even scarred area, we can see the vessel change, IPCL. And then I think we can use the same criteria, diagnostic criteria. Even scarred area, neoplastic change shows demarcation and the irregularity of the vessel. Okay.
Any question from the audience? You want to ask anything?
Small
Dr. Vedu?
question.
Yeah.
In such a case where we can see chromoendoscopy as well as NBI, so do you need a biopsy diagnosis or only on this basis we can do the endoscopic?
In our practice, still even such definite lesion to explain to the patient for invasive treatment, we always take biopsy for proof.
That's true. I think if you do a big EST, like maybe circumferential was almost 70% circumference.
Yeah. So in our clinical practice, we still histology is the gold standard.
One more thing, Dr. Vedu, sometimes when we do assessment, we find some open loops, a lot of closed, but few loops will be open. So I'm saying, do you look at the proportion, what proportion of loops are open?
Some, you mean a B2 vessel and
Yeah, there is some B2 even in a B1, there
So-
are areas of B2. So how do you deal with that situation?
So some papers say that the area of B2 vessel is larger than 7 millimeter. 7 millimeter means about 2 times larger than maximum image. So it's likely to be invasive cancer. Chance of cancer high.
Very small focus.
Very small area maybe that.
We can do
not
EST
so
set.
confident. Yes.
Okay, thank you, Dr. Noria. I think you have to do next case also.
Okay.
So we are preparing in the next room.
Thank
So
you.
kindly go to the next room. We will present the history now.
Our next case is 52 years female with abdominal discomfort and loss of appetite and loss of weight since 3 months. Upon evaluation, her labs were normal and PET CT showed a non-FDG avid symmetrical wall thickening in antropyloric region of stomach. This axial cut of CT was showing the symmetric wall thickening in the antropyloric region of stomach. Now patient is planned for standardized diagnostic upper GI endoscopy. Diagnostic endoscopy has shown gastric atrophy with intestinal metaplasia, a feature suggestive of early gastric cancer. Now planned for standardized diagnostic upper GI endoscopy.
Thank you.
Dr. Ashutosh and Dr. Noria, you are on.
Okay. So again, we usually evaluate with white light endoscopy first. And then when we look at the background mucosa, greater curvature side, there's a pore and then a homogeneous color. But the lesser curvature side, gastric fold is lost. And then it's a kind of mosaic pattern of a whitish color and then reddish color.
Atrophy at the lesser curvature?
Yes. And then maybe this is atrophic border. Lesser curvature side is mosaic. Okay. Then greater curvature side, very uniform color. And then here there is, no, this is not the, now you can see the clear demarcation line. And then inside, there is a very unevenness of the mucosal height, surface and the color.
Touching, there is oozing of blood.
Yeah, yes. And then at that time, not should not really go straight forward to the lesion because so that we can really lose the gross appearance. So it's better to initially evaluate with distant view. So now you can see the clear demarcation exists from here to greater curvature of the incisura and then extend to other antrum. And then from here, the delineation little bit going up and then go to lesser curvature side like this. And then extend it to posterior wall side. Maybe around here, this is the demarcation.
So
and
large,
then, yeah, very extensive. Large. Yeah. And then maybe lesser curvature side, we see this area is extending to lesser curvature like this. And maybe this is the most proximal part. Here, slight depression, like this. So then we really check whether it is early gastric cancer or not. So I switch to NBI. It is very important to start from surrounding mucosa.
From normal to abnormal?
Yes. Usually we compare the surrounding mucosal pattern to non-neoplastic to neoplastic. Okay. So initially we have to evaluate non-neoplastic mucosa, very regular structure, and then gradually go toward the lesion. So that now you can see the irregular vessel here, like this. So actually there is a definite depression in this area, demarcation line. But when we switch to NBI, irregular vessel slightly extend outside the demarcation. You can see.
So these, can you comment on this vessel pattern? Like, is there any network formation, or is it called?
So you mean the histological type?
Yes.
So to evaluate histological type, usually we see presence or absence of microsurface structure.
Exactly.
So basically, if it is differentiated type, we can see epithelial pattern. So I mean that like this type of whitish band-like structure. If we can see that finding, it is differentiated type. But in this case, we cannot really see whitish band. This part we can see, but I think this is degenerative non-neoplastic mucosa in the central part. But the surrounding part, we cannot really see the surface structure. So non-absent surface pattern. And then when we look at the irregular vessel, it does not really network like a corkscrew pattern.
So there is two patterns. One is network pattern and non-network is always corkscrew. So this is an undifferentiated cancer.
So according to NBI image.
So this is mostly unresectable. We are dealing with a case.
If it is undifferentiated type, indication criteria for endoscopic resection is less than 2 centimeters.
Yes.
Mucosa and no ulceration. So it definitely larger than 2 centimeters.
More than very extensive. And on white light, it appears little pale mucosa rather than reddish.
Yes.
So if you switch to white light, so everybody can see that from white light it is not that much reddish. In the middle part it looks little.
Sometimes some area it looks reddish, but such area is non-neoplastic generative mucosa. But when we look at this absent area with absent surface
pattern
and then irregular microvessel, this area is little bit paler than the surrounding mucosa. So I think this white light diagnosis also undifferentiated
cancer. Yes.
So and then maybe next is depth of invasion.
And for the audience, we are dealing with a female patient. She is a female.
Yes.
Where undifferentiated cancer is more likely.
Yeah. And then maybe atrophic mucosa really extend almost near the.
Dr. Mohan is asking ESD can be done or not. Mostly 100% no in this case because most likely this is an undifferentiated cancer, extensive
more than 2
centimeter. It must be more than 7 centimeter.
And then next we evaluate depth of invasion. So in that to evaluate depth of invasion, we have to insufflate the corpus or stomach.
So non-extension sign you are describing.
Yes. And then this maybe.
Please describe the non-extension sign.
Then if the lesion is intramucosal, lesion is well bended and then stretch well.
And we should give maximum air.
Maximum air.
Maximum air in suppletion. And there is stretching of the surrounding mucosa in the invasive lesion. And the lesion protrudes out.
Yes. And when it is submucosal invasive cancer or more, when we stretch the mucosa or gastric wall, the lesion protruded into the lumen.
Hello, Dr. Ashutosh, Dr. Chabra here.
Yes.
You are saying this is an undifferentiated.
Yes.
Only on the basis that you don't have network microvessels.
No, not because of three things.
Yeah.
Female patient, corkscrew vessels, pale mucosa some areas.
It is not pale. It is a reddish mucosa.
Corkscrew vessel is pathognomonic of undifferentiated cancer.
You see the main difference, okay, I agree the corkscrew vessels, but the density of vessels is so high, which is usually less in a poorly differentiated, undifferentiated cancers. I don't know, Dr. Vedo would.
But Dr. Yodo is telling these are not network pattern. Dr. Yodo is telling these are.
No, this is not a network. I agree.
Yes.
So the lost.
So is it corkscrew vessel or not?
Yeah, corkscrew vessel.
Yes,
and then
vessel.
absent microsurface structure plus.
So again, there is one point: absent microsurface pattern and corkscrew vessels both are in favor of undifferentiated cancer. Is it right?
Okay. But diagnostic accuracy is according to data is 82 or something.
Okay. So we are not 100% sure in any case.
But
okay.
But I'm quite sure. Even biopsy show that differentiated type, but some portion must have a undifferentiated.
So can there be in one lesion both differentiated and undifferentiated part? Is it possible?
Yeah, possible.
Yes.
Yes.
So if we take from one lesion, one site, in the same lesion may show differentiated, in some site may show undifferentiated.
Can you show some microsurface pattern within this lesion? Somewhere where it is preserved, where you can still see some microsurface pattern somewhere?
Maybe this part we can see.
Yeah.
Maybe even. Yeah, intestine, but I think this is
there is some
regular
mixed
vessel.
pattern also.
But most of the part, epithelial structure is lost.
No surface pattern here.
But the surrounding mucosa is showing intestinal metaplasia.
Surrounding mucosa, I think here non-metaplastic.
No, Dr. Chabra, do you agree? Same lesion can, there are instances where in the same lesion we can find a mixed type, like.
Yeah, that's not 100% corkscrew vessels.
Yes.
You may find the other pattern also in a purely different shape.
I think this area may have epithelial structure, surface structure present. So this can be kind of combined or mixed type.
That's what.
So usually originally it developed as a differentiated type, and then over the time they differentiated to other undifferentiated type. But anyway, such large lesion, I think it's not the indication of ESD. Maybe technically possible, but the high chance of additional, non-curative resection. And then, so I think this type of lesion, the curative treatment is surgery. We have to ask GB Rao.
Yeah, thank you, Dr. Noria, for that excellent demonstration, and thank you, Dr. Ashutosh. We move on to next case by Dr. Rajendra Singh.
Other room.
History, please.
Our next case is 64 years male, known case of ulcerative colitis for more than 10 years and was on mesalamine maintenance. Now he had complaints of increased stool frequency since 3 months. Now posted for colonoscopy. Plan is colonoscopy shown active ulcerative proctitis with nodule suspicious of dysplasia. So we plan for chromoendoscopy.
Okay, hi, welcome back. We are now, you heard the case, and what we are doing is, we just started the procedure like while we were presenting the case. So I'm not gonna get to the cecum, but I'm just gonna show you how we would do what's called as chromoendoscopy, alright? So if you have a patient who's got long-standing ulcerative colitis for more than 8 years, then that's something called a red flag where you need to understand that you need to do a bit of chromoendoscopy or what's called as surveillance at least every 3 years, alright? And why you have to do that is to pick up dysplasia. So that's important. So once they reach the 8-year mark, for patients with pancolitis, you would have to involve them in a surveillance program. All right. Now the surveillance program involves obviously a colonoscopy every 3 years, and as the duration of disease increases, meaning they had it, let's say, for 15 years, you may want to reduce that surveillance to every 2 years. And if they go beyond 20 years of having the disease, then you may have to even start surveying them every year. All right. Now, how do you survey them? You can do a few things. You can use electronic chromoendoscopy, okay, like NBI. You can use them, or you can use chromoendoscopy as you have seen here. So what we are doing is, when you do chromoendoscopy, you try to envelope the entire sort of lumen as best as you can in the anti-gravity side. So I'm just flushing in the anti-gravity side, and then you suction things out, and then you look for any potential areas which appear to be more red than usual. All right. So red means dysplasia. The reason you do that also is to basically irritate the mucosa, but what you need to do is you need to ensure the patient has got quiescent colitis, meaning the colitis is under control before you start surveillance. If they've got active disease,
then surveillance should not be done. All right, so how do you dilute this? You need to work out your own concoction, and basically what we have done here is we use 10 mils of 1% of methylene blue into about 250 mils of saline. All right, that's what we're using here. I think this can, it really depends on your local institution and what methylene blue concentration you use. I think in this instance we could use a little bit more concentrated methylene blue. All right, but the concept is that you use methylene blue with a diluted sort of concentration, and the reason you do that is to basically try to pick up areas of dysplasia. All right, but today what we're going to do is we are going to just come back to where you all saw the lesion. So this patient, as you heard, has got colitis over the last 10 years, and you can actually see what we mean when we say that dysplasia appears to be a bit red. So you can actually see the change there. Can you all see? I can't hear, but hopefully you can actually appreciate that the dysplasia not only is at the nodular part, but it's also extending here where there's a loss of the pattern. Okay, but I'm just going to go back slowly first and try to see if we can look at the lesion per se as a whole, because the lesion certainly does not look very good.
Dr. Rajendra, is there a reason that we prefer chromoendoscopy over digital chromoendoscopy?
I personally do not like to use chromoendoscopy, to be honest. I think you can see things with good quality white light endoscopy or electronic chromoendoscopy. All right, I think you can do that. So I personally would not use chromo, but there are some trains of thought to suggest that you should use chromo. And lately the school of thought is thinking that perhaps if you use chromo you can pick up more dysplasia, but I think the data is still not out there.
But remember, the scenic guidelines still recommends endoscopy as a standard.
Yeah, scenic guidelines is good, but it is about 10 years old now. All right, so I think they need to work on things. Scenic says chromoendoscopy is good if you use standard definition white light endoscopy. In this day and age, we don't use standard definition anymore. We use high definition, as you can see there, and you can actually see that with high definition scopes, you really don't need to have sort of chromo. I feel it gets in the way, if you ask me. All right, but the problem with this patient is I'm just using the water flush to clean all of this mucus, because the important thing about dysplasia is this, all right, and this is something you must understand. There's no more something called darm lesions anymore. There's no darm lesions anymore. Your dysplasia is either endoscopically visible or endoscopically invisible. If it's endoscopically visible, meaning you can see the margins very clearly, then it is endoscopically resectable. All right? So think about that carefully. If the dysplasia is not endoscopically visible, you cannot clearly find a demarcation line, kind of like this patient here, then you are dealing with something which is more extensive than what it is, and you may be subjecting the patient to an unnecessary ESD procedure. In this instance as well, the problem is there's active disease distally. So that makes our evaluation of re-evaluate this patient to see whether all of these false positive signs over here are actually just disease, and what we're dealing with is basically an area of dysplasia, which is this nodule here. Because if that's the case, then we can perform an endoscopic submucosal dissection and remove this. All right, and ensure that the patient at least maintains continuity of their bowel, and they don't end up with having a surgery with lots of issues and complications after that. All right, so I think that's one very key point. So how do we do that then? first we have to prove that there is actually active disease. So we have to take lots of biopsies around this area here and see what it says. And then we may need to upscale this patient's medications. Patients on 5-ASA now, there's a train of thought whether we should give the patient some steroid enemas, as well as maybe even put the patient on an therapy agent, immunomodulator like azathioprine. Gradually, the patient is probably about 70 kilograms in weight, so we have to get a dose of about 150 milligrams to 200 milligrams gradually over a period of 4 weeks, 4 to 6 weeks, to control the disease activity and then to reevaluate, because we don't know whether this dysplasia here is a sporadic one and whether there's something happening here. All right, because this area here is very difficult to determine where the actual border is. Anyone has any questions? So you can see a lot of disease activity there, and this on NBI.
So there is an in-house announcement. If somebody wants to have a cup of tea, please you can go and grab. There is no official tea break. So you can go out, and kindly don't bring the cups inside the hall.
Okay. Okay, you all heard that. Okay, any questions on IBD? So you can actually see again, the margin is not clear. Okay, there's a lot of erosions. Margin is inconspicuous. So you want to take lots of biopsies here to ensure this is active disease. All right, because you want to make sure it is not dysplasia. Because if there's dysplasia here, which quite likely is this case here, then you want to make sure all this inflammation heals. All right, because if you cannot clearly demarcate the margins, there is no point in doing an endoscopic resection. Okay, there's no point. You're just going to make things worse. So control the disease activity, and I would say re-evaluate this lesion in about maybe 6 to 8 weeks once the inflammation settles, and then see if we can identify the margins clearly with a view of doing a resection. What are your thoughts?
Yeah, so I think that is how it works. So you take biopsies from the most suspicious area and also take biopsies from the surrounding area to see for any histopathological evidence for ongoing inflammation.
Yeah, that's there. So you can see that this is obviously not normal compared to the other areas. All right, but this could be an inflammatory nodule. All right, because of all that inflammation. So IBD is very, very difficult to have a classification. Nobody knows what the right classification is, to be honest with you. Nobody really knows. So you can see this could be an inflammatory nodule. All right, but we may want to take biopsies there. And we're going to go to this other lesion here, which looks quite nasty, but you can see erosions around the area here. All right, there are erosions there, but you can see that this has got lots of granulation tissue. It looks quite dirty. You can't really appreciate the pit patterns. This is underwater, so we're having quite good levels of magnification here. In fact, this is maximum magnification with a bit of chromo, so you can see dye floating around, and then you can actually not clearly appreciate any semblance of a pit pattern. You can see what's below, but you can't see the lesion pit pattern at all. All right, so it's concerning, but in order for us to remove this again, I would recommend that the disease activity around gets sorted out first.
Thank you, Dr. Rajendra Singh. Sir, we are shifting to next room. We are ready with another interesting case.
Yeah. Thank you. All right, so we'll take biopsies, guys. Can we?
Our next case is 54
we
years.
have shortage of time, so those who want to take tea can go there, but simultaneously we'll continue our live. This is the last case for this session.
Our next case is 54 years male with complaints of dyspepsia and epigastric discomfort with past history of H. pylori related atrophic gastritis and intestinal metaplasia. and had a polypoidal lesion in gastric fundus for which he underwent EMR in 2024. Now his recent endoscopy has shown antral gastric atrophy with a polypoidal lesion in proximal anterior wall around 3.5 centimeter. Now planned for diagnostic upper GI endoscopy. Over to Dr. Monish.
Good evening, everyone. So we have this very interesting patient of atrophic gastritis, and he has some flat elevated lesion which is seen proximal stomach on the anterior wall, and Dr. Vedo is going to describe. I think this patient has very interesting findings. Dr. Vedo.
Yes. Hello. Can you hear me? So now this is cardia, and then there's some erosion or something. Maybe it caused malleolus tear or something. But anyway, when we insert the scope into the stomach, now you can see this type of very beautiful surface structure lesion. And then when we insufflate the stomach, as I mentioned, that basically normal stomach has a gastric folds, but this patient, gastric fold is completely lost here and there, and almost everywhere. And then lesser curvature side still little reddish mucosa is remaining, like an island or peninsula. And then when we proceed the scope, I scratch this mucosa with a scope, so that is, it causes contact bleeding. But anyway, here is also atrophic. And some kind of island, like slightly elevated area is seen. And then lesser curvature side also atrophic. And then posterior wall side, there's some very thick mucosa, and then gastric fold is remaining. So, and then when we proceed the scope to the stomach, antrum looks quite normal. Maybe I didn't explain much about the normal antral mucosa, but actually there is very smooth and homogeneous color. Previously, I explained that H. pylori gastritis usually have a very mosaic pattern of elevation or like an uneven mucosal surface, and then mosaic color, reddish and whitish. But this mucosa looks very normal. And even when we switched to NBI, we didn't see whitish patches which indicated for intestinal metaplasia. So if this patient is H. pylori associated gastritis, a patient with such extensive mucosal atrophy, he or she must have an intestinal metaplasia in antrum. So I suspect his atrophy is not associated with H. pylori infection. So I'm a little bit suspicious for autoimmune gastritis because antrum looks quite normal. Even like rather similar to corpus mucosa, rather. And then only near the pylorus, you can see the ridge, like normal antral pattern.
Yeah.
So I think a distal part of the stomach is quite normal. And then sometimes autoimmune gastritis, atrophy becomes a little bit uneven. And then something called remnant oxyntic mucosa. So in some part, most of the part is affected by autoimmune pathogenesis and make the mucosal glandular portion of oxyntic mucosa was lost. But as I explained in a previous presentation, maybe some parts still round surface structure, little bit remaining, or some part looks like little bit intestinal metaplasia. So as I mentioned, like end stage, even autoimmune gastritis, we can see the intestinal metaplasia. So just according to my observation, patient has a very extensive atrophy in the corpus, and then some part, maybe non-neoplastic or non-metaplastic or non-atrophic. You can see this part has a little bit elongated, but basically cryptorefized pattern, which is similar to non-metaplastic mucosa and corpus mucosa. So some part oxyntic mucosa is remaining. So and in this background of mucosa, this part has a biliform structure and no irregular vessel or no irregular surface pattern is available, but I suspect this is a neoplastic lesion because, as discussed with Mohan, sometimes H. pylori gastritis intestinal phenotype neoplasia is developed, so well demarcated, and then it shows irregular vessel or but sometimes gastric phenotype lesion sometimes show this it resembling hyperplastic polyp. So maybe we take biopsy and then ask pathologists about the opinion.
But on endoscopy, if we have to describe this lesion, it is a very, we'll say, regular microsurface and regular villiform pattern with regular microsurface and regular microvascular pattern.
But when we look at the especially central part, the size of papillae is really not uniform.
Irregular, the central part.
Yeah, some part large.
We see on the left sides, the microsurface pattern becomes smaller,
yes,
more dense, micrified.
But not really compare this small area and then large area, but even inside the large area, some papillae is very large and then little bit irregular shape, and some are small and then very heterogeneous. I think this represents some characteristic finding of neoplasia, I guess.
Okay, Dr.
Yes.
Noria and Dr.
Take biopsy,
Monish, please take the biopsy and we'll continue here with our lecture.
Yes.
Thank you very much.
Yes.
Thank you, Mohan. There is another entity called as foveolar cell carcinoma.
Thank you, chairpersons.
Could
We would like to
usually,
invite chairperson
gastric
for the next session.
Neoplasia with gastric phenotype is like this. Yeah. Foveolar, yeah.
So the next session is colon, IBD and rectal
Which
cancer
looks
workup.
very
We would like to invite
inflammatory, like
discussants.
resembling the
Dr.
hyperplasia.
Madhura Prasad, Dr. Rajesh Sandil, Dr.
But if
Ayaz Habib,
you would have
and
seen
Dr.
this lesion
Sandeep
on a
Pandey
background
on
of
the
a
dais.
normal mucosa, what would have
Also,
been
we
yours?
request
but
them to introduce the
this
new
type of
speakers.
size, and then hyperplastic polyp usually should be 1-2 centimeter polypoid lesion. It cannot be like a very sessile.
So which would be the ideal site here to biopsy? If
maybe central. Yeah.
Okay.
But I think it's better to inform such endoscopy finding to pathologists.
Okay.
Otherwise, sometimes small specimen cannot really differentiate from.
Should this be removed?
I think so. Yeah. Difficult, but maybe I think Honchi previously performed,
The same case?
yeah, like a gastric type, and then and the background of
The chairpersons to introduce the next speaker for the session.
It's a pleasure to invite Dr. Naresh Bhatt for the JNET and NICE classifications. So the stage is all yours.
Thank you and good afternoon, friends. Just a little deviation. I'm not going to speak too much on them. I'm just going to discuss how good or how not good it is. So is it perfect or just good? when we see a polyp, we'd like to predict histology, we'd like to predict the risk of development of cancer, assess possibility of deep submucosal invasion, and of course plan our resection strategy. Initially they started off with dye-based procedures, and we had the famous kudos pit pattern, where it's still used in limited settings. Then we had this paper when NBI came in the early part of this century. Professor Yasusano showed that you could differentiate adenomatous from non-adenomatous or neoplastic versus non-neoplastic polyps just by seeing the capillary mesh network on the polyp. So that opened a new door, and so finally they gave up this idea of doing dye-based chroma-endoscopy for everyone, and they introduced a fairly simple classification called the NICE classification, which had type 1, 2 and 3, which was simple. This could be used without magnification. It said type 1 is hyperplastic, type 2 is adenomatous, and type 3 is cancer. And then they said you decide treatment options based on this. However, what happened is that ESD started getting popular, and people were keen on knowing whether this type 2 was only adenoma or it had cancer or even involvement of the superficial part of the submucosa. So when this study came out, which showed that magnifying endoscopy with NBI was almost as good as doing magnification chroma-endoscopy, people then used this knowledge, which Professor Sano put out again, his classification where he said type 2, CP type 2 was adenoma and type 3A was an intramucosal cancer. So they married the classifications with a lot of discussion, and that is NICE 2, which encompassed both adenoma and intramucosal cancer, was then split by the Japanese expert team into type 1, type 2A and 2B. 2A reflected adenoma, 2B was a more advanced kind of lesion, and where because it involved the submucosa, you couldn't do just an EMR, but should consider an ESD. And of course, type 3 meant that you sent them for surgery. So this is almost about 10 years old, and I'm sure most of you are quite familiar with it. But at 10 years, let us look at how these perform. If you look at protruding lesions versus flat lesions, you find that whatever lesion is protruding, even if it's actually a hyperplastic or a sessile serrated lesion, if it's protruding, it often gets misclassified as JNET 2A. And hence, flat lesions are better assessed with a JNET classification. Second, when you have a large lesion, the depth of invasion is difficult to assess compared to non-polypoidal lesions using JNET. And again, larger lesions, you cannot interrogate the whole surface at times. There may be mixed or overlapping vessel patterns, and peristalsis can add to the confusion and cause secondary changes leading to ulceration, which can again confuse the endoscopist. So these are some of the problems of the JNET classification. The Achilles heel of the JNET classification is the type 2B lesion. If you look at type 1 and 2A, the correlation is pretty good. But if you look at 2B, the spectrum of pathology can extend from just simple low-grade adenoma to high-grade adenoma, intramucosal cancer, superficially invasive cancer, or even deeply invasive cancer. Which means 2B is a heterogeneous group both in protruding and flat lesions. And hence, this is something that needs to be addressed beyond the JNET classification, and that is what is recommended, that if you have a JNET 2B lesion, because the sensitivity is poor, you need to interrogate it further, going back to dye-based techniques using crystal violet, and then you find out whether it's a non-invasive pattern, whether the surface pattern is fairly regular or it is irregular, which means that JNET 2B is heterogeneous and still needs some other modality, and hence, therefore, far from being perfect. If you look at the morphology of polyps, if you look at high-grade dysplasia, if you find a polyp which has got a depressed area, that is the last kind of column, you find there's a very significant number of these patients have high-grade dysplasia when you have a depressed or a type 2C morphology. If you look at deep submucosal invasion, the same thing. If you have a depressed component there, it is more sinister. If you use this same analogy in lateral spreading tumors, you find that if you have a depressed or a pseudo-depressed pattern, the chances that there is deep submucosal invasion, especially a largest polyp, is extremely high. Similarly, that is, this kind of lesion looks superficial, but it's got definite cancer. Similarly, if you have an LST with a dominant nodule, it may look like 2A, but the chances that there's deep submucosal invasion is very high. What does this simply tell us? It tells us that the diagnostic yield is good in type 1, reasonably good in type 2A, but performance is pretty bad in type 2B and 3. Here the sensitivity also can be low. The specificity may be high, but the sensitivity is low. That means that here we have a situation where you can use all your skills, but you can still be wrong. So can we get more confident in diagnosing T1B cancer? That is extending deeper in the submucosa. And I would like to bring to your notice this very interesting paper that came out just this year. Is the diagnostic concordance using the JNET expert team. The same group got together and they looked at a set of lesions, just the images, and this is what they found. They also used secondary findings beyond JNET to see if they could predict deep submucosal invasion. These are scattered vessels. They were thick linear or meandering atypical vessels or demarcated areas. And interestingly, they found that the first group, that is the sessile serrated adenomas, hyperplastic, very good concordance, 80%, all of them agreed. But if you look at the spread, even in 2A lesions, which is just the typical tubulovillous adenoma, or you had the more advanced lesions, the concordance was very poor and they were right or agreeing only about 40 to 50% of the time. And when they added other factors like using white light endoscopy, looking at the morphology of lesion, is there a depressed area, is it an irregular shaped area, or are there these secondary findings that I discussed, they helped in reclassifying lesions, which meant that you cannot depend only on JNET to give you a very sort of strong predicting value. You have to look beyond. You have to look at the morphology, look at the total picture, and that is what is important. We know about sessile serrated lesions. There's about 20% of colorectal cancers go through that pathway, and JNET doesn't talk about it. Raj will, so I'll leave that to him. People have started to marry the Hayes-Winkel criteria and the NICE and come up with the WASP criteria to predict whether it's a plastic polyp and sessile serrated lesion or adenoma. But if you looked at the experts, this is Professor Sano and many of his colleagues, they did a study on JRET1 polyps over 6 mm in size, and they found that 20% of SSLs would be misdiagnosed as hyperplastic polyps and left alone. This can be disastrous. The usual criteria that we use to call it SSL were too non-specific and occurred in hyperplastic as well. So even for experts, accurate differential diagnosis of SSLs and HPs using magnifying colonoscopy was challenging. So to summarize, nice classification useful. If no magnification is available, use chromoendoscopy if you wish, the dye-based. You can use JNet, which is good with both zoom and dual focus scopes. This has been validated in several studies, including in our center in India. They found dual focus scopes almost as good as zoom scopes. JNet has issues with JNet 2B, large protruding lesions. Serrated lesions, of course, are not addressed, and therefore the simple message is morphological details with Paris classification and chromoendoscopy are still relevant in today's time. Thank you.
Thank you. Thank you, Dr. Naresh. We will have the discussion at the last. I'd now like to invite Dr. Rajvinder Singh, who is going to discuss about the serrated colonic lesions and the detection, the characterization, and the resection strategy. Over to Dr. Rajvinder Singh.
Can I get some help with AV? Can somebody with AV help me to just put this? I just like to just take the HDMI. HDMI. No, not that. No, that one won't work. The HDMI. This will work. One earlier we tried. Yeah.
This one?
Yeah, yeah.
HDMI?
Yeah, here on this side.
Okay.
Okay. Yeah, just straight in. Yeah, it will work. Okay. Thank you. Okay, thank you. Thanks, and sorry for the slight AV issue. So we'll talk about SSL, and I must say that it is quite difficult and challenging. So I hope you've all enjoyed the workshop so far, because I have, and I've learned a lot, and thanks again to Mohan. So I'll just start off with this video. You can actually see a lesion next to a diverticulum, and if you look very closely, you can see that it's got what's called as a very mucus-like cap, which was removed. And also, I'll just stop over here. You can actually see that the lesion is nodular, but just not too dissimilar to the patient which we saw as the first colonic case today. If you don't look carefully, you may miss a lateral component. So this is with NBI, and you can see that it's a lateral flat component, an inconspicuous margin, sort of spidery vessels, and this was then successfully removed using cold snare EMR technique, which I hope we can demonstrate at some stage in the workshop over the next 1.5 days. So this is just a cold snare being done, and the reason we do that is because with SSLs, this is the best technique to use, and also that it's very close to the diverticulum, as you can see there. So we ensure that we get good clear margins. If you use a heat current and you're not very careful with the margins, then you have to be careful that you don't infiltrate and apply current on the diverticulum itself. All right, so this is actually quite a nice case, again, of a patient with an SSL with lateral extension close to the diverticulum. So I'll try to look at this overview and then give you some insights with regards to some of the concerns we have. You may have heard from Naresh with regards to the WHO classification of serrated polyps. So not sessile serrated lesions, but serrated polyps. It's hyperplastic. You've got the SSLs and SSLs with dysplasia. and you got a traditional serrated adenoma. So this is the WHO classification. I'll just be concentrating on what's in red. You also need to know some important considerations, including clinically significant serrated polyps. All right, so they are hyperplastic polyps more than 1 centimeter anywhere, more than 5 millimeter proximal to the sigmoid, or a TSA or SSL of any size. And serrated polyposis syndrome is something which you have to also understand if patients have got more than 5 or more than 20 serrated polyps. I won't go into detail with that, but you need to know these classifications. The family history criteria for SPS has been dropped after 2019 by the WHO. What are the concerns? They progress quickly. We are worried about this. We are often missing them. They're difficult to detect. They are difficult to resect as margins are not very clear. And not all SSLs are created equal. And it's very important, this new concept has come with regards to SSL detection rates or SSLDR. So we heard about the molecular pathways. 1/3 of cancers come from the serrated pathway. You have to understand that. And they go through these different mechanisms in play, including the CIMP and MSI, or the CPG island mutilator prototype. So this is courtesy of Dr. Sano, which shows that it slowly progresses from a microvesicular hyperplastic polyp to an SSL with dysplasia, and then cancer with an accelerated, rapid Lynch-like progression. Okay, so you must understand that. You must understand that compared to non-interval CRCs, interval CRCs or interval colorectal cancers occur more likely in the proximal colon. They have got MSI and associated with CIMP. And in this large study of more than 80,000 patients, they found that cancers were diagnosed within 5 years of colonoscopy, and they were 2 times more likely if these cancers which were picked up if they had CIMP positive and they are microsatellite unstable. So more or less in keeping with serrated lesions. All right, so the dwell time is important. And what I mean by dwell time is, even though these lesions are seen, they remain dormant for more than 10 years sometimes. And they only become dysplastic after a duration of about 1 year. If they are dysplastic, that is. So from no dysplasia to dysplasia, 10 or maybe 15 years. Once they are dysplastic, they become cancer sometimes within 1 to 2 years. So if you miss a SSL with dysplasia, you better be careful. That patient will have a cancer very quickly. And this graph demonstrates that as well, where the sudden spike occurs after a long period of time. They almost sort of follow on from the adenoma pathway 10 years later. Right, so it's a bit different from the adenoma pathway. And this systematic review says if you find one, you better make sure you look for others, okay? Because the higher odds you're going to find other SSLs in these patients. So this is so important in more than 34,000 subjects. So see one, you better look for more. Detection is an issue. For instance, you see this, it's hard to know where the SSL is, all right? Unless, of course, when you draw things, it looks really good that it's there. But sometimes if I draw something over there as well, you think there's an SSL, but it's just a tactic to present. Anyway, we remove this. What is our local data? So again, thanks to Hardik, I was communicating with him quite a bit prior to this. I know Mohan is very busy, but you know, this is a study which has come locally from your place, Ashutosh, Odisha. The SSL DR rates is 2.5%. It's quite a good study. I could not find any other studies in India to look at the SSL DR rate. So it's something which could be interesting for some of you young budding gastroenterologists or junior consultants to take up as a research project. So they're often difficult to distinguish from hyperplastic polyps, as you would have heard from Naresh. There's a lot of inter-observer variation as well. You take it off, the pathologist tells you something else. And in this study, interestingly, from 32 centers in the United States, where all the trouble begins, as I suppose. Anyway, you can see that 10 out of 32 centers did not use serrated in their pathology reports at all. All right, so they're not even being reported by some centers. So variation among pathologists, 13 times, right? 13-time variation amongst different pathologies. Between endoscopies, unfortunately, 8-fold. But later studies show up to 22 times differences in SSL detection rates. All right, so The benchmark, though, is 6%, as I presented in the earlier presentation. This is from Western data, though. We must always take these SSL DRs, these ADRs, and all this other funny sort of short-term mnemonics with regards to our local population rather than looking at the Western population. How to improve? Obviously, longer withdrawal time, but you can't stand there for 20 minutes. So you have to kind of look and think that perhaps an 8 to 9 minute withdrawal time is necessary. Endoscopies with higher ADRs have better SSL detection rates, but not necessarily the case though. So if I put it another way, you've got high ADRs, you may not have a high SSL DR rates. If you have a high SSL DR rate, you can be sure that person has got a high ADR rate. All right. It's very interesting because maybe our mind is fine-tuned to looking at polypoid type lesions in the colon and not flat lesions. All right. Look into the right colon twice, and as I said, if you find one, you better look for more. This is AI. I put it really small there. Can you see that? Can AI really help? Yeah, because it is useless. Okay, that's why it's not in big bold letters. This is an endoscopist, the famous Dr. Rex, trying to tell AI there's an SSL there, but AI doesn't want to listen, so there's no square, there's no line being drawn. He even put some fluid and say, please tell us it's there. But AI is not looking at it. AI managed to pick something up though. I think it picked up a small polyp elsewhere. See, look at this SSL, AI is not picking up. Yeah, so this is a nice case. SSL, AI is not picking up a small polyp there, but not that large SSL. Only later on it does, but that's after it's been lifted. So how do you improve? You can use NBI. I think that's useful. This study shows that, but there's no statistical significance in this study done 10 years ago. We looked at TXI in our study, which we published in Gastroenterology last year. And SSL actually tends to come up, and it's quite interesting. We found that we can pick up more flat and right-sided polyps, and we also found that it doesn't matter between high and standard detectors. There was also an incremental gain using TXI to find these lesions. All right, so our SSL detection rates were about 10% with TXI compared about 6% with white light. And we didn't unnecessarily pick up hyperplastic polyps and take them off in the TXI group as well. So we're not only finding more SSLs, but we're not finding more hyperplastic polyps, which will lead to unnecessary polypectomies. Characterization, you heard about NICE classification, and NICE is unfortunately all over the place. In Mike Wallace's editorial, he said ultimately their conclusion is that it sits somewhere between NICE 1 and 2. I think it's not so nice of a dilemma. That's what I would put it as. So you can't use NICE. You can use some of these features, and you can actually see that if it's got a mucus cap, it's got an open pit, inconspicuous borders, telangiectasia, then that's in keeping with an SSL. This is our classification we came up with 13 years ago. SSLs, which is a hyperplastic polyp, is always well circumscribed, and SSL is not, and it's got open pits as you can see there. So type 2O pits and inconspicuous margin. This is a nice video, and I hope I have a bit of time just to show you, because I think this is important. So after you flush an SSL, you can't see it, all right? So be careful. Don't go and look somewhere and talk about something else, and suddenly you find the SSL is not in front of you. So this is with NBI, and after NBI you can see that cloud-like surface, inconspicuous margins, and as we put in the magnification, you can see that the pits open up. See, the pits are opening up, and then one of the pits decides to extrude some mucus. See, it's like a volcano there, and there's mucus on it, as you can see there. So pit with mucus. All right, so this is quite a nice video which I use. Just be careful of SSLs which looks like adenomas, because this means the SSL has changed and become dysplastic. All right, so you have to be careful if you see that. So I go to resection very quickly. This is the CARE study. Everybody knows about it, basically saying with SSLs in the good old days, the chances of taking it off properly were fairly poor if they were large. Okay. And this is just an example. Old picture, looks like an adenoma. Take the snare, take it all off. All right, and then with a better definition scope, you can actually see something else brewing. See that? That's the lesion which was seen. This is a large SSL. and that's the adenomatous component, and that's the sessile serrated component. So you have to be careful when you do this because we need to resect it very carefully and cautiously. All right, so how do we take this off? All I can say is that cold snare EMR is the way to go. All right, it is the best, it's easy to do, and we can take off lesions which are fairly large fairly quickly within a minute or so using this cold snare EMR technique if you have got an SSL, and this is a scar which develops after the resection. How do you do it? This is an adenoma, but I'm just showing you the basic tenets of cold snare EMR. Use some injectate, use a bit of adrenaline, include a normal rim of mucosa, firm downward pressure using a specialty 10 millimeter thin wire snare. All right, that's important. Cut and time it with your assistant. Don't be greedy, don't take a lot. All right, take in small pieces. It's okay because you're going to take it off piecemeal anyway. Use a water pump, as you can see there. Repeat with the edge of submucosa and the polyp and inspect the defect if you're not happy, and go and cut further. This whole sort of polypectomy took about 3 or 4 minutes to do. Quite a large lesion, easily done. All right, sometimes the margins are inconspicuous and you don't know what to do. In this case, we knew there was a dysplastic component, so we went on and did an ESD for this patient. All right, so you also have to bring patients back, and you can look this in detail in some of the publications. So take-home message is SSLs are often missed, difficult to detect, but can be done if we remain vigilant. Know your SSL detection rate. So again, go back, try to start some audit process in your respective units. I think that'll help. Once dysplasia is detected, I showed you data in that 34,000 patient study. It progresses very quickly within 12 to 24 months. So beware. Adenomas can masquerade as SSLs and vice versa. So you have to ensure careful evaluation. SSLs are easy to resect using the cold snare technique. They lift very, 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 very easily. But they've got a high recurrence rate if you're not careful. So meticulous technique with the cold snare EMR technique. So with that, if you need some references, these are some of the papers we published. If you have the appetite, come to Australia in the next 2 weeks for our endoscopy masterclass. Just before I end, I'd like to show you this picture. So this is how we can detect lesions or people in this case. This is the first imaging symposium which was done here. And you see Dr. Naresh Bhatt is still looking the same. So he's never aged. And then we've got Amit, we've got all of Mohanis, we've got all of the others, Vikram as well there, and of course Rupa. So you can detect SSLs as you can detect how all of your consultant colleagues are here. So thank you very much.
Quite an enlightening lecture, but sorry for the paucity of time, we won't be able to take any questions. And with that, we end this session. Thank you.
Thank you.
Thank you, Dr. Rajwinder and all our chairpersons. I would like to call the next set of chairpersons, Dr. Nitin Jagtap, Dr. Shubham Mehta, Dr. Kiran Peddi, and Dr. Savan Bhupna to introduce our next speaker.
I would like to invite Pada. Pada has done extremely important and high niche work in field of IBD, has been doing for last few years. Over to you, Pada.
Thank you so much. Thank you so much for this invitation to talk about dysplasia and IBD, which is a topic very close to my heart. So with this, I think, can you play the slides? I think the stage is perfectly set for this talk because I think we had a demonstration with ulcerative colitis and there is a lot of unanswered questions and I'd like to answer them in my presentation. Also, we discussed conventional and unconventional dysplasias like sessile serrated lesions. We'll see how that works in IBD as well.
If you want, there in the backstage. Meanwhile, we'll
uploaded there. Sir.
Uploaded.
Uploaded.
Oh. Then. Yes.
So thank you. So dysplasia in IBD. IBD patients are at increased risk of developing colorectal cancer, that is 2 to 3 folds as compared to the normal population as per the population-based study. Chronic inflammation is the driver of neoplastic progression. It is not the single colonoscopy. It is the histological inflammation over the period of multiple years, which is called cumulative inflammatory burden, which is the predictor of neoplasia here. And the speciality of this is it can arise in multiple areas of the colon, which is due to field cancerization. I'll come to that shortly. The pathogenesis of IBD and the dysplasia are not different. Not only because of the pathogenesis, it is genetic, host immunity and microbiome. It has implications for risk stratification as well as how to manage these patients. And dysplasia is the most important risk factor for colitis associated cancer, and endoscopic detection and resection may differ and avoid surgery and also refer to surgery. Inflammation control, identifying the risk factors, and endoscopic diagnosis and treatment are the way forward. So let's see how the evolution of dysplasia management has evolved over time. So first we have the physical examination only. We used to do PR examination, then came the barium enemas, then the fiber optics, digital scopes, then the high definition scope, then the chromoendoscopy. The primary detection, lesion detected changed from metastatic disease, mass tubular colons, mass DAMs, then polypoidal lesions, raised lesions, abnormal pits, mucosal defects, and flat lesions with chromoendoscopy. Intervention changed from prophylactic colectomy to finally resection with intense surveillance now. And the outcome has changed from death, insensitive to early cancer. Now we are detecting early cancer. Invisible dysplasia, now that is also becoming obsolete. From random biopsies, we are going towards targeted biopsies, and we are taking fewer targeted biopsies more importantly. So we are moving from colectomy, DAM, invisible neoplasia, random biopsies to endotherapy, visible lesions, and targeted biopsy. So here the key is accurate re-stratification, then accurate detection of precancerous lesion, and adequate management of the lesion. With this, you can achieve the outcome of interest. That is, improve the quality of life and the overall life expectancy of the patients. So why the dysplasia is different? Because you can see in the early event in normal colorectal neoplasia is the APC mutation, whereas P53 mutation occurs late. Why is that? Because there is continuous cycle of inflammation and repair. So P53 mutation occurs earlier in that IBD, and that's why there is field cancerization. I will come to that later, and it can be flat, multifocal, and invisible. That's why it explains the need for random biopsy, surveillance, and mucosal healing, why it is important. If you can see this chart, this is not just a theoretical chart, just to show that the colitis-associated neoplasia is a part of mesenchymal consensus molecular type, which is less seen in the sporadic cancers, and it is through the chromosomal instability pathway, which takes around 7 to 8 years to develop cancer. Also, you can see the IBD cancers are more inflamed or immune tolerant, and they occur distally and higher risk of distant relapse and death. Why that is important? Because to understand field cancerization. When there is inflammation, normal cells die, although the stem cells that are the mutant stem cells, they are selectively survive and then undergo clonal evolution and expansion that leads to field cancerization in IBD. And this has 3 types. One is IBD non-progression. You resect the lesion doesn't come back. Then this IBD clonal sweeps. This is through the field cancerization that I told. Here, there may be proximal neoplasms and proctocolectomy may be required. And there is third one, that is IBD clonal mosaicism, which occurs. There are multiple clonal expansions, like in PSC, Crohn's colitis, and skip lesions. So even if you resect one lesion, there may be another lesion in the right colon. So in IBD, we have top-down approach. Here, the thing is reversed. In sporadic adenoma, you see top-down dysplasia, that is dysplastic crypts are at the surface, whereas in colitis-associated dysplasia occupy the full length of the crypt, although it looks similar in examination. We learned about non-conventional dysplasia in earlier talk. You can see 1/3 of the IBD patient may have this unconventional dysplasia, hypermucinous, goblet cell depleted type, sessile serrated adenoma, and they are most frequently flat or invisible and often higher risk of cancer and high-grade dysplasia. So actually we performed this endoscopic recognition and resection. We did 2 systematic reviews recently published, and we actually gone through all the original articles, and this is the summary of that. Endoscopic resection of dysplasia, the reference standard is dye-based chromoendoscopy. The lesion characterization, the benefit over visual, this virtual chromoendoscopy is marginal. It is useful in high-risk settings, PSC, because it is time consuming and so it is not very popular, and the need for random biopsy may be the least. Whereas high definition white light endoscopy with the current scopes, it has recent Helios study published in Gut have shown that whether this is the increased yield in dye-based chromoendoscopy is just due to the enhanced contrast or the higher inspection time. They just re-inspected this every segment, and the yield was similar to the dye-based chromoendoscopy. So the role is only now limited to PSC in high-risk situations, and virtual chromoendoscopy lesion characterization is better than the high-definition white light endoscopy. It is faster than dye-based chromoendoscopy and lesser biopsy than high-definition chromoendoscopy. There is also some papers coming in on computer-aided detection or AI, but it has similar sensitivity to virtual chromoendoscopy, but more false positives, needs more refinement. So this is how I think Dr. Rajvinder told about this SSM protocol. Here in European guidelines have told this 5 protocol: shape, size, site, surface, surrounding, and then margin, ulceration, colitic, non-colitic segment, completeness of resection, and techniques used for visualization. We have moved from arms and arms to polypoidal or non-polypoidal and invisible dysplasia, which is also disappearing right now. So this is a case example. This is a case that I did 3 weeks back. So it's a flat elevated lesion, 2 centimeter in length, and descending colon, surface is Kudo 3L or 4 type, surrounding mucosal activity, mildly inflamed lesion, sigmoid colon, 2A flat lesion, margins are well defined, ulceration no, it is in the colitic segment, completeness en bloc resection was done with ESD, technique used was HD, white light endoscopy 190 HQ, and NBI was used. So what are the risk factors? So because to detect one dysplasia, you need to do 88 colonoscopies in a patient. So you have to risk stratify how often to do this. And there are actually, the mnemonic is 2D and 2P. Disease-related factor and dysplasia-related factor, pathology-related factor and patient-related factor. Dysplasia-related factor are extent of colitis, duration of disease, because both of them contribute to cumulative inflammatory burden. Pseudopolyps, I'll show interesting data now. Strictures, PSC. Dysplasia, the interesting thing about low-grade dysplasia, after resection, it is the rate of cancer varied from different studies. However, if it is more than 1 centimeter, endoscopically visible, incomplete or unresectable, multifocal, and moderate to severe inflammation within 5 years, there is a high risk of progression to colorectal cancer. Pathological related endoscopic and histological inflammation, male gender, early onset because of longer duration of disease, and family history of colorectal cancer, specifically to rule out Lynch syndrome. And other risk factors, actually St. Mark's has a lot of data on that, aneuploidy and P53 expression, and shared genetic risk factor for IBD and colorectal cancer, that like STAT3 and gene microbiome interaction, actually they can help to personalize precision medicine, how to risk stratify these patients, and I think this is the future. And this is a recent paper published on JCC, which showed pseudopolyps, the concepts are changing. 12% actually harbored dysplasia in 158 cancers. The positive predictors were heterogeneous pit pattern and non-polypoidal type, and the negative predictive factor for dysplasia were ulceration. So most of them are focal or confined, so resection was the treatment. So they suggested risk-based resection rather than routine removal or biopsy of the pseudopolyps. As you can see here, foci of low-grade dysplasia and high-grade cancer in sessile and villus surface and the lower down panel. Then this is Japanese group from Yokohama University have shown endoscopic characterization of the lesions. If the pit pattern is type 2 or 3L Kudos type and there is margin is distinct, it actually has 100% specificity to say that the lesion is non-neoplastic and can be endoscopically resectable. Like in this example, this patient has an indistinct margin and type 3 or 3L or 4 pattern on methylene blue staining. So this patient had a PT1B cancer, which has almost 1700 micrometer depth of submucosal invasion is there. So the screening colonoscopy went to start 8 to 10 years after the disease onset. At diagnosis in PSC patients, and there should be quiescent disease, and the careful washing should be done. And the modalities are these that we have discussed. Targeted biopsies we all know we are doing, but non-targeted biopsies only in PSC, scarred tubular colon, whereas on-fast view is not possible, inflamed colon, and if there is poor preparation. However, it still samples only 1% of the mucosa, and the yield is 1 in 500. So this is a case example, PSC IBD. You can see the lesions that this case I did last month in December. This patient has lesion in the ascending colon cecum, hepatic flexure, sigmoid, and you can see they can have lesion all the wires because they have this clonal mosaicism rather than only field cancerization. So this is the guideline. So how frequently to do surveillance? 5 yearly, if there is 2 surveillance endoscopies were negative, only proctitis is there, and 1 yearly or 3 yearly based on 4 factors, disease related factor like PSC, pseudopolyposis, dysplasia related, whether it is less than 5 year, more than 5 year, pathology related, mild versus moderate to severe inflammation, or patient related like family history of cancer with less than 50 years or more than 50 years. And the resection, I'm going to come here just in the next slide, but here another point is one modality is there which is called invisible dysplasia. Here we have to do another high quality chromoendoscopy by an expert endoscopist or sent to a second pathologist to confirm whether really there is dysplasia is there or not. If it is unmasking of dysplasia, then you manage like visible dysplasia. If it is high grade multifocal, goes for colectomy. However, it is low grade or unifocal, then very intense surveillance is required based on the degree of dysplasia. Then one word about the pouch neoplasia. It is very, people don't know much about that. So you have to inspect all the 3 regions like pre-pouch ileum, the pouch body and the cuff, and at least 3 biopsies from each segment should be taken. And how frequently to monitor this patient? So if there is dysplasia, the reason for colectomy was dysplasia, then annual sigmoidoscopy has to be done. If no, then pouchoscopy should be done at 1 year and see the mucosa. If it is like a purely colonic mucosa, colonic metaplasia like type C mucosal change with inflammation is there, then yearly colonoscopy is required, pouchoscopy is required. However, whereas it is type A, that is completely small bowel like pathology, or B like partial metaplasia, in those cases repeat colonoscopy, pouchoscopy should be done at 10 years from the diagnosis of UC. And suppose if there is chronic pouchitis, PSC, more than 10 years history of UC, then 3 yearly pouchoscopy is recommended. So endoscopic resection of dysplasia, there are a few examples that I have done. So this is EMR, small, less than 2 centimeter, right colon lifting, polypoidal lesion, well demarcated, no SMI, piecemeal, lower end block resection, recurrence 2 to 2.4% in the earlier studies, but this has varied up to 50%. Histological assessment of R0 resection is difficult because you are giving multiple specimens to the pathologist. Difficult with submucosal fibrosis, CAP, band and underwater EMR are the answers. Then ESD, this is a descending colon ESD, less than more than 2 centimeter, flat lesions, left colon, submucosal fibrosis, Genet 2B, and the contraindications are non-lifting lesions, Genet 3, Paris 2C, Kudo 5 or ulcerated lesions. The en-bloc resection rate is 88 to 100%, R0 resection rate is 73 to 96%, complications 2 to 10%, bleeding perforation, local and recurrence rate is up to 6.8%, surgery is 10 to 20% because of the multifocality, and metachronous lesions are seen in 31%. So because of submucosal fibrosis, like in this lesion, you can see there was a lot of fibrosis there in the one corner. So traction, water pressure, pocket method or lifting solutions, which are long lasting, are required. And this is FTRD. This is published by my mentor, Dr. Kocher. And these are for well circumscribed, less than 3 centimeter lesions, sufficient tissue compliance, and at post surgery or EMR ESD scarring site. So last slide is ESD case selection, the submucosal cushion. I think Dr. Samantha will cover that. But here, this is an important study from Korea. We have shown that after you put the submucosal injection, they injected with a mini probe. If the submucosal cushion was more than 1.5 to 2 centimeter, these are the patients that should be selected for ESD. If it is not, these are usually not feasible. So the key takeaways for dysplasia and IBD, cumulative inflammatory burden is the main driver of colitis associated cancer. The biology is different. There is field cancerization. The tumors are immune tolerant. 1 in 3 are non-conventional. High risk of progression. Risk stratification by 2D and 2P method. Detection, only dye-based colonoscopy in high-risk patients, and HD WLE with high definition with segmental reinspection, as well as virtual chromendoscopy can be used. Characterization, high definition with virtual or dye-based, 5S pattern, margin, Paris classification, Coulthard speed pattern, Genet for characterization. Biopsy, targeted more than random. random biopsies only in PSC, inflamed tuberous colon or poor preparation, resection, EMR less than 2 centimeter polypoid, ESD more than 2 centimeter flat, submucosal fibrosis, and when you need in-block resection, surveillance, high-grade dysplasia 6 to 12 months, low-grade more than 1 centimeter 12 months, less than 1 centimeter pedunculated every 2 years. So here, this is our team, and I think this is the teamwork between the patient, pathologist, IBD physician, advanced endoscopist, surgeon, and now AI is going to help us. I think with this, I'd like to finish my talk. Thank you so much.
Thank you, Partha, for that excellent talk. I think we can take 1 or 2 questions.
Partha, can I ask a question here?
Yes.
So practically, say you do a surveillance colonoscopy, no colonic inflammation, but you find out low-grade inflammation, low-grade dysplasia, sorry, and no visible lesion. How do you approach these patients?
Low-grade dysplasia?
No inflammation, low-grade dysplasia and surveillance colonoscopy. How do you approach this patient? Because low-grade dysplasia, as we know, can behave in 10 different types. So how do you approach a patient with no inflammation, just low-grade dysplasia on...
Which is the visible dysplasia? Or
no visible dysplasia.
No visible dysplasia. Yeah. So the guidelines are clear on that. If there is low-grade dysplasia, then that has to be surveillance because it is invisible. Then you have to do a second. If you are not confident in doing it, you may refer to another specialist who are more experienced with this advanced endoscopy or image-enhanced endoscopy, and also review the slides by a second pathologist because the diagnosis may be tricky. And then if there is still, it becomes a visible dysplasia and you may manage like a visible dysplasia, if it still remains invisible and it is low-grade unifocal, then the guidelines is surveillance every 6 to 12 months.
And does your approach change between UC and Crohn's?
Change in UC and Crohn's. Yeah, Crohn's, the trick is if the more than 1/3 of the colon is involved, then only you need surveillance, otherwise not. And in those cases, there can be skip lesions. So you need to do surveillance for the entire colon and be careful of the right-sided lesions as well.
I think we'll close the session. Instruction from the organizers. Thank you. Thank you very much.
Thank you.
Thank you all the chairpersons. Now we invite the chairpersons for the next session, Dr. Sandeep Laktakia, Dr. B. Ravi Shankar, Dr. Ashirwad, Dr. Shiren Shetty. We request them to introduce the next speaker. We also request our chairperson to be more vigilant for the time as we are running short of the time.
Okay. Hi. So Ravi has passed on the baton to me and saying that you look after the time management, and I will try my best to stop the speaker if they overshoot the time. At the first bell, he gets first warning, and second bell, he gets shot. May I invite the next speaker, Jayan Samanta? I have my gun loaded. And you have to speak in the time given to you in next 10 minutes. Finish the talk on role of EOS in early esophageal and rectal cancer, the top and bottom of the GI tract.
Good afternoon, everyone. Thank you, chairpersons. At the outset, I'd like to thank Mohan sir, Zahir sir, and the whole team of AIG for this opportunity. So I've been asked to talk about the role of EOS in early rectal and esophageal cancer. So why this topic is primarily needed is because we are always now have entered into that organ preserving mode where even multi-millimeter level staging determines the cure versus over-treatment, right? So we need to exactly find out what amount of level of obstruction, what kind of level of involvement is there for the lesion. And EOS being one of the where the transducer is very, very close to the GI tract wall. So this is probably one of the best modality to tell you about the mural story, what is going on in the wall. So first I'll come to rectal cancer. My topic is early rectal cancer, early esophageal cancer. So what is early rectal cancer? By definition, a rectal lesion is lesion within 15 centimeter from the anal verge on rigid sigmoidoscopy. So this is how the rectal wall looks. And any tumor, we are all aware, we have been discussing about it. One is carcinoma in situ, where it is confined within the mucosa. If it goes to the submucosa, it's T1, and if it goes to the musculus propria, it's T2. And if you look into what is the definition of early rectal cancer, in the West they define it as TIS, in situ, T1 and T2 with no lymph nodal involvement. That's in the West is called as early rectal cancer, but the Japanese, they define it primarily as up to T1 as early rectal cancer. Even in that early rectal cancer also comes the Haggett classification, where you have a polypoidal carcinoma. In that situation also, even up to level 4, it is early rectal cancer. And this is the short brief outline as to where we call as the early rectal cancer up to T2, where the involvement is just up to the musculus propria, that too in the inner wall of the musculus propria. So having said that, what is early rectal cancer? How does early rectal wall looks on US? So the superficial mucosa and the deep mucosa, you will find that when you inflate the balloon, there is an interface which looks hyperechoic, and then you have the mucosal layer up to the musculus propria as the hypoechoic area. Then you have the submucosa as the hyperechoic area, and then you have the musculus propria again as the hypoechoic area, followed by the serosa or the adventitia that you have. Right? So this is the basic anatomy of the wall that you see on EUS, either you do a radial or a linear EUS imaging. So how do you prepare the patient? This is basic stuff, so I'm not going to go into the details. You give preferably a full colonoscopy preparation, use bowel preparation, perform a sigmoidoscopy prior to the US examination. It's always beneficial to see how the preparation is, how the lesion looks, and then obviously you can instill a lot of amount of water inside the lumen and then inflate your balloon of the US scope. So primarily we use either a radial echo endoscope or a linear echo endoscope. For all practical purposes, for the wall anatomy to understand, we use a radial echo endoscope, inflate the balloon and then try to see the wall, which gives a very, very good anatomy. Linear is primarily meant for biopsies of the lymph nodes or any other biopsy that you require. But sometimes if you do not have a radial echo endoscope, you can use a linear echo endoscope. So this is how the imaging looks. On the left hand side, you can see a T1 tumor, very, very clear and classical. You see the wall has been, the balloon has been inflated, and you can clearly see that the tumor is confined within the, I'll just use the pointer. The tumor is confined within the musculus propria, right? So on the right hand side, you can see a T2 tumor where there is a MP invasion has happened. So these are very, very clear demarcations that you can see when you're doing an US as to the extent of the T staging is concerned. These are two very short images on the videos. On the left hand side, you can see this was a tumor which initially appeared to be a T1, but as you rotate and see the full extent of the tumor, you can see that this is basically a T4 tumor that we are dealing with. On the lower right hand corner, this video, this was a polyp, you can see. Initially, it did not have a lifting sign as Partha was talking about, and when we did an EUS, we found that the musculus propria was actually getting involved as we did the EUS in this particular patient. So this is how EUS helps in T imaging. So how does it fare? How good is EUS for T staging of rectal cancer? This is a systematic meta-analysis published some time back, 42 studies, and they showed that there were very, very good sensitivity and specificity of more than 85% sensitivity and more than 95% specificity for detecting T1 and T2 tumors, the early rectal cancers that we are talking about. Does that mean that it's very, very good? If you look into after that, in 2011, the German studies, they had more than 300 hospitals, they published this paper and tried to correlate whether US was going a good T staging as far as the pathological correlation was concerned in around 7,000 patients, and they found that the correspondence of UT to PT, meaning the pathological and US correspondence was just 65%. There was 18% understaging, 17% overstaging. So basically what I'm trying to say is that they had reanalyzed and they found that as the expertise increased, then the correspondence kept on increasing, meaning thereby it is not something which is very, very comes easily for every endoscopy that does an US for T staging. Again, meaning thereby that all that glitters is not gold. There is some caveats to it. And if you look into this particular paper published in 2015, what they tried to find out by saying that T2N0 is the stage beyond which you require a neoadjuvant chemotherapy. So that was the stage that they tried to find out how good was EUS in differentiating for the rectal cancer, and what they found was that the negative predictive value was around 83%, and the negative predictive value for nodal mets was around 87%, and they said that in 23% of the cases, meaning there were approximately around 1/4 of the cases, the US made an error while doing a staging of rectal cancer. From T staging, I move on to nodal staging. As we all are aware, the depth, as the depth goes on increasing, obviously the chances of lymph nodal metastasis will increase. And how good is EUS for nodal staging? The first thing that we need to understand is what we need to see into it. For perirectal lymph nodes, we check for that from the dentate line up to 25 to 30 centimeter and up to the level of the iliac vessels. What do we look for are regular, well-defined lymph nodes that we try to look for. And a study has kind of showed that if the short axis of that lymph node is more than 5 millimeter and hypoechoic, they have a higher predictive value for being malignant lymph nodes. So we look for that, and what they represent is 1 to 3 malignant appearing lymph nodes is N1, more than equal to 4 is N2, and the performance status is pool sensitivity specificity is north of 70% for US for end staging is concerned. And this is the ROC curve which shows around 0.7985, meaning thereby that for US performing as for the nodal staging is concerned, it performs as moderately and as good as probably the other modalities are there, that is MR such as MRI. The added benefit of US is obviously you can do a lymph nodal biopsy. It improves the accuracy of your US staging, and it has been shown to reduce the risk of recurrence versus CT. T3 or beyond lesions will not matter obviously, but one of the caveat is that when you're doing a biopsy of the lymph node, please make sure you're not going through the tumor. There will be two problems. One, it will false positive for the lymph node, and you also have a chance of seeding onto the lymph node, which was probably not malignant earlier. From here, I think probably my next speaker, Dr. Tharani, is going to talk about MRI. But when there was a comparison between US versus MRI for rectal cancer staging performance, this was one of the studies published a few years back. They showed that US performed better than pelvic MRI as far as the staging was concerned, similar as far as T staging was concerned, similar as was the nodal staging was concerned. And if you look into the T1, the T2, which we are more concerned about, you'll find that US outperformed MRI in terms of the T staging and the N staging was concerned. But there are certain caveats when we try to compare between these two. US will outperform in overall staging, but it is much better for a T1 or a T2, meaning for early rectal cancers, it is much better. MRI may be better for T3 and T4. Circumference resection margin, this is something which the surgeons are very, very concerned about, is best assessed by MRI. So that is one advantage that MRI has over US. And nowadays MRI uses those endorectal coils, which has shown to have a better accuracy as compared to the previous MRI. So obviously it's a balanced choice and maybe complementary. What about comparing US versus magnifying endoscopy for depth? Again, this is basically like comparing apples with oranges. You cannot compare US with a magnifying endoscopy, but this study actually did it and found that both were performing equally well. What about contrast enhanced US? Very, very small studies which have shown that it probably helps in better delineation or characterization of the tumor. And they probably have help in distinction between T1 and T2. US elastography can also be used. Again, some added benefit has been shown, not really. Coming to shortly up to esophageal cancer. Esophageal cancer is different because here the superficial esophageal cancer is up to T1B, and early esophageal cancer is T1A and only T1A. So that is the difference because of the differentiation in the lymph nodal metastasis seen in this. In esophageal cancer, one more modality is helpful because they tend to develop strictures. So mini probe is one thing which can help in better delineation of stenosed esophageal cancers and malignancy. We had done this study on benign diseases, but again for malignant diseases, the use of mini probe has been shown to yield a very, very good results, north of 80% as far as the depth is concerned. And for staging of US for esophageal cancer also, it has a relatively modest role of 80% sensitivity and more than 99% pool specificity for T1 tumors. And if you use FNA add-on, it obviously increases the sensitivity and the specificity. I'll take just 1 minute. And one more additional point that I think Partha was mentioning, that if you use saline injection and then do a US, it better differentiates between T1A versus T1B. This was a very small study which actually kind of showed that you can actually differentiate between T1A and 1B. And obviously if you combine NBI with US for staging, it has a very, very good diagnostic rate of 97% and a staging rate of 95%. Some loopholes obviously are there, like the error rates or understaging is around 20%. Predictors for understaging are T2 stage or length more than 3.5 centimeter. Barrett's is something which there is a very, very high rate of overstaging as far as US is concerned. Obviously, US can also be used for placing a fiducial marker, but this is definitely not for the early esophageal cancers. And no talk can end without talking about artificial intelligence. These are now coming up. Radiomics is coming up in big time. So I'll summarize by saying US remains invaluable for early GI cancers, both esophageal and rectal. For early T1 and some T2 lesions, US is better than the other modalities. Reasonable value it has for end staging. Biopsy of the lymph nodes gives added benefit. Look for overstaging and understaging. You should be careful about that. Probably a very, very good and systematic training for the US to localize this lesion, and using it as a complementary to other modalities is key to utilizing its maximal potential. Thank you.
बच गए.
For the next talk, we request Dr. Tharuni Putta to deliver the lecture.
The topic is MRI guided endoscopic decision making in rectal cancer.
Good evening. So Dr. Jayanta has made my job and life a little easy for the next 10 minutes. So you've all learnt about how EUS is helpful. I'll just want to introduce you to how early rectal cancers may look on MRI, if you're not already familiar with it. So you've seen these beautiful EUS pictures where these 5 layers of rectal wall are very, very well seen. Of course, done by an experienced sonologist. But look at this second image on the right side. This is how an MRI, T2 weighted axial MRI through the rectum looks. So the inner, the gray layer here represents, I hope my arrow is seen, yeah. That represents the mucosal layer. The thicker white layer represents the submucosa, and the outer continuous dark layer represents the muscularis layer, muscularis propria layer. Now look at the image on the left side. So not all rectums are similar, and the same rectum in the same patient at different times of day are different. So on the left here, you see that the rectal wall looks thinner, so we are not able to make out the mucosa clearly. Submucosa looks thinner, but muscularis propria is reasonably well seen. So keep this in mind when we look at the next few slides. So now this rectal wall is engulfed circumferentially by this white mesorectal fat, which is enveloped again completely by this red line, that is the thin mesorectal fascia, which in other words in surgical terms is called circumferential resection margin. That is the plane of dissection when a radical resection of the rectum is required, or a total mesorectal excision is the right term for that. Now within this mesorectal fat are the lymph nodes, vessels, lymphatics, and yeah, I'll skip this. So we'll go through some cases. So this is a very well circumscribed polyp in the mid rectum arising from the anterior wall. You can see the outer surface of the muscularis is extremely smooth and intact, and so is the inner surface of the muscularis propria layer. So this lesion is definitely not involving the muscularis propria and is likely to be from only confined to the mucosa or perhaps involving the submucosa. So at the most it is a T1 tumor. And there are no lymph nodes in this case, and this case is potentially amenable for local resection. Can MRI differentiate between a non-cancerous or a non-malignant polyp versus T1? Not there yet. I am not sure we'll ever be there. Now, the second example, we see a more flatter and hemicircumferential lesion. We can see that the muscularis propria, the dark outer layer, is intact here, while from about 2 to 7 o'clock position, it's lost its continuity. So it's at least a T2 tumor, and this perirectal, that a fine fat stranding or speculations may suggest that there is early invasion into the mesorectal fat. So it could be early T3 as well. So in the absence of lymph nodes, either a T2 or early T3 lesion not in the lower rectum can be addressed by primary surgery. Again, anterior resection in a rectum. Now this is a very obvious case of upper or mid-rectal malignancy where there is much more invasion of the mesorectal fat. So this is an advanced T3 disease, there is no doubt about it. So with or without lymph nodes, when this tumor is not either involving CRM or very close to it, one must require a total mesorectal excision, but prior to that a neoadjuvant therapy so that the CRM remains clear after surgery. Now in AIG we use these AI-enabled annotations where all the organs at risk are automatically annotated by the software once the planning CT is uploaded. So, and the oncologist is free to then, sorry, hold on. Yeah, the oncologist is then free to kind of annotate what doses should be given to the primary tumor, what doses of radiation should go to the lymph nodes, and get this heat map kind of an image where they can predict how much radiation goes to each of these organs at risk, and so predict any post-radiotherapy complications. Now moving back to early rectal cancers, I think Dr. Jayanta has already covered this. So local resection is recommended only for early rectal cancers. Now early rectal cancer definition may be slightly debatable. All non-cancerous polyps included T1 lesions, T2, early T2, which means the inner circular layer is a bit of a stretch. Again, to recap these T1 subcategories, SM1, SM2, SM3 essentially tell us the depth of invasion of submucosa. SM3 is considered as deep submucosal invasion. Now, MRI, we are not trying to aim to differentiate each of these subcategories, but it's essentially we're trying to figure out if one day we can be as good as US or maybe better at differentiating locally resectable tumors from non-locally resectable tumors. That is at least up to SM2 lesions, maybe a few SM3 lesions. Now for SM1 and SM2 lesions and non-cancerous polyps, a submucosal resection would be good, endoscopic resection. If it is involving deep submucosa or inner muscularis, that's the circular layer, a transanal full thickness resection may be required. And if we are heroic enough, maybe an intermuscular dissection like it's being done in some countries. Now current guidelines obviously recommend endoscopic rectal ultrasound for the staging of early rectal cancers and decision making in local resection. And yeah, the data we have already seen in the earlier talk. There is, however, some, if not lot, inter-observer variability depending on the competency and experience of the performer. And in large early rectal cancers, large in size but early rectal cancers, the completeness of endorectal ultrasound is going to be very important in figuring out if there is any deeper invasion, and that might be a challenge in many cases. So although historically MRI is unreliable in differentiating T1 from T2 lesions, and a couple of decades ago we never imagined that early rectal cancers could be differentiated. T1 versus T2 would be a discussion on MRI. Now the avenue is changing. With newer protocol modifications, we might perhaps get there. I'll just go through some examples. This is a large rectal polyp arising from the lower rectum. We can see that the complete intactness of the muscularis layer all around with a narrow stalk of the polyp. This is an 80-year-old lady who presented with bleeding PR and more than a few comorbidities, and there were no lymph nodes. So a local resection was preferred in this case, and this patient underwent a transanal full thickness resection. After the biopsy came out to be focal high-grade dysplasia. So the specimen also confirmed the same findings. It's a tubular adenoma with focal high-grade dysplasia and focal invasion into the superficial submucosa. So this was a curative resection in her. Now, the first image here is also of a patient with early rectal cancer. But there's some nodular thickening of the mucosa, but you can see that it's very hard to make out where the tumor is beginning and ending, and the depth of the tumor, whether it is involving muscularis or not. Now these other three images are of just 3 random rectums I picked up from yesterday's MRI pelvis cases. They all look very different. If you look at the top right image, it's a beautiful MRI image of a rectum where continuous muscularis is seen, in fact maybe 2 layers of it, thick submucosa and mucosa. So if early rectal cancer comes in this patient, when MRI, the rectum looks like this, it's easy to differentiate T1 versus T2 tumors. But if the rectum looks like this, where the differentiation between muscularis and the submucosa is not as clear, it is extremely challenging. So we need to adapt the MRI protocols and reading according to this. So this group from Norway, I believe, has modified their MRI protocol in early rectal cancers by giving a bisicoidal rectal enema, microenema prior to the study, and then doing the study. So this cleared the rectal lumen, but that's not the most important part. It also induced a bit of submucosal edema. So that submucosal inflammation kind of lifted the tumor off of the submucosa. So the top image, the top right image there, is the tumor where it's not very clearly seen from the muscularis. But the bottom image is the same tumor after the enema, where it's lifted off the submucosa. We can clearly see that it's involving only the mucosa, maybe a bit of SM1, but definitely not the muscularis layer. And the post-op specimen showed SM1 tumor in this case. Now other examples, there's another flat lesion where it's involving full thickness of the submucosa and it's pulling the inner layer of the muscularis towards it. So this we can confidently say is a deep submucosal involvement, and so choose whether to do local resection or not wisely. Now on the last image, it is definitely involved the full thickness. You can see that the full thickness of submucosa is nice and bright here, while there is no submucosa left, and the inner layer of muscularis is also involved. So this is a T2 tumor and probably not good for local resection. Now this modified MRI protocol has also shown similar degree of performance as endorectal ultrasound, and similar degree of overstaging. So it is not overstaging to the extent that a routine MRI pelvis does. Now there are also few other signs that are being investigated. Now none of these have come into guidelines yet. They need to be validated, and all these studies have been done where the radiologists, the reading radiologists have been systematically trained over a set of cases back to back of multiple early rectal cancers, and then used as a reader for the study. So that is an important factor before using this in your routine practice. So submucosal enhancing stripe is another such feature. So at the base of the early rectal cancer, if there's a continuous enhancing stripe that is separate from the muscularis layer, that is also a good indicator for T1 disease and is not commonly seen in T2 tumors. So we have a few such signs being described on MRI. But no matter what, remember, there's always a chance of micrometastasis in 2 to 3 millimeter lymph nodes in both T1 and T2 tumors. And with the deep submucosal invasion, the presence of lymph nodal metastasis is in 15 to 20%. So any local resection, we are leaving behind the lymph nodes. So please keep that in mind. I think I'll end that. Thank you.
Thank you, Tharani. You just finished in time. Any questions and comments for both the speakers? Jayanta, you can join on the stage with Tharani.
Ma'am, can I ask, I think in the background of inflammatory bowel disease, the same signs what you explained holds good, or it's difficult to?
No, it doesn't hold good. Inflammatory changes will also show thickening of the mucosa. So unless it's a deep invasive tumor, I don't think we'll be able to pick. And I do not believe there are any studies on that.
Ma'am and Samatha, both of you can answer. Suppose post-chemo radiotherapy in a rectal cancer, what is the best modality to reassess the recurrence?
I think data has clearly shown that once chemo radiotherapy has been given, US is very, very bad in kind of reassessment of the stage or the recurrence, because what happens, there is a lot of artifacts that comes in because of the fibrosis or whatever edema that is there. As a result, US is not a very, very good, meta-analysis also shows that US is not a very good modality. I think MR will be a...
Both for CA esophagus and CA rectum.
Yes.
Sandeep?
Yes, Rajesh, please.
So I would like to share our experience of US in rectal CAs, because this study which was done at AIG, one of our surgical fellow was doing that, then compared with MR. So I was involved in that project. I used to do US index and found that for T1 staging, EUS was superior to MR. And as far as the CRM is concerned, it was more or less same, that it was non-inferior to that. But as Jayanta has rightly said, if there is a post-op patient who had received new adjuvant therapy, it was very difficult to assess this. Just a small comment.
If I have comment and experience.
Dr. Jayanta, suppose there is a definite lesion based on IPCLs, squamous cell carcinoma of the esophagus. Would you still go ahead and do a US if you want to if you are planning a ESD?
No, not really. Because the reason or the guidelines, if you go into them, it clearly suggests that only and only if there is a deep submucosal invasion is suspected, only then we go ahead for doing an EUS for proper staging of the T. Other than that, if you feel this is purely a superficial esophageal cancer, then you don't need to do a US for that matter.
Jayanta, to add on, in current role with role of PET CT scan, which is done very routinely, what is the role of an EUS in your practice? Early for esophageal cancers.
Yeah, again the same thing, that I think Mohan sir and Professor Ueda will agree with me that if there is a superficial lesion and you believe that there is no deeper submucosal invasion, in those situations, either of the proper staging techniques, either you talk about a T staging using US or a PET scan or PET CT that you talk about, are not actually required. As per the guidelines is concerned, is not actually required. If there is a suspicion of a deep submucosal invasion, obviously you go ahead for a PET CT and or an US. Both are not exclusive of each other. You understand what I'm trying to make a point? It is obviously a complementary to each other.
think basically nowadays we need to know whether adjuvant chemotherapy is to
Yeah,
be
exactly.
for either carcinoma, esophagus or rectal cancer, and that is where I think all these modalities do help us.
Right. One question I have for ma'am. I think the last slide you skipped because of want of time, but in that particular endoscopy paper, I believe, do you think that 1 millimeter invasion, etc., can be actually been done? Because the group has been doing for
Yeah.
quite some time.
So those are, I think they are radiologists trained in Netherlands by
the Dutch group,
UK
yeah.
team, and they have shown that it's done well when 1 millimeter thickness of the muscularis is preserved, outer part of the muscularis is preserved. They went ahead and did a intermuscular dissection, which means dissection in the plane between the circular and longitudinal muscle layer. It's not been replicated in any other studies, and sorry to say, but in my opinion, it's a bit heroic. Mainly because lymph nodal metastasis is not going to be addressed, and that's upwards of 20% lymph nodal metastasis.
That's
we do not, and that study was, I think, completed just a few months ago. So we need to see the long-term follow-up of those patients for recurrence before we can adapt that.
Yeah, anything which is going beyond the submucosa, I think you leave it to the surgeons rather than trying more than this way. But I think with that, we'll come to the end of this session. Thank you very much, both the speakers, for sticking to the time and sparing my gun. And I thank my co-chairs for active participation.
Thank you all the chairperson. We would like to invite the next set of chairperson, Dr. Ashutosh Mahapatra, Dr. Jeffy, Dr. Wilson, Dr. Neha Berry. I request them to introduce our next speaker for the day.
I think next speaker is Dr. Anuradha, who does not need introduction. She is a pathologist par excellence.
Good evening all. Thank you, chairpersons. So today I'll be talking on what the pathologists need from the endoscopist for accurate measurement of the biopsy tissue provided for interpretation of the early GI neoplasias. So as we all know that early GI neoplasia is increasingly being managed by endoscopic surveillance and resection. So anything limited in clinical or endoscopic information definitely will lead to diagnostic uncertainty. There might be overgrading or undergrading of dysplasia and inappropriate therapeutic management. So there is a shared responsibility between the endoscopist and the pathologist. Endoscopist needs to give information on the macroscopic findings, the lesion morphology, depth estimation, and the type of resection technique. And the pathologist should interpret this tissue, grade the dysplasia, confirm invasion, and assess the margins. Now, what is the information that we require from the endoscopist for optimal evaluation? So the first and foremost is adequate clinical information, where we need patient demographics, exact anatomical site, what was the indication for which this procedure was done, how is the background mucosa, whether there is any Barrett's or chronic gastritis, atrophic gastritis, H. pylori, IBD, and is there any prior histology of the previous endoscopic resections. And what is the information we need about the endoscopic procedure? We need to know about the lesion characteristics, what's the size of the lesion, what was the morphology according to the Paris classification, the location from landmarks, how is the surface pattern, whether it's pit pattern or vascular pattern, and any signs on endoscopy which can give an idea that the endoscopist is thinking of invasion like non-lifting sign, ulceration or rigidity, and the biopsy, whether it is a targeted biopsy or a random biopsy, number of fragments, what is the site-specific labeling, and whether any cautery was used. Now, the pathologist can interpret these biopsies and we can give an idea whether there is dysplasia, low-grade or high-grade dysplasia, or intramucosal or invasive cancer. And of course, there are certain limitations on the biopsies. Now, if you just see in the form of there's a case of a 20-year-old female with an anastomotic ulcer in a case of post-operative CA colon. A biopsy was given. Now, in this biopsy, you can see that there's foci of ulceration and there are areas of intraepithelial atypia, and there is some amount of inflammation. So when there is inflammation, we should be careful not to interpret it as true grade dysplasia. So this is a reactive atypia. And this is a 48-year-old male. The clinical suspicion was of early esophageal carcinoma. Biopsy was done, and you can see that there is some lesion tissue here, and the lesion was showing intraepithelial high-grade squamous dysplasia, but we are not able to comment further on the invasion because we do not have the submucosal tissue or the subepithelial tissue to comment. Now the same patient underwent an EMR, and you can see that very classically when we have a full thickness biopsy, there is a foci of invasion into the submucosa. So this confirms that this was an invasive carcinoma. Now what are the findings which we need when colonic polypectomy is done? What's the polyp size, the polyp number, and what are the number of polyps sampled, and what are all present in one jar, because sometimes we receive multiple polyps from different sites all cooked into one jar. What is the exact location of the polyp, the method of removal, and possible endoscopic diagnosis. Now this is a 59-year-old female with a rectal polypoidal lesion, strong suspicion of mitosis. You can see that there is transition to high-grade dysplasia, but there is no muscle to comment on invasion, so we are not able to comment that whether there is a malignant component in this. So subsequently, the important specimens which we get and where we can give much more information is the EMR ESD specimen. But of course, we need to know whether it's a piecemeal resection or an en bloc resection. Orientation of the specimen is very important at the site of endoscopy, where we need to have a properly pinned and fixed sample with marked oral and aboral end. And pinning of the sample at the site of the endoscopy room is very important to prevent curling of the margins, because otherwise this will affect the further orientation and evaluation of the margins, which I'll show you in subsequent slides. And the optimal time of fixation should be 12 to 24 hours. And this is artifacts which we face difficulty in interpretation. When you overstretch it or put over pins, you can see that there is a tearing of the specimen which will affect the tissue evaluation. And also too much of overextension will cause mucosal breaks, and because of procedural effect or excess cautery, there can be degeneration, so evaluation of the horizontal margins becomes difficult. Now the role of pathologist in evaluation of the EMR ESD specimen is to confirm the diagnosis, evaluate the depth, margin, assess the risk stratification markers, and give a comment on the background mucosa, and further do ancillary tests like MMR if it is an invasive malignancy. So a pathologist can evaluate and can give important criteria which are important to say that this procedure was adequate. And the things with unfavorable outcome are if the morphology is very poorly differentiated, if the depth of infiltration is beyond submucosa SM1, or if there's lymphovascular invasion, or if there's any large vessel invasion or margin positivity. Now the margin curative depth varies from organ to organ. In esophagus, if it is squamous cell carcinoma, the SM1 is 200 microns. If it is esophageal adenocarcinoma, it is 500 microns. Gastric adenocarcinomas is 500, and colon is 1000 for definition of SM1. Now this is a 66-year-old female who underwent a rectal polyp, and it was a large specimen of 7 centimeters which was pinned, and you can see that you have got all the layers. You have this polypoidal tissue, and this is your deeper margin, which is obviously free here, and these are the vertical margins which are also free. When we go to the hyper, we see that this is a tubular adenoma, and there is some amount of invasion here into the muscle. This is your submucosa. So how do we measure the depth? Now when the muscle is identified, you draw a vertical line and then measure the depth from the vertical line to the deepest point of invasion. But when you cannot identify any muscle, you have to measure from the topmost point, that is from the ulcerated area, to the bottom to give an idea about the submucosa. When we have adequate submucosal dissection, it's very easy to comment on the depth of invasion and also look at vascular emboli. But when you have a shallow submucosa, the pathologist can only give information about the submucosal invasion, but cannot evaluate for the vascular invasion, which is a very, very important prognostic marker, as we have discussed. Now in this case, if you see, there was one tiny foci of tumor infiltration adjacent to a vessel. So presence of this gland can give an idea that it is a submucosal invasion, so it is beyond SM1. So, and you can use ancillary techniques like IHC to identify that one foci of invasion when you sample the entire specimen. And you can use decimal to identify the muzzle and calculate the depth of invasion, as in this case it was 1003 microns, and beyond this is called SM2. And the pathology report has to be crisp, carrying all the required information required for the clinician as to what is the type of tumor, what's the grade of the tumor, what's the depth, and how is the margins, whether they're lymphatic or venous invasion or perineural invasion, and comment on the margins. Sometimes there are pitfalls in evaluating depth of invasion, as in this case of a Barrett's nodule. You can see that there is transition from the mucosa to areas showing intestinal or the goblet cell metaplasia, and further areas showing dysplastic glands which are infiltrating through the muzzle. And you can see that this is your deeper margin which is free, and the glands are infiltrating in between the muzzle fibers. And then there are also areas of poorly differentiated tumor. So these are the signet ring cells. And if you take in the Barrett's, now this is the mucosa and lamina propria. Barrett's, this is the muzzle. There is a problem that there is duplication of the muscularis mucosa in Barrett's. So if there is invasion of the muzzle into the duplicated muzzle fibers, should not be considered as invasion into the true muzzle fibers and over-diagnose the case and staging of the tumor. You can use Desmond to highlight and evaluate both the duplicated muzzle fibers and the original muzzle fibers. And you can use either the AJCC or the Stolz classification and give a diagnosis. This particular case was adenocarcinoma with infiltration into the duplicated muzzle fibers. Now, why does the depth matter? Because if there's only infiltration to mucosa, there is very negligible nodal risk, and if it is anything into submucosa, the nodal risk is high. But if you note here, for the same depth, if the esophagus still needs surgery, whereas in colon, they can be considered as therapeutic cure. Now, this is another case of a gastric ESD, and this was an ulcer of 0.8 centimeters. But microscopy, there are multifocal areas of tumor, and these are the signet ring cells at different points along the length, and you can use IHC to highlight the same. And so when you have multifocal areas, the pathologist should measure all the different foci of tumor and add up to the tumor. So though the gross ulcer size was only 0.8, actual microscopic tumor depth is 2 centimeters, and wherever the undifferentiated component is present, it should be considered as that. Margin involvement only predicts local recurrence. It does not give any clue about lymph nodal mets, and you have to evaluate both the vertical and horizontal margins. But the pitfalls are when you have a very superficial plane of resection, the evaluation of the margin becomes difficult. As you can see here, the margin is gone almost up to the mucosa instead of the deeper submucosa. Lymphovascular invasion can be demonstrated by using special stains like D240 or elastic stains. And tumor budding is another important prognostic marker which needs to be evaluated in the colonic polyps. So I would like to conclude that the early GI neoplasia requires a complete clinico-pathological correlation with complete information to prevent over or under diagnosis, and an effective communication is very important to ensure appropriate therapy and follow-up. Thank you.
Thank you, ma'am. I think we should all update our pathology forms when we are sending the specimens. We just have time for one question, so if anybody has a question.
Madam, how frequently you encounter mixed type of early gastric cancer in your setting? Because why I am asking today in the live demonstration, we encounter a suspicious type of mixed cancer, mixed early gastric cancer. Because if you find mixed early gastric cancer, then the chance of lymph node metastasis is very high. So how frequently you see?
So I would say it's like around 5%, 5 to 8% of the cases where we get mixed. So whenever you have so I am presuming that mixed means you are asking me about well-differentiated, poorly differentiated.
Poorly differentiated.
Yeah. So that is why in EMR ESD, the rule number 1 is entirely embed the specimen. So there is no way that you're going to part process the specimen. And you should do a PS Alcian blue, which is very important to pick up that minute foci of poor differentiation. And always do a pan-CK in cases of gastric cancer, which will highlight the areas of poor differentiation.
Okay.
Do you do immunohistochemistry in all cases to rule out H. pylori?
Yeah, so we do GIMSA for all cases of H. pylori, and we also have a H. pylori antibody. So whenever we have invasive malignancies, since last 1 year we have made it a rule to do a H. pylori IHC as well in our cases.
All cases?
All cases of cancer.
Thank you all the chairpersons.
Thank you.
And thank you Anuradha ma'am for a very elative talk. I would request the next session chairpersons, Dr. Zubin Dev Sharma, Dr. Kapil Sharma, Mr. Abhishek and Mr. Kinjal Saxena to be on the dais and introduce our next speaker.
For the next session, for the standardization, reporting and integration with the AI, we have Dr. Tanmay Jain.
Good evening all. So I'll be myself Dr. Tanmay Jain. I'm consultant in AIG. So I'll be talking about standardized reporting and integration with artificial intelligence. So before I proceed, I want you to have a look at these two reports. So these are actually same lesions of same patient, but actually these are two very different reports. So in the first report, I'll just use the pointer here. This just describes that there is a small superficial ulcer of approximately 1 centimeter, but the same but a different endoscopist doing same procedure in a same patient, he describes it quite differently. He has mentioned about the size of the lesion, whether it is superficial or deep. Also he has mentioned about the margins. So the second report obviously looks quite standardized. So what I want you to notice this is the same lesion, same patient, same procedure, but actually these are two very different reports. So what do we actually mean by standardization? There are three basic limbs of standardization. The first one is the completeness of the procedure. That means the mandatory anatomical landmarks should be seen. And the second one is the consistency. That means we should have a standardized terminologies like we have erosion, ulcer, and wherever possible, we should use the classification systems. Like we have the Forest classification, we have the Prague classification for Barrett's. The third limb of standardization is the reliability. What is the meaning of reliability? Is that the endoscopist should perform the endoscopy in a systematic way. Like for example, we have the SSS protocol, and wherever possible, required number of photo documentation should always be done. The quality of endoscopy actually depends on two things. The first one is the performance, how good is the endoscopist, how good is the endoscopist. The second one depends upon the documentation. So for example, if I'm the endoscopist and I've done a very good job, but I failed to document it, so obviously it carries no significance for the patient. On the other hand, if I'm not a very good endoscopist, say I have missed some blind spot or I've not adequately distended the mucosa, I've missed a lesion, so definitely I will not document it. So that also is not good for the patient. So we have got major society guidelines, namely the BSG, ASGE, and the most recent one is the ESGE, the STAR project, which came up in 2025. So all the major society guidelines, they agree upon three pillars of standardization, that is the pre-procedure, intra-procedure, and the post-procedure. So I'll be talking about each of them in detail. So pre-procedure standardization includes appropriate indication. There should be a clear documentation of why the procedure is being performed. If there is any comorbidities or any antithrombotic medicine, that should be documented. the fasting status and the pre-medication checklist should be complete. And the most important is informed consent should always be there. The second limb is the intra-procedure part, which I already described. There should be a complete examination. All the blind spots should be seen. We have the very good SSS protocol session which we had in the morning. Adequate mucosal visualization should always be achieved, and the report should be described as comprehensively as possible. And the most important part, the photo documentation should always be there. The post-procedure standardization consists of giving up a very comprehensive endoscopy report, which should give a complete endoscopic impression. If we have taken biopsies, so how many bottles we have taken, the number of biopsy samples that we have sent, that should be mentioned. And if there is any follow-up advice, or if there is any post-procedure complication or any post-procedure advice, that should always be there in the endoscopy report. So this is the sample ESG report, which is available on the ESG website. So this is a sample standardized reporting. It describes it into the pre-procedure part, the intra-procedure part, and the post-procedure part. Because of paucity of time, I won't be able to read it completely, but you can always have a look at it on the official website. Now, regarding the role of artificial intelligence, I feel in the past 5 years, it has come up in a big way for standardization. We have obviously the CAD-E system, which detects any pathological lesion. We have the CAD-X system, which can further characterize that particular lesion. We have now AI models which can auto-detect the photo documentation. It can detect the completeness of the examination. We have various AI models that can do the uniform documentation. So various AI models have been developed, especially in the past 2 to 3 years, from mainly China, Japan, we have Taiwan also. So basically majority of the models, they have been trained to automatically capture the photos. We have various models that can detect the image quality, the cleanliness of the procedure, the completeness of the procedure. And for the colonoscopy, we have various AI models that can detect the insertion time, the cecal intubation time, the withdrawal time, and whether the procedure is complete or not. This ARC1 model from Japan, that is now able to recognize the various tools, snares or biopsy forceps. More recently, we have the voice-based AI systems which have been developed on natural language processing. So these systems actually do what? There will be a microphone given to the endoscopist. So the endoscopist will keep on describing the report while doing the procedure on a real-time basis, and automatic report generation will be there. At the same time, that particular AI model is able to detect the photo, take the best photo out of it, and automatically annotate the photo. So this is the ADRIA platform, which works on the natural language processing. And as you can see, there is an automatic report generation based upon the voice inputs, and it is able to capture the photos on our command. It is also able to annotate the images based on our commands. So this basically cuts down a lot of time. So this is basically, this article was published in Endoscopic International 2025. So this software is basically, it makes us to look at all the 29 sites of examination. Once we are at a particular site, it makes sure that we have seen all the anatomical boundaries of that particular part. And suppose if we are in the stomach and we have not adequately seen the posterior wall, so there will not be a checkbox here, and we will not be able to generate the report. So this basically this basic software does what? It helps the endoscopist to take his time to monitor whether he has been able to see all the 29 areas completely or not. So more recently, in our center AIG, we have been developing the AI systems with our vision being standardization of the reporting, completeness of the procedure, lesion detection, cleanliness, and obviously the time auditing. So we have done what? This is just one part of our endeavor. We have made a comprehensive list of all the lesions, all the pathological findings which we encounter during endoscopy, and each lesion we have tried to describe it as comprehensively in detail as possible. For example, for gastric ulcer, we have various check boxes to save our time. There will be a checkbox for number, whether it is single or multiple, then the size of the ulcer, then shape, base. So various, like this, various checkboxes we have. So in the end, I would like to summarize that standardization has got three pillars: the pre-procedure part, intra-procedure part, and the post-procedure part. And the limb of the main part about standardization is about the completeness of the procedure, making a reliable, comprehensive report, and obviously AI is the next big thing which is coming up. Thank you.
Thanks, Dr. Tanmay. Am I audible?
Yeah, you are audible.
Okay, I have a question on like what are the hindrances for AI-based standardized reporting adoption, and what are the pitfalls you will be concerned about?
So hindrances, what I feel is that the standardization of the procedure, the standardization of the terminologies, it is not very much, I will say, standardized now. What I call it as ulcer may be called as erosion by some other person. So although the definition of ulcer and erosion is like less than 5 millimeter is an erosion, but obviously what I feel is that there tends to be sometimes discrepancies between two endoscopists. The second hindrance, what I feel, is that the data set on which these AI systems have been developed. So if I have trained a particular model, let us say on 500 videos or 1000 videos, but suppose I have not trained them properly. So the AI software will not be able to give an appropriate input. So that was the hindrances. The pitfalls, what I feel is that in due course of time, not in the past, not in the coming 5 years, I feel in the coming 10 years, due to the overutilization of artificial intelligence, I feel is that it can lead to detraining of the endoscopists. That is one thing I feel.
One question. Dr. Tanmay,
sir.
Here, Asutosh Mahapatra. So excellent talk.
Thank you, sir.
You have very elaborately told, not once, twice, thrice, you have told about ESG documentation.
Yes, sir.
But I do not agree
Sir.
personally with ESG, only one part, that is photo documentation.
Yes, sir.
If you look at the AGA photo documentation or any
Yes, sir.
American society and European society,
Yes, sir.
their photo documentation for early endoscopic examination, stomach examination, less than 8 photo.
Yes, sir.
But one should follow Japanese guidelines,
Yes, sir.
where at least you should take 22 photos.
Yes, sir. That is true, sir. There have been differences in the guidelines. ESG is about 8 photos, and Japanese, obviously, they are 22 photos, sir.
Why I'm telling, I also, Dr. Noria, I sent
Yes,
recently 2 photographs.
Yes, sir.
And I have done myself.
Yes, sir.
Those 2 endoscopy, 3 years back, antrum, no growth.
Sir.
And 3 years back, large growth in the antrum. And Dr. Noria told me you did not photo document well, almost 5 years back.
Sir.
So not only antrum, we have to say about the anterior wall of the antrum, greater curvature of the antrum, lesser curvature of the antrum, or posterior curvature. So we could not, whether I have missed, I do not know, but there is a large growth in the antrum.
Dr. Tanmay, which is the best AI tool for detection of the early GI cancer? Best AI tool?
I'm not pretty sure, sir, for the early GI cancer.
What we have shown is what the endovalt, which you have shown that.
Yes, sir. Yes, sir.
I think we can conclude the session. Thank you for your.
Thank you, sir.
Hello. Yeah. So thank you, chairpersons. So now coming to the next part of the conference, we now have a multidisciplinary discussion where we are going to discuss various aspects of early GI malignancies. I invite the panelists, Dr. Rajwinder Singh, Dr. Noria, Dr. Tarani, Dr. Anuradha, Dr. Sujana, Dr. Pradev, Dr. Vamshi Krishna and Dr. Sunita to please come on to the dais.
I think this is heavyweight. So up till now we learned individually how to do endoscopy, how to diagnose a cancer, early cancer, but it requires a lot of interplay between all our faculties and to ultimately decide the treatment. It's not like some cases are clear cut, okay, they can be resected, some clear cut, okay, they go for surgery. But there is a gray line where we must discuss together. And some of the cases I have accumulated, and we'll go to this case, which is around 50-year-old male with hematochezia for 6 months. He had recently underwent angioplasty 4 months back. Now he has bleeding, and then we did an endoscopy, a colonoscopy, and you can see here by just morphology. Raj, you can tell us about this. There's a flat lesion, and there is some of the infiltration which they are glaringly visible to me. What do you think about this?
Yeah, so thanks, Mohan. So another nice case where you firstly do not need any advanced imaging. You should always look at a polyp from a distance. So that is one sort of good learning point.
Yeah.
And when you do that, you can immediately see some sort of worrying signs. One is that there's probably some level of fibrosis or scarring occurring towards the left-hand side of the lesion.
Yeah.
And the other thing is there's easy friability. So the lesion seems to be wanting to bleed.
Yeah.
And then you can also see that the luminal component has got, if you go back, so you can see that the various shapes within the luminal component, almost like a mountain or a peak in the middle there. So that's all worrying signs to suggest that this could be submucosally invasive.
Yeah. So it's not like we'll go directly for ESD in this case. So we'll definitely like to ask our either radiologist or as Jayanta told us about the EUS, but we tend to do MR and Tharni, could you tell us about this MR which we did in this patient?
Also, we would request Dr. Rohit Dama, our surgical gastro senior consultant, to join us on the dais. No MDT would be complete without the surgeon in the team.
So this video, I think you have to control. Maybe okay. I'll go here.
Yeah.
Here.
Stop over there.
Yeah, here.
Just point on this.
Okay. So what are the landmarks which you see in MR? Like this patient, we did an endoscopy and we see that this can be a deep submucosally invasive. And we are asking you whether we can go ahead and do ESD or not in this case.
This is a very flat looking lesion on MRI with a little bit of mounds on the mucosal side. But at this point, if we see, it is involving the rectal wall. To me, it looks like it is involving the muscularis layer.
So it's a T2 for you.
I would say it is T2, focally T2, but most of it is lifted off.
Yeah.
So rest of it probably is T1, but at least focally I'm very scared to call it T1.
Yeah. So there are no lymph nodes. Only the muscle is involved, but it is deeply invasive. And then we went ahead and did EUS, and you can see clearly that the muscle is not breached, but the tumor has reached to the muscle layer. So at places it is definitely T2. So Raj, what do you do in such situations?
I mean, as we briefly discussed earlier on, isn't it? The risk of performing an EID you can perform one, but then the risk of lymph node metastasis is up to 20%.
So what about if you do a EID and say, for example, Anuradha says there is a good differentiation, there is no lymphovascular invasion, there is no perineural invasion, there are no risk factor, no tumor budding. So that patient get, rid of a bigger surgery.
Yes. So that is what we sometimes can do, sort of call like a diagnostic ESD, or EID. The issue, I suppose, there is that one is we have to carefully then speak to the patient, discuss this in an MDT sort of setting, speak to the patient and inform them of the risk. So there have been some data to suggest without high risk features, but with depth of invasion only, perhaps these patients can be considered cured.
Cured, yeah.
But I think that data still needs to be replicated in other centers. I don't think it's sort of a data which can be taken at this present moment. So an ESD or EID can be done, but with the caveat that if there is a deeply invasive cancer, we carefully speak to the patient and inform them of the risk of lymph node metastasis.
Okay,
Because
so
if the patients are older, then perhaps they want to take that risk.
Rohit, what surgery you will do in this? Suppose this is a proximal rectum. So another scenario is very distal, very close to anal verge. How your approach will change in such cases?
So maybe few centimeters from the anorectal junction, we can do a low anterior resection, and sometimes it may go to intersphincteric dissection. So maybe about a centimeter at least you have from the anorectal junction, we can manage without patient landing in a permanent stoma.
Okay. What about neoadjuvant chemoradiotherapy? I will ask Sujana and Vamsi.
So definitely, I mean, if it is, especially if it's a lower rectal tumor and if you're worried that the patient will have a permanent stoma, then yes, neoadjuvant chemoradiation followed by non-operative management because it's a very early tumor. If you look at the OPRA trial, so what they did was they did neoadjuvant chemoradiation followed by addition of consolidation chemotherapy was also given. But having said that, T2N0 technically becomes a stage 1. I believe consolidation chemotherapy will be an overkill. Probably Vamshi can answer that. But yes, neoadjuvant chemoradiation followed by close surveillance.
Okay.
The surveillance has to be very, very strict. And also with the caveat that the patient has to be explained that at any point of time, he might have a relapse. And at that point, he has to undergo a salvage dissection.
Vamsi?
So again, if the surgery is not going to be very difficult, T1, T2, you don't need any adjuvant therapy post-op. So unless the condition like Sujana says, medical comorbidities, you cannot operate very close to the rectum, you're losing a sphincter. Other than that, surgery is the first choice we would suggest.
Perfect.
We wouldn't suggest a neoadjuvant.
Mohan, can I?
Only if I can complete, the only other part which we are now coming much in use is the microsatellite instable diseases, where with immuno you are getting kind of a complete CR and a PAT CR, something even without radiation or surgery. But that's a very small subset, 2%. And again, if it's a T1, T2, is even immunotherapy an overkill? Is surgery just good enough? That we don't know yet.
Okay, Dr. Mohinish.
What are the learning situations here? Why we have very fast forwarded to EUS, to MRI, to surgery, to neoadjuvant, everything.
Yeah.
I think we have missed the learning points on endoscopic, colonoscopic examination here. What were the Paris things which suggested that there was a deep infiltration? JNET type 2B, though 10-12% of those cases can still have a deep submucosal invasion. Here comes the role of chromoendoscopy, where you can predict without getting all these investigations. I think
the white light endoscopy and morphology was quite suggestive of deep invasion, and moreover the NBI showed JNET type 2B. So we went ahead and did these tests. But what we did, Raj, what is your comment on this question?
I mean, we did discuss this at length. Obviously, we have 6 cases in 25 minutes. So this is going to take just 5. So that's why we fast forwarded quite a bit. But there were typical signs to suggest that there's deep invasion. And I think it is important to have additional sort of investigations to make sure you have a complete picture. The other thing which we may also need for this patient is a staging CT scan, right? Which we have missed. You never know, after all of this, suddenly there's a node in the lung. which we haven't covered. But that is the other thing which we would do as well for these patients.
Okay, so this was a learning case, how to manage a rectal T2 tumors.
Mohan, what happened with the case?
He was for ESD today. Yeah, so but now maybe we are not doing that. Once we did EUS today, and also the MR was done today only, and then we called him for ESD, but I think he's not a candidate for ESD. So when not to do and when to involve multidisciplinary team is also important. So this is again a young man with dysphagia. This patient has comorbidities no comorbidities, but he was smoker. So this patient, we did endoscopy, and you saw today Noria performing an endoscopy on early esophageal cancer, and this is almost the same patient. But there what you saw was only B1 vessels. So that was only mucosal disease. But here you can see this, as soon as we change to NBI, as majority are B1. See that B1? This is quite classical of B1. Noria, this is B1.
B1. Yes.
Yeah. So this is all intramucosal. But as we come up, these loops are going, and here you can see these are open loop. What about these vessels?
Maybe B2. And
B2,
then
yeah.
Small AVA.
Yeah. So okay. So these are B2. So what is the sensitivity and specificity? Once you see B2, will you still go ahead and do ESD directly, or you will add an EUS to maybe more better sure about what is the true staging?
I really don't know the actual figure, but like a JNet 2B, the sensitivity and specificity not as high as not so much high.
Not so. So
especially B2s.
So B1 is very good that okay, everything is intramucosal, you do ESD. B3 is very good that okay, this is deep and you go for surgery. But for B2 we are still not sure.
Yes.
We still agree. So what is in Japan? Would they do diagnostic ESD, or they do additional tests to know?
So according to JCOG study, it's like a prospective study. Additional EUS usually increase overdiagnosis.
Okay.
So we don't really, even guideline does not recommend routine EUS for prediction of depth of invasion. Okay. So maybe if in such case, if it is circumferential, diameter is not whole circumferential, I think we perform.
Okay, so this is not circumferential, it is not more than 5 centimeter. We did EUS and we found this tumor is not invasive, it's limited to mucosa and superficial submucosa, but we found out a lymph node. Now this lymph node, if you biopsy, you will travel through the tumor. So as Jayanta said, we should not do a biopsy. So what about PET scan, Sunita? How will it help us?
In early cancers, the sensitivity is low, but once the lymph node is there, yes, we may plan. Especially in T3, T4, PET-CT has quite good role. But T1, T2, plus or minus.
So what is in radiation field? Now this is a squamous cell cancer which is limited to superficial submucosa, is easily resectable. We have a lymph node. Whether you advise for neoadjuvant therapy or completely cure by radiation, or we do a ESD.
So had it been a node negative, I would definitely send the patient for upfront surgery. But now that this patient is having a node, I would definitely consider for neoadjuvant chemoradiation with a cross protocol, because it's a squamous cell, they are usually very, very sensitive for radiation. And then because patient is quite young, 47, he will definitely benefit with surgery after neoadjuvant chemoradiation.
Okay, but this patient was very keen on endoscopic treatment, and PET scan was negative for that lymph node, and we could not biopsy. We went ahead and did ESD, complete ESD, en bloc resection was achieved, and subsequently this patient, we studied the histopathology. You can see here this it's not full circumferential, and this en bloc resection achieved, and then we went ahead and did full assessment of the histopathology. Anuradha, This can you show us what we are seeing? You have the we have the pointer for you. Okay, here it is.
So this is the overlying mucosa, and you can see that there is transition to dysplastic squamous epithelium, and the tumor is now infiltrating into the beyond the lamina propria into the muscle, and this whole thing is the tumor here, and this is the deeper resected margin, and this is the submucosal vessels and the submucosal glands, and you can see that this tumor is going beyond the muscle into the submucosa here.
So just saying beyond the submucosa is enough, or
So
what
again,
you want to
if you
say?
see this area, you can see that in this area, the tumor is mostly limited to the mucosa. So there is actually no foci of infiltration here. But then again, if you see here, this is the submucosal glands and the vessel, and you have the tumor which is next to the large submucosal duct and glands. So then we will measure the infiltration from the identifiable mucosa to this depth, and in squamous cell carcinoma, anything more than 200 microns is said to be SM1, beyond SM1.
Okay, so in this patient, I think it was 350 micrometer. So this is a non-curative resection. So what will we do? Sujana, we sent you this patient, what will you do? Or you will ask to do additional surgery?
Yes, sir. I mean, if the patient is a compliant patient and if the patient understands, then probably I'll send for surgery. But if not, if the patient is not willing for surgery of medically inoperable or anything of that sort, definitely I'll consider definitive chemoradiation this time and put him on close surveillance again, as per a lot of evidence which is coming out these days from Sano trial and other trials. So we'll just follow the same surveillance protocol.
Mohan,
okay. Yeah.
I have a query.
Yeah.
So like when you saw by endoscopic and you had V1 somewhere V2, so is there any role of CT or MRI evaluation, or only US and then you go ahead with the ESD?
Tarni?
No role of CT or MRI in early esophageal cancers.
Okay, so there is no role. So we'll quickly go to the third case. This is a Barrett's esophagus. It's a straightforward case. We have a Barrett's esophagus, very big hiatus hernia, C7M9. So Raj, what you can see? We can see a Barrett's on the right side, but there is a nodule on the left. How do you approach this?
Yeah, so first things first, you would want to map it out properly. So this looks to be like at the proximal segment of the Barrett's length or Barrett's segment itself. It looks nodular, so obviously you would want to study it a bit closer, but certainly it's looking like an early cancer. There's an area of fullness as well. So I think what you're depicting here is normal mucosa.
Normal, yeah. Now here is the Barrett's.
Yeah.
This is the nodule.
Yeah, so this is the nodule, and obviously you can see that the pit pattern is totally distorted there.
Yeah.
And there's some suggestion of fullness underneath. So one of the things with regards to an early Barrett's cancer, other than easy friability, knowing or mapping the Barrett's cancer itself, is to ensure that if an endoscopic resection is undertaken, and in this case it will be an ESD, you need to ensure you get part of the normal squamous mucosa as well, because there can be sub-squamous extension.
And how do you assess the depth of invasion in Barrett's mucosa, or you resect them?
So it is not same at all compared to squamous cell cancer, unfortunately. We are very poor at identifying a T1A versus a T1B, even endoscopically.
Yeah.
Even with a group of experts. So there has been a publication last year which looked at that, and the concordance is only about 60 to 70%. So the accuracy of endoscopists to differentiate what is endoscopically curable versus incurable is a bit tricky with T1A versus T1B. But with high-grade dysplasia versus cancer, that accuracy is pretty good.
Yeah. So we went ahead and did ESD of this case, and you can see I'll just fast forward just to show that this complete end block resections achieved, and this patient will just see the histopathology. This was the gross specimen. You can see this is the nodular mucosa, this is the squamous, and this is the below columnar mucosa. And Anuradha, can you tell us whether it is curative resection or non-curative resection? How do you decide?
So, if you see here, sir, that there are areas of intestinal metaplasia, so there's background Barrett's here. So, as you go along the length, you have some areas of crowded glands, and that is where you have here, there are these dysplastic glands which are going into the muscle, and here you can see high-grade foci and branching off, and still areas of poor differentiation. So, in this one picture, there was one poor prognostic variable of a poorly differentiated component. As I said in previous talk, the main pitfall for pathologists in interpreting Barrett's is, in Barrett's there is duplication of the muscle, and you have a space between the duplicated muscle and the original muscle, so which may be misinterpreted by the pathologist as submucosa and muscularis propria. So there is over-interpretation thinking that muscularis propria has been sampled, but actually this is the original muscularis mucosa and these are the duplicated muscle fibers. So though the glands are going into the space, it is only limited to the muscle. So there is infiltration into the muscularis mucosa, not into the muscularis propria. So that is what we should be very careful. And here the deeper margin is free, but there was no lymphovascular emboli, but one poor prognostic variable was the component of the poorly differentiated adenocarcinoma component. So that is one thing which has to be kept under follow-up for this patient.
Okay, so I think we have only 4 minutes left, so I'll just discuss one case with you. And this is the very commonly seen now in endoscopy practice. Everybody wants to resect everything. So this is a 64-year-old male, and this patient has, when the endoscopy was done, we saw a very big cyst, around 5 centimeter. So then Pradev, you did the endosono. What did you find?
So in this patient, it is very big, more than 3 centimeter, which is a poor prognostic marker, and it looks irregular as well. The surface of the tumor looks irregular, and there are few cystic spaces, which also gives a high risk feature in this patient. So endoscopic resection might not be curative.
So Rohit, you will do a surgery, total gastrectomy?
No, I think we can save the organ. So this just needs a local resection. So you need to get it an ellipse of that tumor. Problem is it is very close to the G junction. So that is where our role for endolab procedures come in. So we do a lot of endolab surgeries where under endoscopic guidance through laparoscopy or through MIS we can tackle this tumor and get a complete excision, preserving the whole stomach.
Dr. Vamsi, there is a lot of talk about endoscopies that they want to give imatinib first, shrink the tumor and do endoscopic resection. What do you advise?
So
are there any data on this?
No. So the role of imatinib is mainly in adjuvant high-risk patients, wherein you give 3 years of adjuvant imatinib and reduce the risk of recurrence. A role of neoadjuvant is kind of established for large inoperable or multiple organ infiltrating tumors. So in this sort of a situation, to reduce a small tumor further just to remove it by endoscopy, I could not find any data, to be very honest. Anecdotally you might do it, but if it's really a small tumor, I think the surgeons can take it out easily without any problem. So I don't think it's right to go ahead and try that, because we don't know how the tumor shrinks and we wouldn't know the margins clearly. And those are poor prognostic factors for a recurrence. So attempting an endoscopic resection for a larger tumor, I think at this point we should not really attempt that.
Okay. So what are the high risk features from oncology point of view where you want to give imatinib?
So there are some scales and scores. Usually we follow the NIH score. It looks at the size, looks at the location, looks at the mitotic features, then intra-op spillage. These are the 4 main things we look at.
So if you do endoscopy and break the capsule, it is a intra-op spillage once you are doing a full thickness resection?
Yes, I guess it would be something like that.
So that's very important for us also. While we are doing full thickness resections, we must preserve the capsule, otherwise you convert a low risk lesion to a very high risk region. So we have to be very, very careful about the size criteria, the endosono criteria of high risk features like necrosis, irregular margin, intratumoral hemorrhage, etc. So I think I'll stop here. I think we discussed 4 cases very commonly seen in our practice and how we can discuss among the team and come to a conclusion and give the best to our patient. I think I'll stop here, and I thank all the panelists for their time. Thank you so much. We'll go to the live now, and we have 3 to 4 cases, and then we'll stop.
Thank you, Dr. Mohan, for that excellent presentation. And we had a nice MDT here. Now we move on to live cases. We have interesting cases lined up for today evening. So we start with the very first case. History, please.
First case is a 56 years male with iron deficiency anemia for last 1 year.
I would like to invite on the stage Dr. Biswa, Dr. Nagarjuna, Dr. Ramesh Kumar and Dr. Praveen Rai to moderate this session.
First case is 56 year male with iron deficiency anemia for last 1 year, now presenting with shortness of breath and abdominal discomfort for last 1 month. Upon evaluation, found to have large gastric polyps with increased vascularity, probably hyperplastic, and we planned EMR for this patient. Over to Dr. Pankaj and Dr. Vikas. Over to you, sir.
Yeah. Hi, good evening. Can you hear me? Hello?
Yes, we can.
Yes, sir, we can.
Yeah, hi, Vishwa. Once again, thanks to Mohan, Zahir, Sandeep, entire AIG team. And this case, I am with my close friend Amol, who is going to help me. Srini is there, and Dr. Teja is giving the anesthesia part. Patient is sedated in a left lateral position, and this is what we are looking at. Amol, can you start describing what we are seeing?
Yeah, so do you have the endoscopy image there? I think you have. So you can see there is a large polyp, or I think there is a conglomerate of multiple polyps. So here we can see that there are 2 polyp. We can see 2 stalks over there. So there is a slightly smaller polyp on top, and then another even bigger polyp, and plus we have multiple smaller polyps. There is one over here, and then this also looks a little bit nodular. What do you think, Pankaj? Now,
yeah, I think this polyp is probably, but there is inflammation, but it is more on a nodule.
So some of these hyperplastic polyps, they can undergo some neuroendocrine differentiation. So the proximal one which we just saw, there could be some neuroendocrine differentiation, we still don't know.
That's right.
But what is important to know in hyperplastic polyps, if you can see the mucosa over here, there is some atrophic gastritis. There is quite a bit of atrophic gastritis. Pankaj is showing us the antral region.
Yeah, this is quite a bit.
We can see quite a bit of atrophic gastritis. So,
but the pit pattern and everything is normal.
Pankaj, what do you think could be the cause of these polyps in this patient?
I think the most probable cause would be H. pylori related.
Okay, H. pylori related atrophic gastritis. And
that's right. Secondary polyps. Other is probably, we have seen the duodenum quite D3 and DJ while we are waiting, but we have seen no other polyps. So probably not a part of any other polypoid syndrome.
The other important thing that we check for in this patient is this patient a cirrhotic? Because in patients with chronic liver disease, hyperplastic polyps do occur of this nature. And okay, so Pankaj, would you remove all hyperplastic polyps in the stomach?
No, usually not.
So what would be the...
This is probably this patient has bled. And these are all ulcerated, recurrent anemia and bleeding, and plus we have a lot of ulcerations here.
Right.
And these are bleeding. So
recurrent anemia is an important indication, or an active bleed is an important indication for removal of these polyps. Apart from that, size of the gastric polyps, hyperplastic polyps, more than 10 millimeters usually would be an indication for resection.
Right.
Because some of these hyperplastic polyps can undergo dysplastic or malignant change. But there is some controversy in that point, I would say. I would be a little bit reluctant to remove all polyps.
Absolutely, I agree.
Particularly in those with liver disease and things like that.
Right. So yeah, because of the paucity of time, what we have planned is that we will remove this top polyp first, and probably that we will do by injecting and then lifting up and removing, and then probably applying a clip there. That also if it bleeds, because the patient has bled and probably there may be a big vessel. This large polyp here, as you can see, it appears to be stalk, but the stalk is quite thick. You can see. So what we are planning is we will try to see if we can apply endo loop here.
Pankaj,
yeah,
Yogesh here.
Yes, Yogesh.
Is the colonoscopy done for this patient? And
I think it is done and they don't see anything there. That is what I presume.
Yogesh, these are hyperplastic polyps. So I don't, meaning unless this patient has some other indication for a colonoscopy, I wouldn't do a screening colonoscopy for polyps in this patient just because he's got polyps in the stomach and these kind of polyps. I think it's irrelevant.
Yeah.
Because
Now-
he's got significant atrophic gastritis. So I think that is cause enough for these polyps over here.
And one more thing which I usually, even if you have this hyperplastic polyp, you don't require to do an ESD. And if someone attempts, I think it is going to be a disaster because there will be a lot of fibrosis and a lot of bleeding.
Yeah, see, sometimes if the stalk is very thick, like in the lower,
Yes.
not even the lower one, but sometimes you even have even a wider stalk. In that situation, sometimes a preemptive ESD is useful because you can prophylactically coagulate the vessel.
That's right. That's
So
right.
it's
But
for that
it is
purpose,
not easy.
for the
Yeah.
margin or something of that sort, but mainly
right.
for the hemostasis. So that
So
is-
I think what we have done is we have injected just normal saline with some methylene blue. I have not put any adrenaline in it, which is not my preference. And I'm just trying to separate these two polyps and see, just get below this and garlanding this snare across the polyp. We have taken a 15 mm snare. We can do a 20 mm, but we'll see.
Sometimes taking a very big snare, both the polyps can come together and then that
And
can...
as you can see, what I am doing is I am trying to maneuver with my scope rather than the polyp, because now can I have a little, can you close a little, thoda sa close karo. Because what happens is when these large polyps are there, you can have the polyp open. We have to see that we are not catching the polyp and only the stalk. So probably just go beyond it like this and see.
Another option is probably do a retroflexion and try and catch it.
We'll see. I am doing the same thing. Yeah.
Can sometimes help.
Let's see.
Yeah, but I think you've got a
Close slowly.
better position.
Yeah, I think now this is okay.
The other thing is, hyperplastic polyps, you should preferably not use clips over there to close unless there is some, really bad bleeding which you cannot coagulate or this thing, because if you have a, this thing, then there is a higher chance of recurrence of these
Yeah.
polyps.
So one of the polyps.
One of the polyps is out. Okay.
You see, this is a
The tiny
stalk
one.
which what is left behind. We'll see. It must have fallen in the fundus.
Yeah, it's gone in the fundus.
Yeah,
Yeah,
here
there
it
is
is. That's the polyp here.
But there's no bleeding, nothing to worry.
Yeah, not right now. But this, I think, is quite big. And would you remove this also? No.
Yeah, I think you can.
Okay,
You should
open.
probably,
We will.
because more
Open.
importantly, I think, Pankaj, we need to see the base and make sure that
Perfect.
there's
Close
no
slowly.
vessel, open vessel.
Close slowly. Close. Yeah. Okay. So we have removed the polyp completely. I'll just push this down with the snare. And now we are seeing the base. We'll see if there is any bleeding. Not much. What we can just do is probably touch this with a snare and then it should be fine. Can we put some, go it to the soft coag? Yeah, just, going to the soft coag, just cleaning. Thoda sa close karo snare. Okay, that's fine. Okay, I think that's fine. There is no bleeding here. So we'll observe while we remove the second polyp. If there is any bleeding, we can always apply a mechanical hemostasis, right? Yeah. And now, loop. Right? So now we go to the second polyp. There is a little bit of oozing and we'll see. I will just remove this big one first here. What do you think? We should try a loop. That is what my gut feeling says, because it is a thick stock.
I somehow
You
don't
can-
prefer loops.
Yeah, I know.
So I would rather go ahead with the snare, inject, go ahead with the snare and keep a coag rasper ready. In case there are some open vessels, we'll coagulate them. That's
So,
my
Dr.
preference to
Amol.
doing it.
Dr. Amol.
Yeah.
So when will you choose a loop?
What?
When will you choose a loop?
like you mentioned that.
See, yeah. My take is whenever the stalk is thicker, this is almost around 15 to 20 mm. Anything more than 10 mm, 12 mm, I would prefer to try to loop it. It makes me a little more secure. Gastric, I am not much worried about the bleeding because we can always tackle the bleeding. But why not be safe rather than trying to make a mess out of small thing? And the problem with these loops are it is difficult to garland them also.
Yeah,
because they are so floppy. So we'll just try for couple of minutes. Open, please.
So, Dr. Amol, you mentioned you won't use a loop.
No, I somehow don't like
why
to
is that?
apply loops for polyps because I think they are more of a nuisance than a help. It is a difficult task to garland the loops around the polyp, and they sometimes slip off, they get entangled, and despite that, when you actually put the snare, sometimes the Pankaj.
Oh, there is another one more polyp. Yeah.
So you'll have to go between those two. And they are very floppy, it gets very difficult and it just gets messy. So and the other thing, as I said, Praveer, is mechanical hemostasis in hyperplastic polyps with a clip or something is avoidable because that has shown to increase the risk of recurrence of these polyps. So you want to do a thermal hemostasis as far as possible. And you can use aqueous rasper now. We also have means measures like a hemospray and things like that, which we can use if the need be. But try and avoid putting clips or anything on the mucosa because remember that it is a mucosa that is diseased which is causing these polyps. And if we further traumatize the mucosa, there is further hyperplasia and that induces
Can you just sheath
further polyp formation. So that is the basic mechanism of these polyps formation. So that is why I prefer not to use mechanical methods.
No, it's okay. I'm just trying. Open.
Amol sir.
Yeah.
Biswaya. Sir,
Yeah, Biswa.
when do you prefer in such polyps using clutch cutter and directly achieving hemostasis and cutting through the base? Is that a...
This could be a good case for a clutch cutter.
Yeah, you can use a clutch cutter also.
This could be a good case for a clutch cutter. I fully agree with that, Biswa. Because then you have a control also that you are going to be coagulating. Yeah, correct.
Yeah, sheath close karo.
Yeah, I think with this thick stalk, we are quite comfortable placing a loop first. It gives at least that risk of bleed reduces. This is what the real life experience also. This is what the assumption is. So
that happens, Praveer. So, once the loop is fired, the problem is where do you put the snare? Because
I know.
Very often you will cut
through we have to. It is cut, na?
With the snare. See, it's cut through.
No, give me the injection. We'll just inject and cut.
So
what has happened is the loop has
loop cut through the polyp.
Cut through the polyp.
And that is.
We'll see. And then it's little bit of bleeding. We'll just inject and because there is what we were thinking as one polyp, it has turned out to be that there is a smaller polyp on top here, which the stalk was not visible. So it's okay, no worries. Okay, needle out please. Inject.
So how many among the audience, just raise of hands, would like to use a loop over here?
Inject.
Okay. And no loop, how many? Oh. So majority don't want to use a loop, Pankaj?
Praveer, you should have asked that question before the loop cut through the polyp. You may have had a different...
No, it is okay. It is always
It's
a biased opinion. Yeah, it is always a matter of...
Sorry about that.
Yeah, inject. Okay. Yeah, you can go back and come.
Yeah, you can go back.
We'll just do it because this will take some time. Yeah.
Yes, this is Dr. Madhura here. I just wanted to know if anybody likes to use large clips at the base, couple of clips from both directions. Does that work or that it's of no use?
Again, it's preferable not to use clips in these kind of polyps because you're only going to, when you follow up these patients, they're going to come back with a vengeance. These polyps are going to come back with a vengeance. And you'll get even a bigger polyp next time you scope this patient. That's the biggest problem.
Okay.
Thank you, Dr. Pankaj and Dr. Amol.
Yeah,
we shift to, we'll come back, sir. Can we come back, sir?
Yeah.
We'll
We are
come back
just cutting this now.
Okay,
We have
then
got it.
We'll stay back for a moment. We just want to see what you are doing.
Yeah, it is done.
It's done.
We have
Finished.
removed, and there is no bleeding.
There's no bleeding now.
Okay.
Bleeding has also stopped. Wonderful. Well, great.
Do you want to put a clip, sir?
We will.
Okay.
Because it has bled, we will just apply a clip here.
So we'll move to,
Don't put a clip.
next
Don't
room
put a clip.
where Professor Noya is ready with another interesting case. History, Ushoda.
Our second case is 46 years female with epigastric pain and weight loss in last 6 months with past history with recently eradicated H. pylori, and she was on PPI for the last 3 years. Upon evaluation, we found a severe gastric atrophy with intestinal metaplasia, features suspicious of early gastric cancer. And now plan is a diagnostic upper GI endoscopy. Over to Professor Noria, Professor Sridhar. Over to you, sir. Your lives.
Hello. So now I'm starting the observation of the stomach. So gastric, greater curvature side, gastric pole is remaining, and then anterior wall, and then lesser curve, and posterior wall. And again, as I already mentioned that usually H. pylori associated gastritis develop lesser curvature predominant distribution. So greater curvature pole is remaining, but lesser curvature side gastric pole is lost. And then again, like a mosaic pattern of the color, or it will be irregular mucosa. So I think this patient has an open type atrophy, like this C2 or something. But anyway, we start SSS protocol, middle body, anterior wall, lesser curve, posterior wall, and try to find some localized irregular change of mucosal surface or color. And then proceed as lesion scope to antrum, and then greater curve, anterior wall, lesser curve, posterior wall. So now you find some little bit depressed area and also demarcated change of color. Can you really understand? So this is mucosal height, and then when we proceed to pyloric area, there is some depression.
Yeah, we can see the depressions.
Yeah, like this. And then when we see the mucosal color, I think there is some demarcation like this. But anyway, we continue SSS protocol observation. Incisura, lesser curve, and then because sometimes gastric cancer, 10% or 15% of the early gastric cancer patient have multiple lesions. So it's better to not satisfy to find one lesion, but also you have to look for another lesion, synchronous lesion. So Kimura Takemoto classification lost fold and then pale color extend to cardia, and then almost reach to cardia, and then beyond cardia, and then atrophy border exists in a posterior wall and the anterior wall side. So I think this is open type atrophy. So high risk for gastric cancer patient. And then switch to NBI. Maybe you can see, compared to very round regular pit pattern, you can see intestinal metaplasia, very beautiful structure, and then light blue crest sign exists here. Can you see?
Yeah, very beautifully we can see the light blue crest.
So this patient has a corpus atrophy, extensive atrophy, and then corpus intestinal metaplasia. And then next, previously we check this region. So initially we try to find demarcation line. So again, it is very important to start evaluation from the surrounding mucosa So this is non-neoplastic mucosal pattern. I think this is intestinal metaplasia. You can see biliform structure and light blue crest sign. And then when we go close to the lesion, I think this is demarcation. Now you can see irregular vessel here. So here as well, like this. So, and then here is more clearer. Like this. A little bit extending to proximal part, but this is demarcation here. So from here and then extend to the anterior wall side, this is demarcation. Here is also demarcation, like this. And then extending. So this is the anal edge.
Professor Ido,
Yes.
have you put a cap on it?
Yes, of course, of course.
Is
To
it a
perform
black-
magnification observation, cap is mandatory.
Is it a black cap?
Yes,
Yeah,
it is
black
a
cap, yes. So this is anal side. And then, so basically pyloric channel is well preserved. And then little bit proximal to pyloric channel, there is a demarcation line, like this. You can see. And then extend to posterior wall side, to like this. And then this is a edge, lateral boundary of the tumor. Now you can
Professor-
see very clear demarcation line.
Yedo,
Yes?
Ashutosh here.
Yes.
I think it's T1B. Do you agree?
Okay, so basically NBI cannot really predict the depth of invasion.
No, from white light image, it is very much depressed, and
Yeah.
there is some ulcerations are there.
And I don't think it's really ulceration.
And size is also very large size.
Maybe 3 centimeter or something. But I think this is some mucus, very adhered mucus, I guess.
And in the middle there is a like nodular.
Yeah, but the nodule is not always the sign of deep invasion. So to evaluate the depth of invasion, we have to evaluate a non-extension sign. And then antrum sometimes it's difficult to extend, but how amount of air should be evaluated in the corpus to extend the gastric wall fully in order to almost greater curvature fold it disappeared like this. So now insufflating. Now gastric fold is almost separated. Now we are really free, nearly free, insufflated. So compared to previous image, the region is little bit flattened. Yeah. So if it is really invasive submucosal, like this, so surrounding depression becomes shallower. Maybe here a little bit elevated, but according to this finding, like change the morphology according to the amount of air. So I think still possibility of intramucosal cancer.
Is
Now,
there any dilated vessel on NBI?
Basically, the NBI is not useful for prediction of depth of invasion. Colon, esophagus, it's useful. But for stomach, early gastric cancer, NBI image does not useful for prediction of depth of invasion.
What about differentiation?
Differentiation, yes. So maybe we see previously with Ashutosh, that time we didn't see this type of. Now we can see epithelial pattern like this. So if we can see this epithelium, it means a differentiated type. because always differentiate type create the glands, so if we can see epithelial structure. But the previous case, such structure is disappeared, absent, and then we can see only irregular coil-shaped vessel.
Yeah.
I think this, and also you can, if you see, not little bit difficult, but
so
like this. Now you can see the network pattern
Yes.
of the vessel. So I think this is a differentiated type.
So undifferentiated, you see corkscrew type
Yeah,
pattern?
yes. And like this.
We see a good network of vessels. And
Yeah, in the center. So, as Astor said that it can be ulceration, but the ulcer means the defect of epithelium. So still we can see through the mucus, we can see the structure pattern. So I think this is just the adhered mucus.
And you wash it very gently.
Yeah, yes.
To avoid any trauma to the mucosa.
Yeah. But anyway, so here is also almost flattened. So only concern is this little bit elevation. But in general, I think it was trying endoscopic resection.
So we plan to go over the ESD for this, in your opinion?
Yes. I think indication of ESD.
So, Noria,
Yes.
if ESD were to be performed, can you tell us your plan of ESD? How would you?
So probably the most difficult part is the pyloric channel, near the pyloric channel. So it's really attempt to start from this part, proximal part. But if you start from here, so every region shift to the pyloric channel side. So management of this part is very difficult.
Raj
For
and
me.
Noria, I think we'll move ahead and we'll do the ESD
yes,
tomorrow.
Okay.
So we'll
Maybe
go to
other time we will
another
explain.
case.
Yeah. I think it's better to inject here to expand the mucosa and then cut.
Our next case is 45 years male with intermittent melena and iron deficiency anemia since last 2 months without any weight loss. His CT abdominal angiogram showed enhancing lesion in D3, CA levels were normal. Upon evaluation, endoscopy showed large periampullary polypoid lesion with a hypoenhancing duodenal lesion in the EUS. So we planned for a diagnostic EUS to look for resectability of the lesion. Over to Dr. Jayanta Samanta, Dr. Sandeep. Over to you, sir. You are live, sir.
Okay. Am I audible? Yeah. Hi, hello everyone. At the outset, I want to thank once again Mohan sir, Jahi sir, Sandeep sir and the whole team for this opportunity. With me is Sandeep sir. Do you have the endoscopy view there? Yeah, can you see it?
Yes.
Hello. So what Jayanta is using is a duodenoscope to evaluate this a large polypoid lesion in the duodenum. And can we go Buscopan? Yeah, go ahead, Jay. Okay. Yeah, you can see it's a very large polypoidal lesion extending till probably into D3.
Yeah.
And as we come back gradually, we can see there's a very thick stalk over here, right? Can you appreciate the stalk? This on top? Yeah. Can you see this stalk? Yeah. So what we're going to do is we're going to try to probe this stalk and try to find out whether it's actually encasing or involving the papilla or it is away from it. So we'll use a sphincter. So far we could not find the papilla. So we thought when we come live we will start probing it with a sphinctotome or any instrument. It looks like a cauliflower and with thick pedicle. So you think there is a papilla behind? Not sure. Let's see. Okay. And then the plan is to do an EUS to see how deep it is going. Yeah. And where is the landmarks in case we don't find the papilla? Will EUS help us in locating that? Whether this stalk... Try to rotate and lift it. It's very heavy actually, sir. And you can do the heavy lifting. So we'll try to kind of rotate it and remove it and kind of push it away and see if we can see the... just probing the stalk and see if we can find the papilla.
Sandeep, what are the LFTs like?
Sorry, what are the LFTs? So liver functions are normal. Yes. Liver functions are normal. Liver functions are normal. There is slight history of melena. Yes. And that's how anemia and reevaluation is primarily the case with melena. Yes. And so you think you're going to be able to see anything is this? It has its own limitation. If the papilla is behind or deeper to it, then probably will not be able to see. So that's why EOS also has a role here, and this will help us in deciding where the. So from both sides, Jayanta is very nicely trying to feel and separate out the mucosa from the large pedicle. Yeah, nothing is seen. Okay. Very nice. So this all, the left side doesn't show the papilla. No. Yeah. Okay.
To collection.
Pardon? So what do you think? What are the opinion from the house? The experts on the panel, what is their feeling? Can you hear us?
Yes.
Yeah, we can hear you.
They are thinking. Yeah, Dr. Nagarjan.
Yeah.
Oh, what's your opinion? Should we cut and then see the papilla, or should we try to locate the papilla first up front and then do the resection part?
Sir,
because this definitely requires removal.
Sir, please apply NBI there.
Okay, NBI.
Yes. You can find papilla.
That's a good idea. Yeah.
Okay.
If you find white opaque substance like substance.
White opaque. Okay.
Yes.
There's everything.
Papilla. Yes.
There's some white area here and there on the right side of the, but
we'll try to. It's very heavy. It doesn't get easily kind of mobilized around with the tome or whatever that device that we are trying to utilize.
But you still can't see the papilla.
No, I don't think I can see the
Let's
papilla.
switch back to white light.
Yeah.
Or should we switch to endoscopy and see? Sorry, EUS and see?
Yeah, I think we can switch to US image and then try to find out.
So I think since the bilirubin is normal, LFT is normal.
Yes.
It's unlikely that it's blocking the papilla completely for sure.
Right, sir.
Yeah.
Right, sir.
So I think we can cut it and then we can look for the papilla.
That also is. So then we have to be, so today the aim is to do the diagnostic part of it.
Yes.
The therapeutic part, we will take it tomorrow.
So I think
and then we will use fluoroscopy also, because just in case it's at the papilla, then we have to do a pancreatic duct stenting. So then fluoroscopy is must.
So let's take out the scope and switch the scope and go to an US scope first.
Jayant, can
Yes,
you
sir.
just project on the base of the pedicle? There are two lips on that pedicle, and I guess there is a small opening there at the base of it. Yeah, in between those.
Somewhere here, okay.
Yeah.
Where the thick pedicle and the caulifla starts.
So can you just separate that?
Okay, just one more try, okay.
Try to do that as well.
Actually, before we came on the screen, we kept looking around.
Yeah.
And but we didn't want to traumatize the papilla as this lesion. Otherwise, the landmarks disappear, and then the audience may not like it.
Somewhere there. Yeah, somewhere there.
Yeah.
No?
Possible. But I can't say.
No. I cannot say it with definitive on also.
On the lower down, I think he's trying to say if you drag it down, if you drag this down, maybe if the papilla is there, can it come? It's very difficult to say. I think let's move to US, and in order to save time, we'll get the answer tomorrow definitely. If not, if US does not give a clue.
Yeah, I think he was talking about this one probably, but it's not illegal. We'll switch the scope, sir. Yeah.
Maybe gradually pull back the scope. Pankaj also is here, so we have a third eye.
Yes, sir. Pull the scope back.
And then see if he.
Okay.
और ऊपर. Okay. इस fold के नीचे.
Okay, we'll try to
one more symptom transfer. Okay. So Pankaj, you can be inside. I think more the merrier.
Pankaj sir, we tried to do that as well. But I don't think. I get it. I get your point.
So far, we looked at the left, the right, and the suggestion from the audience, also from the hall, that look at the marginal zone. And Pankaj is saying it's far away from it. Maybe let's look here. I think not this fold. Maybe upper.
About this fold, I believe.
On the right side.
Sir, can I change the position of the patient and see?
This papilla, this tiny one, the tiny one, the blackish thing.
This one.
So just at the tip.
This one,
maybe not very convincing. Okay, let's see. But anyway, we'll cut tomorrow and then see.
So we'll switch the scope now, sir.
Yeah, please.
And we'll go to a.
So if you want to go to other room and come back, we'll wait. We'll put the linear
Our next case is 71 years male, treated like functional dyspepsia since last 1 year. He didn't have any weight loss, and labs were also normal. UGI showed a small ulcerated area in the mid body of the stomach. Now we will plan for a standardized diagnostic upper GI endoscopy for further characterization of the lesion. Over to Professor Noria, Professor Sandeep. Over to Professor Noria and Dr. Noria.
In a moment we'll be ready. We are arranging the case. Allow us 1 more minute.
Any questions from the audience? Quick comment from our moderators.
Zoom endoscopy. Well, a B5, A7. What's your preference and why so?
For conventional,
I mean, there are a lot of big people who are going to do it in the audience. So, how you wish?
So, a conventional white light we use usually B4 between B4 and B6, and then for NBI I prefer to use B8, 7, 8 or something, and then the difference. Difference is, for example, this is very normal corpus.
This is B7.
mucosa. This is B7.
And if we change, does it should?
And then, so this is
A5.
A5.
Yeah.
So the edge is so basically A mode really enlarge or thicken the object, like so this cell becomes little bit thick.
Okay.
But the B mode is sharpening the edge.
Sharpening the border.
Sharpening the border. Yes. So the image looks little bit clearer. So this is A mode, and then this is
B5.
And then this is
B7.
B7. So I think this image looks, microvessel sharper.
Yeah.
This is
A5, B5, and B7.
Yeah. That is the difference. So maybe you can ask Olympus people to how to modify the settings, enhancement mode. But anyway, so now I came to stomach, and then again initially we clean the gastric mucosa. So cleansing, mucosal cleansing is basically the always initial step for the mucosal evaluation. So now I'm cleaning and then suck all the fluid. And after that, we start evaluation. And try not to strongly suck the mucosa, so almost like a sipping the fluid. And try not avoid like a very strong mucosal suction.
So the mucosal suction has to be softer. Even the water jet we use for cleaning should be soft.
Yes.
Do you see a lesion when you were there?
Forward? Little bit, but basically I start systematic observation. now some redness. So I suspect this can be associated with positive H. pylori infection. And here also you can see some slight depression. Yeah.
Erosion?
Not erosion. I think on the base still there's a epithelium. So we don't say it's erosion. I think some depression. And I think this is also some suspicious finding for multiple lymphoma or something. Anyway, not cancer because there is no irregular vessels. And then we proceed to middle part of stomach, 4 quadrant direction. And then gastric fold is a little bit lost, but you can see regular arrangement of collecting venue. So this is called collecting venue, like a spider-like shape, like vessel. So it is regularly arranged. So I think, as I mentioned, it can be positive H. pylori infection, but according to this endoscopic finding, patient may be H. pylori naive patient. And then when we switch to NBI, we can see clearly the very regular round pit crypt openings. And even such finding is even seen in the lower corpus of the lesser curvature, which usually H. pylori associated gastritis start from here. But this mucosa is really regular. And then, so this is here as well. So some depression is seen. And then when we,
Nitin, has simethicone and N-acetylcysteine used in this patient for preparation?
Yeah, it was given previously. Now we have washed it with the same.
Yeah. So, Dr. Ito, is there any concern of any biofilm formation with simethicone in the channel when we are using it through the channel?
Biofilm
inside the
which
scope
is
channel.
very
difficult to disinfect.
But usually it is problematic when it is used in a water jet channel or small nozzle. And if you just use simethicone with a syringe flushing, does not cause problem. Yes. So sorry. So this is actually the reason, I think. So now you can see the pale demarcated area, but maybe we have seen the previously the early gastric cancer case, suspicion for undifferentiated type. But compared to that region, demarcation is not so much clear, I guess. Like this. So even last case, if we get closer to the boundary of the region, we saw clear demarcation. But in this case,
So demarcation will be
demarcation, even white light, we cannot really see the clear demarcation. And then we switch to NBI. So again, start from surrounding mucosa. Surrounding mucosa is regularly arranged, very normal corpus pattern. And then we proceed to region boundary. But the mucosal pattern is almost quite similar. I think this is mucus. Yeah. Like this. Maybe here is demarcation. But compared to previous gastric cancer case, demarcation is not so much clear. Yeah. Like this. And then I think this is
definitely, but the surface pattern is.
So this is also the region, but I think this is called tree-like appearance.
Yes,
It is typical for multiple lymphoma. So demarcation is not so much clear, and then
It's a very nice tree-like appearance.
tree-like, tree-like means you can see. Previously we saw a collecting venue, spider-like collecting venue, and then we can see very similar, very thick vessel in the inside of the lesion. So I think this is typical finding of multiple lymphoma. Vessel irregularity. Vessel irregularity is not as irregular as cancerous case. So
with H. pylori being less suspected in this patient.
Yeah, then so maybe, but I think we have to check. Okay. Post eradication. Okay.
Professor Noria.
Yes.
Once we have treated
so what is the most common differential diagnosis in this case? You are telling it is maltoma. Can it be undifferentiated cancer?
Adigastric cancer.
Yes.
But the demarcation line is not so clear. Not clear.
No, I'm telling about undifferentiated.
Yeah. And then surface structure is preserved.
Because RAC are present.
Yes.
Your depressed area and demarcation line absent. Why it is not a case? What are the points against undifferentiated cancer? Because RAC present in the distal stomach, pale area and irregular vessels. So I think first diagnosis should be undifferentiated cancer, then should be maltoma? No.
First the differential diagnosis multiple lymphoma because demarcation line is not clear. And then vessel is not like a corkscrew pattern. We see the tree-like vessel like this, like a bluish tree-like vessel, and then unclear demarcation. So I think
the expansion and we have to move on to the next case.
Okay.
So it's very nicely demonstrated tree-like appearance and the lack of demarcation line, which sometimes you may not be able to properly see, but it is there, but it's not clearly we can differentiate in that.
And then also we saw some small depression. I think like
we move on to the professor to the next case.
Okay.
Yeah.
Okay. So I think this is also the multiple lymphoma. So usually multiple lymphoma involve all gastric mucosa. So sometimes some old case report perform ESD for this type of lesion, but usually all multiple lymphoma cell exist in a whole gastric mucosa. So basically the indication is radiation therapy for such lesion. Okay, thank you.
Thank you, Dr. Maria. We move to Dr. Jayanta and Dr. Sandeep, where they are ready with the US scope. We want to see the findings.
Yeah.
Yes, Dr. Jayanta, you are on.
Okay, thank you. Are we audible? So, can you see the US image?
Loud and clear.
Can I have some? So, we're using the Aplio i800, which has Olympus with Canon processor. Yeah. So, this gives a very sharp images, and as you can see the screen, Jayanta is filling water, and this is a large tumor in the duodenum, second part which we saw by the side wing endoscopy. These are big vessels inside. I'll just put Doppler on top of it, which are going through the thick pedicle into the, so the aim is to look at the duct anatomy and the papilla. I'll make the image little bigger for you. We have already given Buscopan. Yeah, so he's filled it water. This is the, so sir is going to help me out. I'll help them. That's the duct. That is the bile duct that we see over here. The arrow. Appreciate the bile duct. Can you see the arrow in the hall? That's the bile duct. Yeah. So that is a bile duct that we see over here. This one. Yeah. And as we kind of rotate the scope, this is the pancreatic duct that starts appearing. That's a pancreatic duct. It comes here. That's a pancreatic duct which is dipping down. That's a pancreatic duct. And as we go further down, you can actually kind of see
It's the same case which you demonstrated.
Sorry?
Is the same case, no? The one
same case. Yes. So big large polyp, polypoidal mass, the ducts which join together, the PD and the CBD. But we're not able to take it to the papilla. Papilla is still hidden within this large polypoidal lesion.
Okay.
Whether it's merging with it or maybe inferior to it, and that's why we could not see by the endoscopy view because it's so big. and bulky, that it may be coming below here.
Yeah.
But we're not able to connect these two tubes to the papilla. We are reaching this lesion itself, the wall itself, which has thick pedicle and has very high vascularity.
Yeah, and this is
let me put some Doppler on top. Okay.
So, what's the caliber of the bile duct? Here it's
the bile duct is okay. Bile duct is about 4-5. This is bile duct. This is pancreatic duct.
Pancreatic
This is
duct.
pancreatic duct.
And
The bile duct is about
show you the
4-5.
bile duct just now. So the bile duct is not
Not
that
dilated. Not dilated.
So this one is the bile duct.
This is a bile duct.
This is the bile duct, and this is definitely not dilated. And as we are trying to trace it down to the papilla,
the papilla is somewhere here.
Yes.
It's almost merging with the pedicle.
Yeah,
This is
can
the
you see
pedicle
now?
of the.
Yeah.
So these are the ducts which are merging here.
Yes,
And
yes.
then we also see some vessels as well in the
Yes,
pedicle.
Yes, yes.
In this case, can water help us or balloon?
No, he's already got a balloon and we have filled enough water in the duodenum. That's a very valid point. And filling the water, as you see, this is the duodenum which is filled with water, and giving antiperistaltic agents keeps the water there.
Right.
And in case we are also doing an polypectomy or ampulectomy, then the polyp also remains there, doesn't run away distally. So
I think we've seen enough.
I think the next answer will come only after cutting that lesion.
Yeah, exactly. Because this.
I think this
pedicle can
is
be
a very thick pedicle. You see, this is a
very thick.
pedicle here,
Yeah,
and then
yeah.
that's a duct which is coming.
Yes,
here.
yes.
So either it's opening inferior to the lesion,
Right, sir.
which will not be visible endoscopically,
Exactly.
or it's merging with this pedicle only.
This
So we
pedicle.
will know it after we cut it.
Right, sir. Right,
I think that's the maximum we can do. And this
And
is,
it
you
is-
see the vascularity? It is a very vascular lesion, so likelihood of bleed is more. One has to be very, very well prepared with this.
So we were discussing, sir. We'll ask Mohan sir whether he wants you to.
So this is something, a feature called as SMI, is smart microvascular imaging, which picks up even very tiny vessels. So this was the big vessel which I picked up. So this is more superior to the conventional Doppler. Yes.
So my question, sir, is to you and Mohan sir is that will this embolization of this vessel help for the dissection?
That's a very important point, yes. So if the tumors are large and especially neuroendocrine tumors which have a very high risk of bleeding, this also we can consider anti-embolization
before
doing a polypectomy bar ampulectomy.
Right,
of
sir.
the
Right, sir. Right, sir. Any more questions?
I think you have shown it very nicely. This is a very stable position, and that shows expertise of Jayanta in demonstrating the lesion. This is a maximum. I think we can go to the extent of finding where the ducts and the papilla is.
Right, sir.
I think further thing will only happen after this.
After the ampulectomy.
Sandeep,
Yes, please.
Is there any single big feeder in the pedicle?
Yes, there is. There is. So you see, if we can trace this backwards,
you connect. So if you connect, you can see this one.
But I don't think we should try to do endoscopic or EUS guided blockage of these. This is a different ball game. I think use conventional angioembolization.
Yes. It's a pretty large vessel.
It's at least 5 millimeter in diameter, which means it's a big vessel.
Yeah.
So you're planning for a snare polypectomy.
But be ready for a fountain of blood.
Not today, but
No, not today. But so I think this is a very nice blood vessel that
Yes.
Yeah.
Since this is a very vascular tumor, will you think about NET and do a...
No, it's not the vascular tumor of NET has a different appearance. You see, endoscopically, it's more like a...
It's an adenomatous kind of
adenoma type.
Yeah.
It has a thick pedicle, and most polyps with thick pedicle will also have a blood vessel feeding it. So, a neuroendocrine tumor, whole tumor would have been very vascular, apart from the pedicle which has a blood vessels.
Right, sir.
So that's a difference.
Will you consider doing a biopsy first?
Biopsy,
we'll continue with...
biopsy has already been done.
Biopsy is done, it shows adenoma.
Shows adenoma. Yeah.
Okay. I think we'll stop here.
Right.
Sorry, please.
if you want to put a loop first and then snare polypectomy.
But if you put a loop and if it's merging with the papilla, then we'll cause pancreatitis and obstructive jaundice, which is more dangerous. So I think best is to cut, control the bleed, and then cannulate and see the papilla. If it's also got cut, then I think putting a pancreatic stent is worthwhile.
Yeah.
If not, then I think we can leave the stenting of the papilla for not required in this patient.
Right.
Just controlling the bleed would be good enough.
Yes, sir.
I think, does it sound okay? The plan of action?
Yeah.
Hopefully we'll show you tomorrow.
Thank you, Dr. Jayanta,
Okay.
sir,
Thank
for
you, thank
excellent
you.
demonstration. We sign off for today and we meet again with excellent demonstrations tomorrow as well. Looking forward to see you all again. Thank you so much.
Thank you so much for the wonderful demonstration. And tomorrow we are having at 8:20 a.m. abstract presentation followed by lectures at 9 a.m. I hope to see you all tomorrow for a wonderful session tomorrow. Thank you.
No more.